So good morning everybody from Physio TV. I am handing over to Dr. Trupti. We are live now.
Thank you, sir. Good morning, everyone. From the organizing team of NOVS 2020, we shall be starting with the first session of today. I hand it over to Dr. Jeeva Ridarajulu.
Yeah, thank you very much. The Physio TV and the Dr. Trupti, the technical support of NOVS 2020. Again, very good morning to one and all. It's my great pleasure and privilege to start the second day of the virtual international physiotherapy conference. To begin with, we have a resource person today who is an eminent neurologist and who is a dynamic leader in the medical profession, who is heading the Wanless Hospital for more than 10 years. And we have a resource person named Dr. Nathaniel Sase sir. Sir does not require any special introduction as such. In Maharashtra, if you say Dr. Sase from Wanless Hospital, everybody knows. All the community people, they knows by name. That is the hallmark that sir is having from the day one of his inception in his career. So just to introduce to the people who don't know the out of Maharashtra, I would like to say sir is graduated from Shivaji University in 1984 and done his internal medicine under Shivaji University in 1988. And sir is a DM Neurology from Christian Medical College, Vellore, which is a pioneer institution in India for taking care of the healthcare profession under Dr. Tamil Nadu Medical University. So sir is the true academician who has ascended from lecturer to the professor grade at various levels of his job that whenever he is undergone. So now sir is presently heading the Wanless Hospital as a medical director, and sir is working in Wanless from 95 to till today. And sir's field of interest is movement disorders, epilepsy, clinical electrophysiology. And sir is having numerous publications in his credit. And we are all fortunate enough to have such kind of a wonderful personality on this platform to listen to his knowledge, which is of more than 5 decades, in fact. So thank you very much, sir, for joining with us. And over to you, sir, Dr. Nathaniel Sase, sir.
Good morning. Good morning to you all, and thank you for this great introduction. And I'm sure that God has given us an opportunity to serve the humanity through this profession, and I'm grateful to him. And I'm grateful to you, Dr. Varadarajulu, for this opportunity so that we can come out of the COVID shadow and speak about the academics once again. To begin with, I would like to introduce my topic today, and I would be restricting myself to the clinical and the management role of a neurologist. And it is important for the physiotherapists who have a great role to perform in rehabilitating the stroke patients in their lives. And it is important to know how do we manage and how do we integrate the physiotherapists in the management of the stroke patients. Stroke is a third leading cause of death after cancer and the heart diseases in the Western world. And the 95% of the strokes occur over the age of 45 years. Recurrent stroke is an important cause of a great disability. And here the role of a physiotherapist is very, very important, and we need to understand that. There have been a lot of advances made in the treatment of the stroke, and tissue plasminogen activator has been a real blessing in the management of the strokes. So may I have the first slide, please? Cerebrovascular diseases include the ischemic strokes, hemorrhagic strokes, and the cerebrovascular anomalies, which may include intracranial aneurysms and the arteriovenous malformations. As you know that the age of longevity of Indian male and female is increasing, the incidence of a stroke is increasing with each year. As the elderly population increases, it is putting a lot of pressure on the finances of the country, and it is going to be one of the great causes of morbidity in the days to come. Next slide, please. Stroke or cerebrovascular accident is defined as abrupt onset of neurologic deficit that is attributable to a focal vascular cause. So we need to establish that it is a vascular in nature and it is of an abrupt onset. Clinical manifestations are dependent on the anatomy of the vasculature of the brain which supplies that particular part of the brain. For example, the middle cerebral artery, which supplies the motor and the sensory part of the brain, then the patients coming with the left MCA territory or the right MCA territory would have a hemiplegia, hemianesthesia, and hemianopia, as against the patients with occipital lobe infarct, which is supplied by the posterior cerebral artery, would have hemianopias and may have a cortical blindness. Next slide, please. Coming to the first part of the stroke, that is the transient ischemic attack. If the cessation of the blood flow lasts for more than few minutes and less than 24 hours, with or without the evidence of minimal death of the brain tissue, it is called as transient ischemic attack. If the blood flow is quickly restored, the brain tissue can recover fully and the patient's symptoms may disappear. And this is clearly a transient ischemic attack. For example, patient may develop a weakness of an upper limb or a lower limb or of the whole side of the body and may recover within few minutes. Why it is important to know about TIA is that it is a harbinger of a incoming stroke. And it is very important to know that and know for sure, because unnecessary use of a tissue plasminogen activator, which is an expensive drug, may be avoided in these patients. Coming to the definition of a TIA, all neurologic signs and symptoms recover within 24 hours, regardless of whether there is an image evidence of new permanent brain injury. Stroke, we call it when the symptoms last beyond 24 hours. There is a new terminology which is sometimes used, and that is called as reversible ischemic neurologic deficit. And it is an in-between part of the stroke where the neurologic symptoms last for more than 24 hours, but recover in less than 4 days. May I have the next slide, please? To know about TIA and acute care pathway, we have this test called as face arm speech test, FAST. 3 simple checks can help you to recognize whether someone has a stroke or a mini stroke. And that is transient ischemic attack. F is for facial weakness. Can the patient smile? Has their mouth or an eyelid has dropped? Arm weakness. Can the person raise both arms? Speech problems. Can the person speak clearly and understand what you say? And T is test for all the 3 signs. And this is very clearly and evidence level of 1B, which is of a very, very high importance. Next slide, please. This is to score the TIA, age more than 60 years, 1 point, blood pressure more than 140/80, 1 point, clinical deficit, 2 points for hemiparesis, 1 point for speech problem without weakness, D, duration, which is 2 points for more than 60 minutes and 1 point for 10 to 60 minutes. And the history of diabetes is 1 point. Maximal score is 7. Next slide, please. This is important when we know it is one of the treatments for the recurrent TIAs and recurrent strokes when it is clearly established. We will not go into the details, but go to the next slide, please. Here we come to the algorithm of stroke. When we have a suspected stroke, we look for the face arm speech test. If it is positive, establish a diagnosis rapidly to the left hand side of the slide. using the validated tool that is Rosier or NIHSS scores. I'm not going to the details because it's going to take time of the NIHSS score. We can look at the uh, uh, textbooks for this. Then coming to the assessment for immediate brain scanning, MRI is to be done, and we look at the picture of the MRI, and if it is not available, a CT scan, and if it is showing less than 1/3 of the vascular territory which is affected, there are certain inclusion and exclusion criteria for using of the tissue plasminogen activator. Look at the thrombolysis on the left arm. If the symptoms are less than 4.5 hours now, according to new guidelines, we can use thrombolysis in the form of a recombinant tissue plasminogen activator, which is a near blessing for the stroke patients. If there is no indication for recombinant tissue plasminogen activator, patient could be admitted to the stroke unit for the specialty care, may need an ICU care. Patient may be admitted, and with the help of the neuro anesthesia and intensive care, we need to manage these patients with general care, neuroprotection, treatment for the complications if at all the tissue plasminogen activator has been used, or if the patient has got a malignant cerebral edema, may have to consult the neurosurgeons for a surgical intervention. Coming down to the pathway of the tissue plasminogen activator, we will coming to the use of tissue plasminogen activator in the later form of later part of our talk. Next slide, please. It is very important to know about what is the pathophysiology of a stroke. We'll be looking at the left arm of the this chart, where there is an arterial occlusion. It leads to ischemia. There's an energy failure of the pump, which allows the calcium and sodium ions to go into the intracellular space. Because of this, there is a proteolysis, and this proteolysis leads to membrane and the cytoskeletal breakdown of the neurons, leads to cell death, and then leads to cerebral edema. And this is the very important, that this is the cascade which actually takes place. And when the cell death occurs, it leads to further ischemia, further energy failure, further influx of the calcium and the sodium ions, and this is how the edema, cerebral edema after stroke, after infarct, keeps on mounting. Next slide, please. After the clinical diagnosis of a stroke, based on the clinical examination, based on the findings on the CT or MRI is established, evaluation and the treatment should follow. The goal of the treatment is to prevent or reverse the brain injury, if at all it is there. Attend to the ABS. These are the 3 ABS: airway, breathing, and circulation. These are the 3 ABCs of management of the stroke. Airway has to be maintained, breathing has to be restored and monitored, and circulation has to be in the correct BP levels. You should not allow it to drop further, or you should not bring it down rapidly. Bringing down rapidly blood pressure rapidly would lead to further ischemia and further damage to the cerebral neurons. If at all there is an hypoglycemia or hyperglycemia, which has to be treated accordingly. Perform CT scan, and during this, when the patient has come to the hospital, when you are clinically confirmed, you must collect the samples for certain blood tests, which I'll come to later. Once the CT scan is done, and that will confirm the diagnosis, because clinically sometimes it is going to be difficult to differentiate between ischemia and hemorrhage. Whenever there is reduction or depression of the sensorium, the blood pressure has mounted up and the symptoms worsen over a rapid period of time, this points towards the hemorrhage. So clinically, based on the history, what we can differentiate even before a CT scan is that rapidly worsening sensorium, raised BP, worsening symptoms point towards hemorrhage. If you look at the ischemic patients, there's a maximum deficit at the onset of the ictus, and sometimes the recruitment of the neurologic symptoms occurs, or there is a remitting deficit. Recruitment means first the patient may have a weakness of the right upper limb, then he may have a weakness of face, then he may lose a speech, and then there is loss of power in the legs. So this may have a circulation, and this is called as recruitment of the symptoms, which we may point towards the ischemia. Next slide, please. Coming to the treatment of acute ischemic stroke, treatment is designed to reverse or lessen the infarction and to improve the outcome. First is the medical support. All the blood pressure, sugar, and the routine parameters have to be looked at. We have now IV thrombolysis, which is a very important landmark in the treatment of stroke. Then it has further improved our treatment in the patients where there is facility available, and that those are endovascular techniques, antithrombotic treatment, neuroprotection, and stroke center and rehabilitation. And you know that it is one of the important points which I have made for you people is that rehabilitation of the stroke patient is very, very important, and the role of a physiotherapist also is very, very important in the management of a stroke. Next slide, please. Coming to the assessment and management, goals are rapid evaluation, early stabilization, neurological evaluation, rapid transport, and triage to stroke hospital. As I mentioned earlier, in the emergency medical room, the assessment of the patient in the form of ABCs is important, and those issues to be addressed at the outset. Next slide, please. Then you obtain the focused history from the patient, if he's able to speak and give you a correct information, or a relative around, or some of the eyewitnesses who would have brought the patient to the hospital. You must note that the time of the onset of the symptoms, because it is important to know if he's in the window period where we can give him the tissue plasminogen activator. You must know that what was the last point of time when the patient was normal, and that would give you a time from the onset of the stroke. It may be impossible to get that in aphakic patients or with no relative around with the patient. Those who were the eyewitnesses can be able to give you the scenario, and from that you may have to extract what is the exact time of the onset of the symptoms. History of trauma to the patient before the onset of symptoms also is important. History of convulsions, history of prior stroke, diabetes, hypertension, and history of atrial fibrillation also is very important in the history of stroke and the past history. If the patient is on any current medication like anticoagulation for his heart ailment or the deep venous thrombosis, it is important to know that, because it may have caused a bleed inside the brain, and we may end up in not knowing and not evaluating that part of the history of the patient. Next slide, please. Pre-hospital evaluation and management in the potential stroke patients. Recommended it is assess and manage the ABCs as I mentioned earlier. Initiate cardiac monitoring, provide O2, maintain around 94, and 94 is a very important landmark. Now we all know because of the COVID, but not for stroke. If the saturation is less than 94, we all send them to the COVID center, because the landmark is that below 94 it is COVID. But we must maintain our patients, stroke patients, O2 above 94, establish an IV line, and if the sugars are high, we may have to start the treatment, because it is important to have normal levels of sugar in the treatment of stroke. Determine symptoms at the onset time and contact family. Triage and transport to the stroke hospital. It is not recommended in the pre-hospital evaluation not to initiate intervention unless advised. Do not give excessive IV fluids, which may lead to cerebral edema. Do not give dextrose. So all the Hypertonic fluids are to be avoided. Isotonic fluids are supposed to be given. Nil per oral. Do not daily transport to the hospital. Patient has to be sent to the hospital for the further treatment and kept there. Next slide, please. Neurological exam and stroke scales. I'm not going on much stress on the stroke scales because they have to be acquired, learned, and continuously remembered. But we are going to have a brief neurological examination, activation of the stroke code if at all we are in a stroke hospital, and stroke scales NIHSS to be performed as to decide what kind of a treatment we are going to give it to the patient. Next slide, please. Diagnostic studies with suspected stroke patients. All patients should have non-contrast brain CT or an MRI, blood glucose, O2 saturation, serum electrolytes, and renal function tests. Complete blood count, including platelet count, because higher platelet count also sometimes lead to a stroke, that is in thrombotic, thrombocytopenic purpura. Markers of cardiac ischemia, prothrombin time and INR, activated partial thromboplastin, that is APTT, and an ECG for the patient. Next slide, please. In selected patients where there are other comorbid histories, you must have PT, APTT, hepatic function test, toxicology screen, blood alcohol level, pregnancy test, ABG if hypoxia is suspected, chest radiography if lung disease is suspected, lumbar puncture if subarachnoid hemorrhage is suspected and a CT scan is negative for blood. If at all CT scan shows subarachnoid hemorrhage after an aneurysmal bleed, we must not perform lumbar puncture. And if the seizures at the onset were reported, then electroencephalogram. Next slide, please. Recommendations. Goal is to achieve evaluation and fibrinolytic treatment within 60 minutes. Use of stroke rating scale, NIHSS, that is class 1 level of evidence B. Limited tests are to be done, that is hematology, coagulation profile, biochemistry, and PSL before recombinant tissue plasminogen activator is recommended for treatment. ECG, troponin, and chest X-ray if needed. Next slide, please. Recommendations with acute cerebral ischemic symptoms that have not yet resolved. Emergency CT scan, either CT or MRI recommended before TPA to exclude intracranial hemorrhage. Then hyperintensity of ischemia could be seen on the MRI, and that has to be confirmed before you give RTPA. The non-invasive vascular study in case of intra-arterial thrombolysis or mechanical thrombectomy is contemplated. This is at a higher center. And when the window period of 4.5 hours has gone beyond, then we may have to give not IV, but intracarotid tissue plasminogen activator. And for this, we need to have a vascular study before giving intra-arterial RTPA, or a thrombectomy surgical intervention is indicated. CT within 45 minutes and read by an expert. CT perfusion or MR perfusion and diffusion imaging, including MR infarct core or penumbra for selection of the patient beyond the time of window period for RTPA. Next slide, please. Where there is a clear-cut recommendation for cerebral ischemic symptoms which are resolved, we need to get a non-invasive imaging, that is of the cervical vessels, CT angio or MR angio imaging within 24 hours, MRI, DWI diffusion weighted imaging preferred, CT brain in absence of MRI. Next slide, please. Now coming to the algorithm for stroke and the TIA management. Stroke or TIA is suspected. As I mentioned, ABCs and glucose, obtain brain imaging. Going to the left hand of the figure, ischemic stroke, bar TIA 85%. Consider thrombolysis, bar thrombectomy if the window period is over. establish the cause in the form of atrial fibrillation, carotid disease, and others. In patients who have a clear-cut diagnosis being made, then the specific treatments for them are contemplated. But on coming to the right-hand side of the image, when you find a hemorrhage on the CT or MRI, you have to monitor and lower the blood pressure, which may have been a cause of an intracerebral hemorrhage. Coming to the establishment of the cause of a hemorrhage, we may rule out aneurysmal subarachnoid hemorrhage, hypertensive bleeds, and the other causes which may be hematological. If it is aneurysmal, then we need to get an DSA done to clip the aneurysm, if at all, which is visible. Hypertensive intracranial hemorrhages, depending upon the edema surrounding it and the symptoms worsening, the sensorium worsening, we may have to consider a craniectomy and removal of a clot if it is superficial. Deeper clots in the deeper areas of the brain like thalamus and basal ganglionic region sometimes may not be possible. Next slide, please. Coming to the treatment of hypertension in patients for IV RTPA, if the BP is more than 185 by 100, labetalol is given. Maintain the blood pressure. In other patients, we can use hydralazine or enalapril. If the BP is not controlled, then there is no question of giving RTPA. Next slide, please. If after RTPA, maintain the blood pressure in a specific level for the next 24 hours. If the BP remains on a higher side, injection labetalol is the drug of choice. If the BP is not controlled, then the last resort is sodium nitroprusside, which has to be strictly titrated and monitored. Next slide, please. A cardiac monitoring is specifically required to screen patients with atrial fibrillation and need to be performed at least for the 24 hours if the atrial fibrillation is suspected. Coming to the patient, next slide, please. May I have the next slide, please? Okay, coming to the acute treatment of the ischemic stroke. As I mentioned, the recombinant tissue plasminogen activators have changed the face of the treatment of ischemic strokes. And it is very, very important landmark and very, very important for the patients. Like in the cardiac ischemia, streptokinase had made a change. Similarly, this RTPA has made a change in the patients with the ischemic strokes. It is given at a rate of 0.9 milligrams per kg body weight over 60 minutes. And in the dose, 10% of it is to be given as a bolus over 1 minute, and remaining 90% is to be given over 1 hour infusion. Patient needs to be admitted in ICU. Hypertension, nausea, vomiting, worsening of the neurologic status has to be monitored during the next 24 hours after the treatment with recombinant tissue plasminogen activator. If the symptoms worsen, immediate CT brain is to be done to rule out hemorrhage after the tissue plasminogen activator, which is one of the side effects of TPA. Monitor BP and neuro examination every 15 minutes during and after the RTPA is given. Examination is to be repeated every 30 minutes for next 6 hours and every hourly for next 24 hours after the RTPA. Antihypertensives given to reduce the BP below 180 systolic and below 105 for the diastolic. Catheterize the patient, CT brain or MRI after 24 hours. Next slide, please. Second and the third generation thrombolytic drugs are high binding affinity for the fibrin, and that is alteplase, fibrin selective activation of plasminogen, and it is a more efficient, it is more useful than streptokinase, but lesser useful than the RTPA. Next slide, please. There are inclusion criteria for the use of RTPA. Diagnosis of inclusion criteria, diagnosis of ischemic stroke after the neurologic deficit has been confirmed. Onset of symptoms more than 4.5 hours now before beginning the treatment. Age has to be above 18 years. Next slide. There are multiple exclusion criteria. If the patient has a head injury prior 3 months, subarachnoid hemorrhage, then history of previous intracranial hemorrhages, neoplasm, AV malformation, aneurysm, recent surgeries, higher BP more than 185 systolic blood pressure, and active bleeding disorders, platelet count less than 1 lakh. All these patients are contraindicated to have tissue plasminogen activator. Next slide, please. Relative exclusion criteria are patients may receive fibrinotic therapy despite one or more contraindications. Only rapidly minor or rapidly improving stroke symptoms, like as we suspect in patients with TIA, tissue plasminogen activator is not given. Pregnancy we should not give, and major serious trauma or surgery within previous 14 days of stroke of a recent onset. Next slide, please. We'll skip this IV RTPA. Next slide, please. Okay, now coming to the endovascular treatment of stroke. When there is an contraindication for IV RTPA, no change in the NIHSS score 1 hour following administration of RTPA when it is not being useful to the patient in the present scenario. 3-hour treatment, now 4.5 hours treatment window period has expired, and less than 10 hours in the window period. Whenever there is a severe neurologic deficit and when RTPA is contraindicated. Next slide, please. This is called as mechanical thrombectomy, and this is done, as I mentioned to you earlier, that wherever there is an indication for mechanical thrombectomy, it is an exclusion criteria from the treatment of IV RTPA. There are multiple stent retrievers, and they are intravascular procedures which can be done in the very specific cath labs and wherever the skilled personnel are available. This is not a routine treatment which is given at routine hospitals or a tertiary care center, but you need to have a very specific cath lab and personnel who have been trained in doing this procedure. Next slide, please. The endovascular treatment within 8 hours, longer in certain patients like those who have an occipital infarct or posterior circulation. There are certain devices which have been approved by the FDA, and they are Mercy retrieval device or penumbra aspiration device, which have been approved by the FDA in the United States and now being rarely used in Indian scenario also. Next slide, please. Just to give you an idea as to intra arterial RTPA treatment, we can actually inject RTPA into the thrombus by going intravascularly, intra-arterially, and dissolve the clot. Next slide, please. This is the lower slide. What you see is the Mercy device, which is pulling out the clot of the thrombus. You can see it on the right side of the slide where you have a thrombus which has been pulled by the Mercy device out. Next slide, please. Mechanical embolectomy also is possible with a device which is used intra-arterially. Next slide. Anticoagulation with heparin is not recommended, and it is according to the class 3 level A evidence, and we do not use anticoagulation when the patient is beyond 10 hours and beyond 4.5 hours of the IV RTPA. Next slide, please. Coming to the antiplatelet agents, the gold standard oral aspirin remains the mainstay of the treatment for a longer period of time. Oral aspirin, 325 milligrams within 24 to 48 hours for a stroke in all the patients. And maintenance is with the 75 milligrams once a day or twice a day, depending upon the co-treatment with the oral anticoagulants like the new drugs which have come. Clopidogrel also is being used, but role is not very well established. There are new drugs, glycoprotein 2B3A receptor inhibitors. They have been under trial, but not really used in practice still. Next slide, please. There have been number of neuroprotective agents like citicoline, piracetam. They have not been found to be of any great help in the stroke management. Of course, the statins in the treatment of the stroke is important on a long-term basis, and they are definitely recommended. Next slide, please. Surgical intervention, urgent use of the carotid endarterectomy when imaging suggests a small infarct core with large territory at risk, that is called as penumbra, with inadequate flow from the carotid stenosis. Occlusion is not clearly established. In such scenario, we can do a DSA and do a carotid endarterectomy when you can bypass the block and the end-to-end anastomosis of the carotid after the removal of the clot area or the occluded area. Coming to the next slide, which is very important. Comprehensive stroke care is which is needed in all the centers which are treating patients with stroke. Stroke care with rehabilitation is definitely needed. Suspected pneumonia, urinary tract infection, treat it with appropriate antibiotics. Subcutaneous anticoagulation for the deep venous thrombosis prophylaxis. Nasogastric tube insertion for the medicines and the food. Early mobilization, and that is where the role of a physiotherapist comes. It's not after the treatment, but during the treatment, early mobilization, giving a confidence to the patient that he may be all right and may be back to his work, provided the patient cooperates with the therapist. Of course, treatment of the concomitant medical illnesses is also important. Next slide, please. Brain edema is one of the important complication of the stroke, and that has to be monitored. Brain edema will manifest in the form of a worsening sensorium, and for this, intracranial pressure monitoring of the neurological signs is important. Surgical evaluation is needed if the edema is very rapidly worsening, and that is called as malignant cerebral edema, which may have to be tackled by decompression of the especially the posterior fossa infarcts like cerebellar infarcts, or in the MCA infarcts where the edema rapidly worsens. You can do a craniectomy and remove the part of the brain which is causing the cerebral edema, and that's called as decompressive craniectomy for the malignant edema. Sometimes patient may develop an acute hydrocephalus and may need a treatment with a shunt to drain the ventricles. Next slide, please. We'll not go to the stroke surgery because that's not the scope of the talk today. Next slide, please. Treatment of acute complications, that is seizures, have to be treated as like any other neurological conditions. Anticonvulsants may be needed, and the drug of choice nowadays is sodium valproate and levetiracetam. Next slide, please. Principles of prevention, primary and secondary prevention, medical and surgical interventions, lifestyle modification, identification and control of the modifiable risk factors, atherosclerotic risk factors like older age, family history of the thrombotic stroke have to be monitored clearly, diabetes mellitus, hypertension, smoking, high cholesterol level and low HDL and high LDL patients to be monitored. Next slide, please. For secondary prevention, treatment with atorvastatin. Statins are useful in the primary prevention also. It reduces the primary stroke occurrence by 51%. Next slide, please. Antiplatelets are the gold standard in the treatment of stroke. That is aspirin, clopidogrel, and the old combination of aspirin and dipyridamole. Next slide, please. Whenever we suspect that atrial fibrillation is the cause of stroke, then in that case, the new drug which has taken the place is dabigatran. We have been using and we are quite comfortable with use of dabigatran now. Last slide, please. Okay, now look at this vehicle. This vehicle I saw when I attended one of the World Stroke Congress in Germany recently. And if you look at the inside part of the car, next slide, please. Next slide, please. And this is a mobile stroke unit. And this has revolutionized treatment in many Western countries. And I'm proud to say that there are 3 centers who have got these mobile stroke units. And one of that is in a very small place called Tejpur in Assam. There's one small mission hospital. With the help of CSR, they were able to get these mobile stroke units. And I'm working on this so that I get one, and that would be the most satisfying thing in my life, that I established these mobile stroke units. And the last slide, please. Here you see that vehicle goes to the place of a patient where there's a phone call, and the vehicle will go, which has got an inbuilt CT scanner inside it. The CT scanner will scan the patient and send the images to a doctor sitting in the their center, stroke center, and a patient who is in less than 4.5 hours could be given RTPA at the ground zero level. And this will revolutionize, reduce the morbidity, reduce the mortality in the patients of a stroke. And we look forward for these days when there will be so many mobile stroke units, which could reduce the morbidity, mortality, and the financial burden on the finances of the country, where there will be so many handicapped people as we expect as the age advances. Thank you very much for this time of sharing with you, and thank you very much for this opportunity and patient hearing. Thank you.
Thank you very much, sir, for your lucid presentation, and best wishes for your lifetime ambition of getting the emergency stroke unit as a vehicle unit to Wanless Hospital, this part of the Maharashtra.
Thank you so much.
The patients from this area will be more blessed in that case by the God if you get it at the earliest. Really, sir, this topic of today, the theme of the conference will be definitely justified by your presentation, because the theme purposefully with thinking about the multidisciplinary approach in the management of the stroke will be an ideal topic for the theme of the conference, because the stroke patients will initially be very well taken care by the neurologist, and they will be handed over properly to the respective neurological team, management, rehabilitation team. Then in case during the phase of rehabilitation, if the patient having any problem, they will be again referred back to the physician, and then the overall the care will be taken so that the complete quality of management we can execute for the affected individuals in the society. So really, sir, we are very happy to listen to you, and it is really useful talk and useful presentation for all neurophysiotherapists and all the budding physiotherapists who are taking up this profession as their career. And really, we are fortunate to have you, sir. And in this, thank you very much, sir.
Thank you so much. Thank you.
Over to you, Dr. Trupti.
Thank you, sir. We shall move with the next session for the day. I request Dr. Khushbu to take over.
Thank you so much, Dr. Trupti. For our next session, we have a very eminent speaker who is none other than Dr. G. Varadarajulu, having 24 years of professional experience in administration, teaching, and clinical areas. He is graduated from Tamil Nadu Dr. MGR Medical University in the year November 1996 and postgraduated from MG University Kottayam in the year July 2002. A challenging neurophysiotherapist having excellent leadership qualities. Presently serving as a Dean of Faculty of Physiotherapy at Kim's Dean to be University, Karad, Maharashtra from October 2002. Having a research background of guiding more than 25 staff projects, 75 postgraduate dissertation, and numerous undergraduate projects during his tenure of his services. So far, he is having 5 publications as first author, more than 25 publications as corresponding author in his credit. He is awarded twice National Level Distinguished Service Award by the Indian Association of Physiotherapists. He is always a visionary physiotherapist, wanted to take up some professional development responsibilities in this part of southern Maharashtra and country. Presently, he's taken the responsibility of the president of Satara Physiotherapy Association and also working as a founder member of establishment of Indian Neurophysiotherapist Association. We are very glad and honored to have with us Dr. G. Varadarajulu, sir. We welcome you, sir. Over to you.
So very nice introduction on this platform, Dr. Khushbu. A warm welcome to all the participants for this today's theme of the conference and the topic of discussion.
Sorry to interrupt, sir. Can you start your video, sir?
1 minute. There is some technical problem. Video on. Yeah.
It's fine.
So welcome back. So we'll be in fact truly discussing about the theme of the conference and taking the example of an very important topic of stroke rehabilitation. So in the previous session, we have attended, all of us are attended the very well discussion by Dr. Nathaniel Sasya sir, who is a medical director of Wanless Hospital.
Dr. Varadarajulu, can you hear me? Sir, unmute yourself.
पहले से जाना First slide.
Trupti, can you please share the slide?
No, she cannot say. Okay.
Madam, you have to share from that end.
Okay.
Yes, over there.
Go to the first. Sorry for the inconvenience. Actually, usually since it is an online presentation, there will be some technical problem. Once again, a warm welcome to all the participants. Today is the topic which is most suitable for the theme of the conference. The theme of the conference is Health Professionals' Integrity is the Hallmark of Physical Therapy and Rehabilitation. So, to understand this concept or this theme, stroke is the topic which will make all of us clear that how do a physiotherapist will work togetherly with or integratively with the other healthcare professionals involved. So in a previous lecture by Dr. Nathaniel Sasesar, the Honorable Medical Director of Wanless Hospital, he has clearly made us understand that how do we look at, as a team of the neurological rehabilitation team, how do we look at the stroke. So the sir is very nicely explained, and it has really given me the good platform to talk on the my part of this continuation of this topic. So you all know that I'm Varadarajulu. I'm heading the Krishna College of Physiotherapy from past 24 years, past 18 years in Karad. So now so today the topic is a multidisciplinary approach for the management of stroke. So role of physiotherapist. So far in the previous session, explained about the role of the neurologist point of view. So when he wants a rehabilitation, and what is stroke, and what are the different managerial, that is conservative managerial aspects. So sir has very nicely explained. Now the patient will be coming to us once the patient is absolutely managed or perfectly managed by the neurological team, that is a neurophysicians team. When they were managed, and they will be safely handing over to the patient to physiotherapist. So what is our concern when a patient is referred to a physiotherapist? How do we look at, okay, what is the role of physiotherapist? What is our concern when the patient is referred by a neurologist and in an inpatient setup in a tertiary care hospital as a neuro specialist? So what is your concern? So first and foremost thing is, in this session we will be discussing, of course you should know what is stroke and other things. Dr. Sasya sir has very well explained. We don't have to discuss more about that. Directly we'll go to this is the area that we were concerned. So we should understand when we are going to when we are seeing the patient, how do they present with us? How do the stroke patient will be presenting with us? What are the common problems that the patient may that you may see at the patient when they have been referred to you? So now what are the common problems? If you see, we all know that when there is a stroke, and we always observe the observable sign and symptom of the stroke is hemiplegia. You will see there is a paralysis of one half of the body. That is what is chiefly we will be finding. Even the patient will be identified, and everybody will be knowing that there is a one paralysis of one half of the body, which is an immediate clinical manifestation of or observable clinical manifestation of stroke. So always we know that hemiplegic will be opposite to the site of lesion. This basic everybody knows. So now apart from this, as a neurophysiotherapist, what you are supposed to observe, and what are the problems that you should be encountered, that you should be looked for is, which is very, very important as far as the neurorehabilitation is concerned. The first one is abnormal postural reactions. Number 2 is abnormal reflex patterns. Number 3 is abnormal tonicity. Number 4 is loss of balance and coordination. Number 5 is sensory motor dysfunction and functional impairment. So this is what is the core areas that we should be, that the patient will be having, where we are supposed to look for. So how does it comes? So after the, the definition of stroke is the symptoms lasting more than 24 hours. So after 24 hours, when you get, means at the 25th hour, when you are happens to see the patient. So what is our expectation? What is our minimal expectation is the patient will be coming out of the unconsciousness and patient will be conscious. When a patient become conscious, it is an highest possibility that, and the patient will be out of the what we can say sudden onset of depression, mental depression, because till yesterday the patient was normal, he was moving around, and because of the hypertension or embolism, because of this problem, suddenly you found that one half of the body is paralyzed, so another half is moving. So it means what? He will be definitely depressed first. See, it will be a mental shock to the person after once he has come back from the unconsciousness. So whenever the patient comes out of the unconsciousness, and if we see that one half of the body is paralyzed and another one is moving, then he will try to move the body by himself. Okay, definitely that movement will not be a normal movement. So that intention of moving will create an abnormal postural reactions, because the part of the body which is not affected pathologically will be normal. The patient will try to use that. When they try to use that, he will develop the abnormal postural reactions. So how does this abnormal postural reactions will come neurophysiologically? Because we all know that when you go back to the development of the growth and development of the nervous system, very initially, immediately after the birth, there is a primitive reflexes will come, and they will teach the movement, normal movement patterns, and they will get controlled by the cerebrum at the higher level. So the cerebrum will have the control over all the primitive reflexes once it is getting integrated. That is what is the literal meaning of reflex integration. So the reflexes which has come, the purpose of the primitive reflexes in the childhood days is, that is infancy days is, it has to come and it should get integrated. It should become a normal movement, and that should be controlled by the higher cortex. So when there is a cortical damage in any means, once again these all reflexes will become uncontrolled, because the reflexes means what? It's an involuntary movements. So it will once again comes and act, because there is nobody to control the reflexes, because cerebrum is damaged. The CNS is affected due to the stroke. So when a patient, when he is trying to move abnormally, so postural reactions will develop. When a posture develop, then the abnormal postural reactions and the reflex patterns togetherly will increase the tone of the muscles on the affected part of the body. Then if you at the phase wise, you will definitely find that a paralysis, that is a motor impairment, motor control will be lost, and balance and coordination you cannot assess only initially, and functionally if you see, patient will be bedridden. So this is what is our observation immediately when the patient is referred to you, whether the abnormal postural reactions are there, abnormal reflex patterns are there, abnormal tonicity are there, loss of balance, whether the motor control, how is the motor control, and balance and coordination, how is it, and functional impairment. So these are the observations, these are the problems that we are supposed to look for when the patient is referred by the neurologist to the neurophysiotherapist, when you happens to check the patient, when you happens to evaluate the patient. So in that way, that is how our concern. Then next thing is ideal time of physiotherapy reference by neurologist. So what is our request to the neurologist is that we always feel that all neurophysiotherapists in the country, we feel that earlier is the better. Only prerequisite is all the vital parameters should be stable for more than 24 hours. So it is not that the vital parameters are stable for 12 hours, again it is fluctuating. That should not happen. So for more than 24 hours, if the vital parameters are stable, I physiotherapist. Whereas if we go back to our history, when do we get a stroke patient in ancient days? If we see, 25 years before, 30 years before, before 30 years or during our parents' time, if we see, stroke means they used to consider it is a sin of the person. So beyond, they think that now the patient is having stroke, that is his sin. So that was the era. Now, once the medical advancement has come, there are people to take care of these people. Once the people are recognized as, the neurologists find our importance, then the patient is to refer to us. So that is what is happening. But before the neurophysiotherapist evaluation, the patient used to come as after 6 months of the stroke, after 1 year of the stroke, with all established symptoms, where we are not able to help the patient to the extent of patient expectation. So what we want is, we want the patient to be referred at the earliest. So what is the prerequisite? The vital parameter should be normal for more than 24 hours. So what is our workstations? Yes, the patient is referred to us in time. Where do we intervene? So how do we do it? So first thing is, stroke intensive care unit is our first place of working with stroke patients. So my dear neurophysiotherapist or my dear budding physiotherapist, what I wanted to tell you that you can go to the ICU where the stroke patient is admitted. That ICU is called as stroke intensive care unit. You will be working with the neurologist and the stroke intensive care unit staff nurse, that is nursing assistant, ICU nurse, and you three will be taking care of the patient in the stroke intensive care unit. So what do? You observe whether the patient has come back from the unconsciousness, whether the patient is doing an abnormal movement, and if he is doing abnormal movement, you are supposed to position the patient normally, and you should see that there is no abnormal reflexive patterns are exaggerated, and you have to check that the tonicity is not getting increased and tonicity is coming and it is maintained. So this is the area of concern when you go to the stroke ICU. So that is your workstation. Then second station is recovery ward. So when a patient is stable and a patient is optimally progressed, we'll go to the next slide actually. When a patient is optimally progressed, so patient will be shifted to recovery ward. So when a patient is in recovery ward, and as a neurophysiotherapist, your role is to check with the functional mobility of the patient. So whether the patient can able to move around himself, whether the patient can gain the confidence of the patient. That is what is your area of concern, as well as when you are in the recovery ward. What is our role? So because patient not developed abnormal postural reactions, patient is tone has been maintained, we should be look after the functional mobility of the patient. So when a functional mobility of the patient is been taken care, and there you can do an intervention, then you will be going with your further management of functional mobility training, and of course the regaining the motor control, and training with the activities of daily living, walking, all those things you can do it. So after that, at community level, so once you are comfortable, the patient is become functionally independent, he can move by himself, he can go, but he should to continue is stay comfortably at his living place. So there is some strategies we should set, we should tailor, and we should give it to the patient so that he will continue in your dwelling area also, at the community level also. This is what is the 4 workstations where as a physiotherapist we are supposed to look for. Then our next concern, So I wanted to bring it to the knowledge or notice of the young budding physiotherapists that you don't worry about recovery of the stroke, because if in case of any damage, like you can imagine as like that of a tree, a branch of the tree has been cut or a part of the stem has been cut, it will grow by himself, because we are not died, the patient is not died, he is living body, he is living tissue. So there is a possibilities of recovering itself. Okay, there is a highest possibilities of recovery. There is no problem at all. So you don't worry about that young buddings. So recovery happens by itself. So okay, by default the recovery will take place. So that is initially found by the Brunstorm, especially for the stroke. So he has understood that once the stroke happens, when the vital parameters are stable, the acute care management by the neurologist has been done, and the recovery is taking place on its own. So you as a physiotherapist to work with the recovery stages, at different recovery stages you are supposed to work. So his observations, the Brunstorm observation as far as the stroke after the management of acute care is that the patient will definitely undergo a stage 1, that is flaccidity. The first phase, what he has observed in the stroke patient is what? There is a flaccidity in the upper part of the body, that is affected part of the body. So whether it's upper limb and lower limb of an affected side, no, it will be flaccid. The tone will not be there. Okay. Then after that, slowly spasticity appears. So spasticity appears. I told you in the previous slide that it is secondary to abnormal postural reactions, abnormal reflexive patterns, which is the initially it has functioned as which is normal in the infancy time, in the childhood time. Once again, it has started acting on the body, and it has developed the abnormal postural reactions. It has created the reflexes, and reflex activities developed the continuous bombardment of anterior and cervical spinal cord, which is not been controlled by the cortex. That is why spasticity started appearing. So this phase also will be happening. Then the spasticity will go to the peak. That is also one phase. Then suddenly the spasticity is raised, will be started declining. It is decreases. Then there is a possibilities of complex movement combinations will develop. Then there is a possibility of spasticity disappears also. But at every stage, as we think theoretically, it will not happen as Brunstorm ने imagine किया है, Brunstorm ने imagine किया, वैसे नहीं होता है. It will not happen like that. Okay. So to facilitate each and every phase normally, the role of physiotherapist is very, very important. We have to normalize the recovery. So because if you leave it just like that, the spasticity may increase and it will not, it cannot be controlled. Then the limb will become highly spastic. So there is no scope for further transition of phase from stage 1 to stage 3 to stage 4. It will not go only, it will stuck to one stage. So that is the area where physiotherapist is very, very important. So in every stage of recovery, we are supposed to intervene, and we are supposed to intervene properly, so that every phase will be happening smoothly and in a therapeutically advanced manner. So that is what is our intention. That is what we are supposed So what is the neurophysiotherapy now? Sir, because in previous time I just mentioned neurophysiotherapist. Who are all we? So as an advancement in the physiotherapy profession, the departmentalization has been evolved from the past decades. As and when we have so many number of physiotherapists passed out from various health universities across the country, the branch of neurophysiotherapy has taken up its root in the existing practice of physiotherapy, because there are more than 5,000 physiotherapists are there, neurophysiotherapists are there in the country, in our own country. So because of that, we are expecting every tertiary care hospital, in every department of physiotherapy, there should be an establishment of a neurophysiotherapy unit, and a neurophysiotherapist only should deal with the all neuro cases. Then only the success rate of neuro patients will be highly appreciable. The hallmark of the quality of rehabilitation will be definitely fulfilled. So now what is skills of neurophysiotherapy? So the skills of neurophysiotherapy, if we say neurophysiological techniques and its applications. So we all say that we have a certain neurophysiological techniques upon which we are all believing. So what is the neurophysiological techniques? You all can ask me. So neurophysiological techniques is nothing but any approach which is going to be alter the altered abnormal physiology of nervous system at a site of lesion. This is what is the neurophysiological techniques. Any skill that you use, there is a, of course, because of the dog, there is an altered physiology. The altered physiology को alter करना वाला skill है तो, और उसको normalize करना वाला skill है तो, that we are calling it as a neurophysiological skills, because these are the certain skills which are evidence to be worked at the site of lesion, which is proven effective, and these are the some of them. So Babat concept, PNF techniques, Brainstorm movement therapy, MRP, roots, all these are the some of the skills that we are calling it as a neurophysiological techniques, which is having a significant effect at the site of lesion, which is creating a positive neurophysiological are called as a neurophysiological techniques. Then neuronal plasticity. So now again one more important area that neurophysiotherapist should be understanding, or a budding physiotherapist should be understanding, is that whether the stroke patients are really improving. We may all of us used to have a doubt once upon a time. So whether this improvement is really true, whether जैसा मैंने previous slide में बताया, is it happening, or it is the only hypothesis of Varadarajalu? Not like that. So it is happening. The recovery is taking place. The evidence of recovery, that is only we call it as neuronal plasticity. There is a physiological changes happening at the site of lesion, because the tissue which is affected getting remodeled, getting reorganized. Okay, and there are so many neurons which are taking up the functions of affected neurons. So the recovery that is happening is been evidence that it is secondary to a positive or an effective neuronal plasticity happening at the site of lesion. That is what is the meaning of neuronal plasticity. So what is the definition is? It's a physiological process of remodeling, reorganization, remapping the neuronal connections by utilizing the underutility neurons of a specific functions affected of the affected part of the body at the site of lesion is called of a neuronal plasticity. So what is the concepts of neuronal plasticity? So how does it is happening, sir? Because this is also area, because we are now entered and become successful in an area of specialization. So we should be strong in our concepts. So how does the recovery take place? What is the concepts behind neuronal plasticity? The first one is vicariance. Number 2 is functional substitution. Number 3 is redundancy. Number 4 is diastasis. So what is this vicariance? So if you see, the vicariance means, in short, I'm going to tell you. So in our lifetime, means for 100 years, the neurons which is specifically mentioned for a particular function. For example, for a movement of for the flexion of index finger. So for the flexion of index finger, there are some neurons which is specifically meant for that particular function at the site of at the CNS, at the motor cortex. So out of that damage, whenever that neuron has been damaged, means, okay, it is proven that the functionally utilized neurons only will be damaged, whereas there are so much of neurons which are kept hidden, which can take up the new functions however you wanted to, whichever the way that you wanted to take it up. So in our lifetime of 100 years, only it is assumed that only 25% of neurons of the brain is only utilized. Remaining 75% of brain is underutilized for the lifetime. So It means what? For a specific function, if that neuron is affected, there are so much of neurons which are ready to take up the function. So if you use the underutility neurons of a specific function, that process, that concept is called as vicariance. Second part is functional substitutions. Because you know, I told you before also, there is our brain works as a complex, works as a team. You know, if there is entire CNS will work as a single component. Even if it's a problem with the spinal cord, problem with the cerebellum, there will be a neurogenic shock. Even the problem with the cerebrum, again there will be neurogenic shock. So the entire CNS will be functioning as a whole. So with that concept, so if one affected part of the brain is being substituted with the other part of the brain, we call it as a functional substitution. That is what is another concept of neuronal plasticity. Then redundancy. So this is what I told you. There are some redundant neurons. Again, we'll be willing to take up. We call it as a failback mechanism. We call it as a failback mechanism. Then fourth one is fourth concept is diastasis. What is this diastasis? If you know, I already told you. Brainstem, just how the brainstem is found now. If you leave the patient after the conservative management by the neurologist, and if you just leave it like that, also patient will improve. So how it is possible? What is an evidence? How do you call it as? It is a diastasis. That is spontaneous recovery. Stage wise, when the first stage happens, second stage happens, then all the movements will come, and however the patient achieved on his own, and that will be the end of the fate of the patient. So this is how the various concepts of neural plasticity. In this, the neurophysiological techniques which I already mentioned now, that is highly will be effectively working with the support of, on the basis of the concept of vicariance only, because the underutility neurons ka support leke, if you train the patient, and the recovery rate will be definitely satisfactory up to the expectation, and that is the stronger concept that is been believed, proven effective in neuronal plasticity. So what are the strategies applied for best possible process of neural plasticity? So hamara paas mein what all things are there? Because these are the weapons. If you wanted to elicit best possible neuronal plasticity, what are the techniques that we are supposed to do? That's what in the previously I told you. So the vicariance ko support karna wala skills, if you are using, then you will definitely get a good functional outcome of the patient. So now in that the pioneer one or the effective one or a proven one across the world is Bobath concept. Why Bobath concept? If you know, the principles of Bobath were derived based on the common problems encountered by the patients of upper motor neuron lesions. So he has tailored the principles that if you prevent or if you manage these are the set problems expected in human lesions, or if you intervene timingly with that problem, and you can definitely elicit a good positive response. That is what is his belief, that is what is his concept. So what is the common problems? The abnormal postural reactions, abnormal reflexes, abnormal tonicity, loss of voluntary control. These are I told you in the very first slide that these are the common problems encountered by the patients. So Bobath has started concentrating on these problems. If you normalize the positions, there is no possibilities of abnormal reflexes. If you control the reflexes, there is no abnormal tonicity. If you maintain the tone, and voluntary control will be will set in, and if voluntary control if you can elicit, and definitely sensory motor integration will take place in a very effective way. So this is what is his belief. He strongly worked on those principles which is commonly encountered by all the human lesion patients, especially the stroke patients. So now, what is the principles that is followed to taken care of, to implement or to control the primary problems? Are strongly believe that you first position the patient normally. So he believed on normal postural alignment. That is why the first principle. And the second principle is inhibition versus facilitation. Third principle is assessment versus treatment. So every session of the Babat, so what is his intention is that whether you are at the ICU, whether you are at the recovery ward, whether you are at the physiotherapy OPD, whether you are at the community level, see that the posture, abnormal posture should not be the cause of damaging the patient. So the postural awareness to the working staffness, to the patient caretakers, some extent to the patient at the ICU. Then when patient come to the recovery, because initially if you wanted to block so many complications, so many consequences, working from the basic is very, very important. So he believed strongly in that. You see that patient is aligned normally, that position where patient is maintaining is not an abnormal position, and it is, and so that position को ऊपर उन्होंने ज़्यादा ध्यान दिया है. Let it be any functional positions. If the patient is standing, so any position, normality of the position के बारे में he was very much confident. He was very much particular. So now after that, inhibition versus facilitation. Then so much so he was particular about the normal postural alignment, but he was failed practically. That is why he has come to next principle of inhibition versus facilitation. Why he has failed if you see practically? Because if you tell a patient who is mentally depressed, who is having a shock, who is a neurological patient, and he will try to move abnormally, even if you tell many staff ne se bola to bhi, physiotherapist ne bola to bhi, patient attend ne bata to bhi, he will try to move because he is a living person, depressed, he was worrying, so he will try to move. So when he is attempting to move abnormally, what will happen? Abnormal tonicity will increase, abnormal reflexes will increase, tonicity will develop. So that is why second principle he has derived, that is inhibition versus facilitation. So whenever you feel abnormality, you should use such a pattern of movement which will inhibit the abnormal reflexes, at the same time which will facilitate the expected normal pattern of movements. So that is the skills he has developed in each and every phase of rehabilitation. Third principle is what is derived is, what is strongly believed is assessment versus treatment. Because every treatment session you should look for how is his postural awareness, how is his abnormal tonicity, how much he is reacting abnormally, how much he is corrected by himself. So every day you are supposed to have a sessional assessment, and then you should set your treatment protocol so that you will attain the goal in the same day itself. So on this basis, he strongly worked. Then the next closely associated, strongly believed evidence-based neurophysiological approach is PNF. So PNF ka what is main thing is, he believes that apart from movement patterns, apart from the reflexes, apart from the positioning in the body, there are something which is that means in affected part of the body. If you facilitate that receptors which is having a direct connectivity to the motor cortex, so that will facilitate the vicariance, that will have a that will give a positive impact at the site of lesion, and that will give a good impact of required desired movements हमको आने के लिए possibility. That is what is believed. So that is why he started using the stimulation of proprioceptors. So these proprioceptors are where these things are available. We all know that it is in the skin, it is in the joint, it is in the muscle. Okay, it is in your voice, it is in your look, it is your touch. So everywhere it is there. So he believed in that. If you give a norm, if you started using all these proprioceptors as an input to the affected part of the brain, and the patient may come out with a good response. That is what is believed. Then brainstorm. I told you. So Brainstorm, he believed in that about Brainstorm movement therapy. So he expected, let the movement comes, let the any type of movements comes, then we are so वो हमने use करके we can correct the movements. So he expected the stage 1, stage 2, stage 3 spontaneous stages, and हर एक stage में movement आने के बाद उसको normalize करने के लिए उनका तरीका था. So he believed on that, and he has derived the exercise protocol upon which he has been proved successful. Then again one more approach, constrained movement therapy, where the activation of the affected part of the body, specifically if we concentrate on the whatever the movement that can be facilitated and that can be controlled, that can be monitored, that can be trained in the affected part of the body, that will be a good source of input to the process of neuronal plasticity. That is also one of the concepts which supported the neuronal plasticity. Then fourth one is conventional physiotherapy techniques. So what is conventional physiotherapy techniques? So it is a symptomatic management. So this is what is all physiotherapists across the world, across the country, they started believing. And we will manage. The patient is having spasticity, we will manage the spasticity. Patient is having contractures, we will manage the contractures. Patient is not able to walk, we will manage the walking. We will give the walking training. The patient is walking with circumduction gait, we will correct the circumduction gait. Like that, if we are following a symptomatic management, so that is the conventional physiotherapy techniques. Maybe also sometimes it overlap with neurophysiological techniques. That is why you get a good improvement even in out of a result of a conventional physiotherapy also. So we are almost come to the last slide of the today's session. That what is how do we know, sir, our approaches, our concerns are really fruitful? How do we know it? So if we say the first one is, we will see there is a regaining of motor control. First result हमको क्या चाहिए? Motor control आना चाहिए. The second one is, you follow any skill, no problem, but what is your expectation from the as an outcome of your therapeutic outcome from the patient is what? Will be whether the patient has been regained his motor control, whether he can be able to do some amount of voluntary control by himself. It means what? There is an evidence of motor cortex recovery at the motor center. Third one is skill, motor skill. Whether the control what he gained, the movement what is achieved, whether it can be incorporated for the functional task, whether he can hold a glass of water he can drink by himself, whether that is been achieved, that is how the next improvement. Then the execution of functional task. So, and then he should go back to his job. Ultimately, we should not see him as a patient, and he should go back to his job. So in this way, if you get an overall improvement, it means our neurophysiological techniques, our neurophysiotherapy approaches are really benefited to the patients of the stroke. So this is what is I wanted to present as a role of physiotherapist as a multidisciplinary approach for the management of stroke. But after which, now we have come to the 2 stages. The first stage in this topic, we have come to the 2 stages. The first stage is governed by the neurologist. Once the neurologist is optimally managed and we made the patient to be stable and the patient is referred to a physiotherapist, and we have started interviewing the patient at the stroke intensive care unit at all the levels. We have treated the patient, and then now patient is ready for, patient is started walking, and he has become independent and in his activities of daily living. And now we are in need of activity specific, that is occupational specific rehabilitation, because his rehabilitation is, we could do only the 50% of the rehabilitation or 75% of rehabilitation, whereas the end of the rehabilitation will be going, this patient will be definitely in need of other healthcare professionals like an occupational therapist. Bound responsibility that a patient was previously was a driver, patient previously was a teacher, patient was previously was no, so occupational specific training देने के लिए how we felt from a neurologist. These are the prerequisites. Like that, occupational therapist will have a prerequisite so that he will start his occupational therapy with the same stroke patient. Scientific today's session. So that is what we are going to see. And of staff nurse at intensive care unit at various levels, especially when you talk about a stroke, and we will be knowing the importance role of a staff nurse, stroke intensive care ICU nurse, how coordinately they will work with us, what is her role, and what is our expectation from the staff nurse when you are happens to go to the stroke ICU. That is what is the that is how we'll be completing this topic on today's discussion. So thank you very much for your patient listening, and if at all you are having any doubts, even from the previous topic of Dr. Nathaniel Sase sir, and even from my discussion, if any of you are having any queries, you can ask me, and I'm ready for the question our session. And over to you all. Thank you very much. Over to Dr. Trupti.
Thank you, sir. It was indeed a great presentation. We have some questions for you, sir.
Yeah.
In case of permanent arterial fibrillation, how much heart rate do we maintain during the exercises?
So regarding the heart rate, we always go with the what we can say sub-maximal heart rate. So we set up a target heart rate. We will be trying to do the lower heart rate, because the exercises what we are going to do, it does not have much impact on the heart rate actually. But even the minimum of sub-maximal heart rate will be sufficient enough.
So the next question is, in acute hemorrhagic stroke, can we mobilize the patient even after blood pressure is quite high? Or do we...
No physiotherapy is indicated when a blood pressure is fluctuating, when a blood pressure is at the peak, because it may lead to secondary attack.
Okay. So when we give tissue plasminogen activator, then within 30 minutes, can we reduce the impairments which are caused by any kind of stroke?
Actually, in a conservative management of the stroke, neurologist, of course, they believe on their maximal potentials, and they will try to do the things well in advance. And of course, it is going to be an effective. And regarding this, I think we may have to check with the neurologist. Can be very well answered to this. But definitely, maybe in a YouTube or like that, after consulting with the respective neurologist, I'll revert.
Thank you so much, sir. Thank you for your valuable time and enlightening us with your knowledge. Thank you so much. We shall move on to the next session of today.
Yes. Thank you very much.
Yes. Good morning, Eric. Dr. Eric.
Hello.
Hello. Nice to see you on the platform.
Thank you very much. So let me just present. Okay, is that coming through?
Yeah, the slide is visible. We'll start with a short introduction of yours, sir.
Thank you.
So here we have Eric Fedland. He is an Occupational Therapist who is working for 10 years. Originally from Orlando and worked as an archaeologist prior to finding his passion in helping people with process of healing. Eric has experience with skilled nursing as a staff therapist and a director of small rehab department, acute care hospital staff therapist, and a drug rehabilitation program. He has completed his field work for school at Johns Hopkins Hospital and the Veterans Hospital of Baltimore, Maryland. He has a large number of interests in various hobbies, and learning is his main passion, which contributes his interest in the field of occupational therapy. We are glad to have you, sir, for today's presentation.
Thank you very much. So my approach today was to look at how an integrated treatment and care approach is done in an all-inclusive care system. So where I currently work is a all-inclusive care program for all-inclusive care for the elderly. It's a system that is called a PACE. And in the United States, Program for All-Inclusive Care for the Elderly provides care throughout the spectrum of care, including physicians' care, social services, therapy, dental, all of the different aspects, including home care. Our interdisciplinary team provides coordinated care through daily meetings. And for most of the participants, what we do is if they qualify for the program, we integrate their care from the start of their program, them joining the program, all the way through till when they leave the program, most often through their passing. So how is PACE different from most American systems? So the Program for All-Inclusive Care for the Elderly provides preventative care. This is a big thing that in the United States is heavily missing in most of the programs. We do provide a complete care package through our program. The standard approach is a fee for service. So each discipline and each area of treatment is provided individually, and the communication between each of those programs and different systems a lot of times is lacking. You may have a person going to a physical therapist and then they will go to an occupational therapist or a hand therapist, and neither one of those people are actually communicating with each other directly. The standard system is fraught with a lot of potential for fraud, especially when we get into the skilled nursing facilities, because it's a fee for service and it is a for-profit system in the United States. A lot of times the programs are working toward maximizing their profit versus maximizing the positive effects for their residents. Overall, the PACE system, which has been around for about 27 years, does show that it is more cost effective. And as a result, the federal government is actually working toward increasing the use of PACE. So that's a little bit of background about what our programs are like and what an all-inclusive program in the United States looks like. So just to give you an idea of how this integrates with something like stroke care. When we have somebody, so I'm going to kind of go through a case study of how someone in our program. So we're going to call our case study Michael. He's a 61-year-old. He's already part of the program. He's been living with his wife. And while eating breakfast, he has experienced the signs of stroke. So the first thing that Michael's wife, Mary, does is she spots these gets a hold of an ambulance. She calls the ambulance, they come. The next part of our program is that then Mary contacts the program. So what this does is this initiates the program's information gathering. So now Michael is headed to the hospital, and our program is now informed that Michael is also going to the hospital. So first things, Mary calls the PACE call line. So that informs the physician who's on call that Michael is headed to the hospital. So now the physician is aware and can start to provide information to the rest of the team. They can then get a hold of the care coordinators, and they can also, if need be, contact the emergency room to start providing information about our participant, because our participant is somebody who we know very well. Michael is somebody who's been in the program already. This physician or one of the physicians who is covering on call at the time has access to all of Michael's information. We have a wealth of information because of all of the different treatments that have been provided through our physician. The hospitalist and the ER now have a greater amount of information. So when they start their treatments, they have all of that accessible because the PACE has actually provided that information to them. So the next step, so after Michael has gone through the ER and the treatment that the neurologist was talking about has been initiated, and Michael then goes into an ICU, we can then take that information. So the next morning, generally, the interdisciplinary team at the PACE has informed of the fact that Michael went to the hospital. We get updates immediately. We have access to the Sutter healthcare system, so we can pull information about all of his CT scans, all of the hospitalist's information, the neurological consults. All of that information is accessible to the team in that interdisciplinary team meeting. So at that very beginning, our interdisciplinary team has already started to make plans. By having that access and having that entire interdisciplinary team, what we can do then is help guide the process in the hospital. We don't necessarily tell them how to do their treatments, but in the ICU, when the physical therapist is in the ICU, they can actually get information from us regarding the person's prior level of function from a therapist's viewpoint. As we all know, with family members and with patients, their view may not be as effective, and their communication about the conditions that they have may not be as effective. So the physical therapist, the occupational therapist, the social workers all have the ability to verbalize that information to the staff at the hospital more effectively, thereby allowing a more effective treatment and better care planning as our participant moves through the hospital system. So we are able to review the charts. They're able to get communication from us. We communicate back and forth. There's a clinical care coordinator who's an RN or a registered nurse. She's in communication with the case manager, any of the hospital staff, Again, our hospital or the hospitalist is in communication with our physician. So as that communication continues, generally we're going to have an acute care stay, especially with a new onset of a CVA. The physician and the hospitalist continue their conversation about what the plans of care are, what kind of medications Michael was on, what kind of medications they think they're going to need, what kind of treatments they're looking at. The rehab team is going to be communicating with the rehab team at the hospital regarding what equipment that participant may need, what they have in place already, what kind of care they can be provided by our program, including home health aides, therapy, etc. The clinical care coordinator continues to have a conversation with the case manager, and all of the team is still having that conversation in the mornings about how Michael is progressing. And each and every day we have a conversation about what is going to be the plan, how are we going to provide the best option for him so that we can make sure that he gets the care he needs. Does that mean that Michael needs to go to a skilled nursing facility? Does that mean he needs to stay in the acute care setting for a little bit longer before we get into the right skilled nursing facility? Where are we going to have him be so that Mary is able to provide her engagement with Michael? So all of this is happening both at the hospital and then also at our program through our meetings. So once the acute care stay is nearing its end, what we're doing now is we're moving into a discharge. So a lot of times, especially with somebody who's had a new onset of a stroke, assuming that they weren't able to get TPN or the effects of the stroke were too great to be able to overcome just with an acute care stay, that person is more than likely going to go to a skilled nursing facility. In this case, Michael needs to go to our case is going to go to a skilled nursing facility. So again, the plan of care has been discussed multiple times throughout this process of the acute care stay while in the interdisciplinary team meetings. So our rehab team now is involved with the communication with the new skilled nursing or with the skilled nursing facility team. So we provide, as a rehab department, we provide an increased level of oversight with regards to the care in the skilled nursing facility. We're still professionally allowing the primary decision making and the care planning to go through the skilled nursing facilities nursing or rehab team. But when, again, because of our knowledge of Michael, because of our knowledge of Mary, because of our awareness of the home setting, all of that, we can help guide some of that, and we can give some guidance as to what the best options for goals of care will be. The clinical care coordinator then shifts their communication from hospital over to the skilled nursing facility. They're going to discuss things with the nurses. They're going to discuss things with the social workers, and they're going to help guide some of the, they're going to act as a liaison between the skilled nursing facilities, nursing staff, and the interdisciplinary team. Again, the physician is going to be in communication. So now that the participant is in the skilled nursing facility, the physician is now the primary decision maker on all of the medications and any of those decisions that are made for care. we also provide the medication. So we're going to be sending our pharmacists will be taking that medication to the skilled nursing facility to be able to provide that care. The social worker for the participant is also going to be in communication with the responsible party, Mary. This is so that Mary is aware of what's happening, and Mary is able to help make decisions and provide us with information about what she's going to be comfortable with, how she's feeling with regards to things. And also she'll be able to give us some information about possible help that she's going to be able to get from family members, neighbors, if she feels like she's going to need help with certain things. So all of this communication continues to happen all the way through the skilled nursing facility or skilled nursing stay. Our interdisciplinary team is going to continue to have these conversations every day about all of the progress. So as Michael is going through his nursing stay, the primary goal for the SNF is going to be to rehabilitate Michael to a level where he can get home. And then we're going to take over from there. The communication is constant. We have a process where our rehab team, specifically the physical therapists, contact the skilled nursing facilities therapists to engage with them so that that whole process of progress and guidance of the rehab process gives information both directions, so that as Michael progresses, we have a better idea of what kind of equipment that Michael is going to need, what kind of assistance he needs as far as transfers, and all of this, once again, is based on his rehabilitation through the stroke process. Again, the primary thing with this is our communication between the interdisciplinary teams of the skilled nursing facility and the IDT of the PACE program. Now we get into the nitty-gritty of the PACE involvement. We're going to become much more directly involved with Michael's discharge planning. So at the onset of the stroke, our team has been having constant conversations about Michael. The reason is because we're getting ready we're doing discharge planning throughout this whole process. We already have done home assessments, so we already know what the home setting is like, and we can kind of anticipate where Michael may need some assistance, and we can also anticipate where Mary might need some assistance or where we might need to put in some equipment. In the hospital, the progress, the IDT at the PACE program is there to help make the decisions about whether Michael is going to be best discharged to a SNF, to home, to a resident care facility, because we know Michael, we know the home setting, we know Mary, and the physical therapist and the occupational therapist and speech therapist at the hospital is only seeing a very small slice of Michael's life, and it's in this very critical time. So the IDT has a lot of effect on the disposition from the hospital, because we're able to say, well, Michael, this is his first stroke. He didn't have much of an effect, so we can actually care for him at home. He doesn't need to go to a skilled nursing facility. Yes, he has some memory issues now, but physically he's capable of doing everything. So therefore, Mary is going to be able to help him, and we can assist with some of the things like safety showers and stuff like that. So again, the interdisciplinary team approach and the all-inclusive care system allows us to make better discharge planning decisions. This carries on through the skilled nursing facility as well. And as we progress, we're going to make plans at his discharge from the skilled nursing facility so that we can have our therapy team, we can have our home health nurses, we can have our aides, our physical aides, so the personal care aides, ready to go, and have a plan in place so that all of this is in place before Michael even leaves the skilled nursing facility, so that we can make sure that Michael is successful when he discharges home, and so that Mary is successful in being able to provide the care, and so that we have the best chance of actually making it a smooth process to get Michael home safely and get back to living. We also have then the opportunity to continue therapy with Michael. This is where the full IDT goes into engagement, because now we need to be able to get Michael to and from his home. So we're going to have transportation involved. We're going to have recreation involved, because when Michael is at the center, he's going to be engaging in activities throughout the day. We're going to have the chaplain involved, because she's going to be working through the changes in Mary and Michael's spiritual needs and their well-being. And all through this, the nursing team and the physician are going to be helping to coordinate this process. So the dietitian is going to be involved, because they're going to be providing the appropriate diet so that we can make sure that Michael is getting the nutrition he needs to be able to make gains with his therapy. The occupational therapist is going to be continuing to go into the home on a regular basis to make sure that the environment is safe, so that when he's doing his ADLs, he's safe. And if there's any need for assistance or any equipment, that's all in place. So now that Michael is home, we're going to continue to provide Mary support through education. So we're going to provide her education on how to do transfers, education on how to use equipment, education on how to provide queuing, anything and everything that Mary may need to be successful, and for Michael to be successful, we're gonna provide that. The great thing about the all-inclusive program is that we are able to provide all of that as a part of the program, and we're able to provide it in a seamless fashion. And again, we're going to have home care, we're going to have home health, we're going to have a chaplain. Everybody is involved, because all of these factors play into the success of Michael and Mary from here on through the program. So our social worker is going to be in contact with Mary regarding her needs. The social worker is going to help with any of the financial aspects, because if Michael is now fully disabled, there's going to be a factor there. This may affect his compensations. Physical therapy is going to be doing their exercises. They can possibly do those in the home. They can bring Michael into the adult day health center to be able to do therapy. All of these things are going to be continued to be provided, because it is, once again, an all-inclusive package. The occupational therapist is going to engage with a with assistive equipment, with environmental modifications as Michael improves, or if he stays at the same level. And eventually, as Michael gets older with this stroke, in 2 or 3 years, he may need new equipment. So we're going to be providing that. Myself, I've actually gotten the Swallow training, so we can cover for speech therapy, so I can actually provide continued education and training to be able to help Michael improve with that. So that's all part of the stroke rehabilitation. So what we're also going to do is we're going to continue to follow with the the physician's going to continue to follow to make sure that medications are in order. And the other thing with our program and with an all-inclusive program is that we also can provide care outside of the home. So in the instance of somebody who isn't able to bathe at their home, our all-inclusive program would actually be able to provide them with bathing assistance, so that we actually have showers in the facility. And again, this is part of the all-inclusive program with regards to stroke rehabilitation, because then as Michael improves and we're able to get Michael safer with therapy or with transfers and with bathing, eventually he will be able to go back to, we hope that he'll be able to go back to bathing at home again. So the primary aspect of our program is the continuum of care. Our IDT follows our participants from the beginning of them joining the program all the way through till when they pass away. If they need therapy throughout that on some level, from physical therapy, occupational therapy, or whatever, we're going to be able to provide that because it's part of a continuum. That will be changed as the needs change. And if Michael needs to continue to do a level of maintenance, we have a way to be able to provide that as well. We have restorative aids to be able to provide that. Throughout this whole time that Michael is in our program, we're going to be adjusting and making the necessary changes to be able to provide the care that is best for him. So that's all I had with regards to that. So I hope I didn't make anybody fall asleep.
Thank you, sir.
You're welcome. Thank you.
It was a nice presentation, sir. We have some questions for you.
Okay.
What do you think is the chief role of an occupational therapist after discharging from home?
So our primary goal in occupational therapy with after discharge is to improve the ADLs, the activities of daily living, either through environmental modifications and recommendations, or through working side by side with the physical therapists to improve the physical capacity of the participant. We may do some adjunct exercises to be able to help. We may provide some level of fine motor skill activities. And we also may do exercises with assistive equipment and some occupation-based activities as well. So an example that I've used in the past is if a physical therapist is needing to work on balance, we may have our participants standing in a kitchen doing reaching exercises so that they're extending outside of their base of support. That way they're focused more on the activity and less on the exercises.
Okay. The next question is, how does an occupational therapist work with a physiotherapist to improve functional rehabilitation of a patient post-stroke?
Our primary goal post-stroke with occupational therapy and physical therapy, when I was in skilled nursing, it was a little different. We were focused on reaching and doing a lot of upper body stuff and focusing on modifications to the techniques for doing things like dressing and toileting. In our program, a lot of the rehab that we do as occupational therapists alongside physical therapists is in providing the equipment in the home that allows the participant to be able to safely do transfers. That would be like transfer poles and grab bars and recommendations for ramps so that they are able to engage while the physical therapist is working on their physical ability to do the transfers. So it's kind of a hand-in-hand method that way.
Okay.
So, Dr. Eric, it's a very nice talk.
Thank you very much.
Yeah, happy to meet you on this platform, and really it was a overwhelming presentation. From my side, I just wanted to know, like, how do you physiotherapy, physical therapist and occupational therapist will work togetherly at your setup, working setup? How do you take up the responsibilities?
So the way that we don't separate things really precisely in our program, again, because of the fact that it's a continuum of care, we're able to provide care that somewhat overlaps. Since we're not billing for our services directly, we're not fee for service, we have the ability to do tandem treatment so that we're able to focus on things as a team and not worry about having a direct effect on the other's billing. A lot of times what we're doing is working side by side, making decisions about equipment. We're making decisions about how to do the exercises. We'll do the exercises together so that one person is able to do something like a postural support while the other is doing some type of a neuro rehab, like you were talking about with Bobath. What it does is it allows us to be two hands in the activity instead of just being exclusive to each other. So we're able to support each other much better. And it's one of the things that I really most enjoy about the all-inclusive format that we have.
Okay, it's very nice explanation. So we feel in India that some of the skills it overlaps with occupational therapist.
Mhm.
So in future, I feel that we should develop clear borderlines from which we can start occupational therapy, and furthermore follow-up will be definitely taken care, so that we'll have a clear demarcations and the responsibilities and the duties that we are going to execute with the patient. That is what I feel we all physical therapists and occupational therapists should work on at different levels. So
Yes.
this is my just out of my experience, I wanted to say that is the area we should work out. This is the role of a physiotherapist, followed by, this will be continued by occupational therapist, to complete the full rehabilitation of that particular affected patient. This is how we should work, I feel, to develop an harmony at the working atmosphere. What do you think about Dr. Harry?
I think that occupational therapy definitely is working very hard to differentiate themselves on a lot of levels. And we do actually have areas of demarcation with regards to, my focus is with occupation-based activities. I really do work hard to try and do my rehabilitation based on, is this something that is a functional activity? It's not, I try to avoid a lot of the exercises. I know that the physical therapists really focus on the strengthening, and it's a very, very strong focus, and it's very necessary for the whole process. As an occupational therapist, my viewpoint is coming from the end of, how can I engage this person in their occupation so that we can get them back to doing this on a normal basis, now that the physical therapist has actually gotten the strength and the neuroplasticity engaged? How do we then incorporate that into a functional activity? So yeah, I definitely think that, we differentiate in the United States. In our program and our continuum of care, it allows us to be able to work together better, so that we're able to more effectively accomplish it without having to worry about, am I doing an exercise that the physical therapist should be doing, or should I can't do that exercise because that would be what the physical therapist does. I can do that one as well, but still differentiate what I'm doing as my goals.
Okay, thank you. Thank you.
Thank you.
Over to you, Dr. Trupti.
Thank you, sir. We have one more question for you, Dr. Eric.
Yes.
Yeah. What outcome measures do you use for upper limb impairments and stroke majorly?
From an occupational therapy standpoint, my primary markers are functional independence. Is somebody able to put on their shirt independently? Are they needing equipment to do that? How much assistance do they need with brushing their teeth? How much assistance do they need with being able to do the full toileting activity? Are they able to clean themselves afterwards? Are they able to get on and off the toilet on their own in the United States? Are they able to undress themselves so that they can do that? Are they able to get in and out of the shower? So we look at all of the functional process of the activities and look at each one of those points. And when we're talking about stroke rehab, a lot of times the hemiplegia has an effect on how they're going to be getting dressed, how their balance is when they're trying to do things like toileting, how they're able to eat, how they're able to swallow, how they're able to, their awareness of the sequencing with regards to getting dressed. All of those different factors, but our primary markers of progress are the end result of their independence with each of their ADLs.
Thank you so much. I express my gratitude on behalf of Knospe organizing team to you for cooperating with the timings that are tonight, and this is a day over here. So I thank you very much for being awake and giving your presentation, sir. And surely we'll look after the integration between the physiotherapist and the occupational therapist. Thank you so much.
Thank you very much, Dr. Eric.
Thank you very much. Thank you. You have a good day.
Yeah. Good. So we shall begin with the next presentation. We have with us the next international speaker from the nursing faculty, Mr. Rajiv Krishnametri.
Can you hear me or can you see me?
Yes, sir, we can see.
Hello. Good
Warm
morning.
welcome to you, sir.
Namaste and good morning.
Warm welcome to you.
Thank you, sir. Thank you very much.
So we'll begin with a short introduction of Sir. Mr. Rajiv Krishnametri, originally from Belgavi, Karnataka, India, has settled in UK since 19 years. He is a senior nurse, CCU, and primary PCI coordinator at NHS Trust, United Kingdom. He has done his nursing graduation from Cayley's College of Nursing, Belgium, and has worked as teaching faculty and management areas in various institutions. He has worked as medical device training officer and member of National Association of Medical Device Educator and Trainers. He has worked primary, secondary, and tertiary centers as secretary of International Nursing Conference and has successfully conducted at KLES Institute of Nursing Sciences at Belgium. He has been a chair for various panel discussions in international levels of nursing conference. He has done diploma in non-invasive ventilation at Liverpool, United Kingdoms, even coronary care course at North Wales, United Kingdoms, advanced life support courses, mentorship courses, and medical management courses at the United Kingdoms. We are grateful to have you, sir, for today's presentation.
Thank you, madam. Thank you, sir, and thank you all the team for inviting me for this wonderful international conference, and I really appreciate your effort and thank you once again. So I'll just share my initially, first of all, I need to apologize. This technology, once it fails, it's very hard to cope with this. My system got corrupted and I managed, and I apologize to Trupti madam as well. Is there a, you can share the screens, madam?
Sir, down there is an option of share screen. You can click on that. Your screen will be visible.
Okay. Can you see it now?
Yes, sir.
Okay.
Yeah.
Is it quite bigger screen now?
Yes, sir, it is visible.
Okay, yeah. I don't see myself, so apologies. Good morning, everyone, and some of the countries maybe good afternoons, and it's here 7 o'clock in the morning. So today I'm going to talk about mostly with the multidisciplinary approach to stroke management, and esteemed speakers already, Dr. Sase and Dr. Varadarajulu and Eric, they have spoken wonderfully, and they've given you all the background and everything about the stroke. And so I'm mostly, as my background with the nurse and working with the thrombolysis and the primary PCI with the cardiac and the stroke is one of the biggest thing in United Kingdom, and they're working hand in hand because we are making aware of to the people that it just the heart attack means everybody gets scared, and stroke means not many people, only the families and the closest families and the relatives or friends, they get affected rather than the whole community. So we are using the word like a brain attack as well for this. So on an average, as we all know, every 3 to 4 minutes someone dies of a stroke, and it is a huge number, and people need to be made aware, and lot of deaths or the mortality can be uh, reduced. And obviously we know the definitions. I'm not going to go with that one. It's a decreased blood supply to the brain or the sudden loss of the functions, and which disrupt the brain function, and that will affect the person. And obviously stroke, it's a clinical diagnosis, and most of the important thing is when the patient has the symptoms, which we go with the facial and like a speech and any kind of limbs or any um, activities or altered in the sensation or alteration in their memory, and they need to be immediately, informed. And so before we go to the hospital setup, when we are in the community, most important thing, we make aware people that about the clinical symptoms or the signs of the symptoms for the patient. So because time is very, very important here. And once they arrive from the community area to the hospital, and the history must be noted immediately, and the examinations. And when you're doing and when you're discussing or talking with the families of the patient, then it's very important to find about their risk factors. And most of the patients in our United Kingdom are high risk because of the smoking is one of the thing. And the diet is the next one because of the intake of the salt, and which can cause a high blood pressure. And this high blood pressure obviously lead into this kind of conditions. And as a nurse, when the patient's arriving to the hospital, our most important responsibility is to make sure the patient is comfortable, and monitor their vital signs very regularly. Apology for this spelling mistake. And the next one is about the heart rate. Monitoring heart rate is also very, very important factor. And then ECG is also one of the tests we do at that time. And a lot of people we forget to do is the respiratory rate. And I think most of the areas doesn't have a monitor or the machines to monitor the respiratory rate. And because of that, respiratory rate is forgotten to record and forgotten to monitor. And but the early signs which we see as a nurse or any medical team or a multidisciplinary team is the respiration. And because the respiration is forgotten, and the respiration can indicate you, and we have a system called early warning system. And early warning system is most important. We give the importance is for the respiration, because respirations can be done without any machines. We can just look at the patients, and it just approach to the patient is very, very important here. So they can just hold the patient's hand, and or just observe the chest movement up and down, and then you can just monitor it. And that increase in the respiratory rate itself will give the one is patient how discomfort is the patient, and the second one is what the other signs, other vitals are going higher or lower. So that's why it's very, very important to always trust, even from everyone, keep monitor on the respiratory rate. And then comes the oxygen saturation. And obviously we need to maintain the temperature and the blood glucose level. So we will go with the systematic approach. It's called A, B, C, D, E, like airway, breathing, circulation, and then we go to the disability, and then the environmental check, like, just check the patient surrounding and all. And with our stroke patients, coming back to this one, as a nurse, we have a stroke rehabilitation team and the stroke assessment team. And when the patient comes to the hospital, or basically either it will be first they call the ambulance. When they call the ambulance from the community, and the ambulance team has got a system to contact us directly via the hospital switchboard. And the stroke nurses will have a bleep system, and they will carry the bleep, and they are 24/7 on call. And then through the switchboard, this is escalated to the stroke nurse, and stroke nurse is aware that this patient is going to come to us, and we are ready waiting for the patient to receive in emergency department or A&E department we call. And once the patient is arrived, as a nurse, as a bleep holder, we have a protocol to follow, and we just follow the protocol. I'll go by one by one later on. And once the patient is here, our target time is CT. For the CT in the acute stroke is less than 20 minutes, and we try to achieve that one ASAP. And because there are centers where are in India and in some of the areas here as well in the community hospitals, that we don't have a CT scan machine. So make sure that there is a CT scan machine available and it is free to use it. And also, it's just not about the availability and the free, it's also important there is a person to do the CT scan as well. Because of the staff shortage and everything, these are very, very important. They look very simple, but these are very important because the time is very, very important. That's why it says, when stroke strikes, how fast is enough. That's why time is a very, very precious factor here. And then once the CT is done, and within that time, what we do is we have discussed with the consultant or on-call doctors, we'll discuss with the families, we discuss with the multidisciplinary team, which I was telling you before. And then that's a multidisciplinary team includes first one is a solo assessment team, and then second one is occupational therapist, and most important, the person during that time is a physiotherapist, because they need to come and they see the patient, and the assessment is done, and then we can plan for the treatment, plan for the care for the patient ASAP. And the most of the other factors involved is about the continence, and because of the control the cranial nerves, the blood, the bowel and the bladder, the patients lose the control on them, and most of the patients will be incontinent. And as a nurse, it is very important one is maintaining the dignity is very, very important in this factor. And a lot of patients will be not very comfortable to tell us, and in a lot of cases, they are not in a position to know what they are doing and what is happening. So it is very, very important as a nurse role that think about all these and just approach with the patient, approach to the patient, and think of all the problems what they might be arriving. And it's a very, very important, is the reassurance is very important at that time, and the reassuring and supporting the patient and the families is very important. And ECG and all, we can do it later on, and if it is any necessary, because as a cardiac nurse we see a lot of atrial fibrillations and things, and whether this stroke is because of the atrial fibrillation, or is there any other risk factors or any other reason why the stroke has happened, then we can treat on that one. And we have a very close monitoring, and this rate of the patients with the stroke and the atrial fibrillation is come down very drastically in United Kingdom because of a lot of advanced technologies, studies, and a lot of research work has been done, and because of which the AF causing the stroke is really coming down. And again, this one is, as I was just saying, as when the patient comes to the A&E, most of the time the paramedics team will have a cannula, which is a cannula or a branula or Venflon. You call it a different names. So it is IV access. So this IV access is very important at that time patient, because when the patient's body, when it is dehydrated, or it is very difficult to get the IV access, because when you want to give these medications, it's very important. And when we do the cannula, or when you put the IV access, make sure you take the blood, all the blood, you take it straight away, because that includes all the investigations, FBC, kidney functions, liver functions, and if you want the blood glucose randomly or the cholesterol levels. So everything we send it in at the same time. And we get our blood results within like some of them machines are like faster. We get it within 15 to 30 minutes, and some of them it takes 1 or 2 hours. So the time is very important, but most important things are here we look for is bleeding and clotting time or a coag screen. So coagulation screen is very important because if we're going to go ahead with the thrombolysis, we need to know the one is patient INR status, whether they're on warfarin or any NOAC, and whether the patient is any risk factors for the bleeding. And that's why it's very important to know about the coagulation screen. And also hemoglobin is another factor. When the patient's hemoglobin is very, very lower, that doesn't mean that we can't give the TPA, but it's very important to monitor that patients closely and support it and just treat that one. Then when the patient is you got a bleep, the patient's arrival, before the patient is arrived, so you make sure that you call for help, or you got a colleagues, or you got a team, so you invite them or inform them and what is going to happen next. And obviously you liaise with the team. And then porters are also important. In India, we call it as a ward boys or IMRs and things. But here we give very, very much importance for the porters because they are the one who are going to help us with the transporting the patients from one place to another patient. But we have a very less number of porters in the hospitals, and they are busy with some other thing. That doesn't mean that we can't do it. So whether it's a doctor, whether it's a consultant, whether it's a nurse, so irrespective of our job role, because we are working with the patient centered. Because of that, even we have, if the consultant is there, we'll just tell them, sir, can you push this bed? And we need to take this patient ASAP to the stroke unit or the CCU for thrombolysis, because time is very, very important. And during that time, nobody will say no to us, and they will definitely help us. And because they don't go with the status, no, I am a doctor, why should I push the bed? And these are the things we need to be aware, because it's a teamwork. It is not just one person we can do it. And like as I said before, inform the CT and make sure it's all ready there and it's working, because sometimes if it is a night time and all, the CT needs a little bit of time to warm up the the system, and then they need little time. So as soon as we hear the bleep, we just inform them and we just get it everything ready. And then our teams are so good, like some of our junior nurses and all on the ward, when we have a bleep, they keep all the medications, trolley, trays, everything ready. And this is really good. And that saves a lot of time, a lot of confusion and things. And once the patients arrive to the unit after the CT scan and everything, then obviously, the on-call doctors will be with us, and we'll go with the plans. And as a stroke nurses, we have a nurse prescribing roles. So as a nurse prescribers, we can prescribe the medications and do all the admissions work and everything. And we do have another role as a nurses. We got somebody called as a physician assistants, and the physician assistants are also like we call as a registrars of the junior doctors, or like associate doctors they call. And then most important is the hydration for the patient here. And because we don't know when the patient had last meal, when the patient had last drink, and some patients will go into the dehydration status, and which can affect very badly with their health. And that's why it's very important. Hydration is very important. And during that time, if the patient is unable to swallow, and if you're not expert to do the swallow assessment test, inform the speech and language therapist. That's a SALT we call here. And speech and language therapists are always available, or if they're out of hours, they're on call. So we bleep them and take their advice. But most of the nurses, whether it's a junior or whether it's a senior or whether it is any educational team or anybody, most of them have got an assessment for the swallow therapy or a swallow assessment screen. And so it is very simple to do it. Just take a little bit of plastic spoon, or and then just give one couple of drops of water on the tongue, and then the patient will be able to, you can see whether the swallowing is happening or not. Then you just feel it, assess it, and you make a decision at that time. And if they're unable to swallow, and if they're difficult or anything, and please do not push it. And if you're not expert, or if you don't know, please say that I don't know about this, I need to know, I need to learn, or I need to experts to come and see these patients. Because if the patient is unable to swallow, if they lose the control, then it can cause like aspiration pneumonia and things, and that can take weeks and weeks or months and months to recover. And that's why SALT assessment from the experts and or the speech and language therapist is very, very important. And then comes the physio assessment and physiotherapy team. We got a 24/7 on call again, and the team is always available and very supportive. And especially for the stroke team, they're always there. And it is they come and do the assessment in the beginning itself, and then they follow up on within 24 hours again. Once or twice they will come, and after the 24 hours they do the regular follow-up with their rotas. And they will try and mobilize that patient, I think ASAP. And that's because, before, if you think, like the same with the heart attack and the stroke, if you think before, when somebody has a heart attack, then they used to keep them on the bed weeks and weeks. And but now we have a heart attack patient, and they come to the hospitals and have an angiogram, and then they will just get discharged on the same day with the radial artery approach. And or some people will go home on the next day after having the stents. And if they have a bypass operations and all, then probably a week or 15 days they will be in the hospital, depending on the recovery, and they will be at home after 2 weeks. So this is how fast the treatment plans are happening. This is the reason even the stroke, a lot of people used to say, Dr. Varadharajulu sir was just saying before, like how the people think about the stroke. It is not anything, we have done something wrong or anything, but it is a brain attack. So that's why it is very important that, we need to give them the psychological support along with the physiotherapy exercise, because once the muscles lose a tone, it is very difficult to recover, and it takes a very, very long time to recover. And that's why the early physiotherapy and encouraging the exercise is very, very important. And then comes the role of the dietitian. So dietitian is again, what the patient needs, like sometimes they will have a low protein in the body. So depending on the blood pictures, you can increase a high protein diet. And according to that, you can treat the patient. And, there are vegetarians, non-vegetarians, vegans, and so a lot of kind of our variety of diet is available in the market or in the hospital set up here, and we refer them according to that, and it's then they will be treated according to that. And a lot of patients we know, it's like a salt restrictions is very, very important here. And again, if a lot of our patients here are like a mildly or moderately or highly obese patients, and this is the reason dietitian role comes in very, very important here. And then the pharmacist, obviously, the pharmacist and the occupational therapist, and Eric sir was just saying about the occupational therapy. And in that occupational therapy, when it comes to the stroke rehabilitation, it's very, very important that we need a support from the family, because without that it is very difficult. And if there is some people, they don't have any families or friends or anyone, and they are elderly, and or they live abroad and they're that far, like how we are living and parents are back home. So similar that way, in that case, we have a stroke rehabilitation centers or a care homes or nursing homes we call, but they are specialized in the stroke. And during that time, till they regain their strength, regain their energy, and come back to their normal routines, we send them to the community hospitals or the stroke rehabilitation centers. and then will be treated there. And the occupational therapist role is a very, very vital, because some patients may go home, and these patients may need a long-term wheelchair, or maybe the short-term wheelchair dependent. And because of the limbs and all, because they're unable to get out of the hospital house, and because of which some people are staying upstairs, and they don't have any other, like a wheelchair or like a stair lift or anything to come down. And these are very important. The occupational therapist, our team, will visit their areas of the house. They go and do the assessment, and according to that, they will do the changes, and everything will be supported with our NHS fundings here in UK. And then depending on the person's income status as well, so financial status, and then everything will be supported, and then everything will be done. And once it is done, they will inform us or wherever the patient is. And because sometimes you need to push the wheelchair, and there are a couple of steps to get into the house. So in that time, they need to be assessed and everything. And especially again, hygienic needs, when they need to have a bath and everything, the bath needs to be safer as well, because a lot of patients go into the bath and they slip, and they don't have anywhere to hold, and then they will have a head injury, and they may die. And these can be prevented with the assessment of the occupational therapist when they go on assessment in the house and everything. So again, these are basically, we got it from the Royal College. We follow the guidelines from the Royal College of Physicians on the stroke. And if anybody wants, they can go for the referral. We do have a nice guidelines, and we follow the nice guidelines as well. And again, we have a Nursing and Midwifery Council UK, or NMC UK. You can just Google it. And in that, we have a stroke program. And that's my short and simple presentation. And if you have any questions or anything, please let me know. And once again, it's a sincere apologies, because my original presentation was disappeared. So I just managed to get this one done. And I'm very much happy to discuss more rather than one-way teaching. And if you have any questions, I'm happy to take questions for now.
Thank you very much, sir.
Thank you, sir.
Really, indeed, a very contributory presentation of your today's. Actually, we were also very happy that your nurse thinking in line with the neurologist.
Sir, can you repeat again?
This part of the region of the country, it is really it's a worthy message out of your presentation to all the staff nurses, even to physiotherapists who are working with in various levels of stroke management. Actually, my suggestion always, in case of staff nurse with whom we are working in our hospital, in our tertiary care hospital, which is a Krishna hospital, which is a 1125 bedded hospital, where we have more than 100 ICU, and nearly every day there will be a 10 to 12, 10 to 15 stroke patients used to be there in our hospital, and they are in our hospital. So we work with staff nurses. Our expectation from the staff nurse in the stroke ICU is that they should, like how I was telling about the importance of positioning and important of the their maintenance, their vital parameters, monitoring the vital parameters. And we feel that in our nursing curriculum also, some of the areas, this knowledge of normal positioning as per the requirement of physiotherapist should be incorporated in your academic so that will become a standard operating procedures for an ICU staff nurse when they are working as a core member. That is what I feel whenever I go with and work with our own setup. Because we tell them, sister or brother, this is how the patient need to be positioned. This is what is important. I practically feel that I think they will not be that much practically proven effective by just simply by saying this. But when you mandate it to learn in your curriculum and then to follow, I think that will become an important area of, and giving more importance as far as the stroke rehabilitation is concerned.
Yeah, because we have various devices we use for the positioning of the patients. Like, if they're on the bed bound, it's very important to use the slide sheets, because of the repositioning, so that we can prevent the friction on the skin, because skin is very, very fragile. And to prevent the friction on the skin, we use slide sheets. And second thing is, when the patient is ready to come out of the bed, the first and most important assessment will be done by the physiotherapist in our hospitals. And I mean, everywhere here in UK, the same thing, because with the physiotherapist and the nurses together, make sure the patient is able to stand first, and then they encourage us. And once they're able to stand, or if they have upper limb strength, and we use the banana board, so which is like it's a shape of a banana, but it's bigger. And then you keep half on the bed and half on the chair where you're transferring, and they will slide slowly using the arm strength. And then they'll hold the side of the chair and then slowly slide there, which is very, very important. And if they have a strength on the feet, if they don't have a strength on the feet, we have like a little kind of rotator, which is like a little circle, which just twist it, and then they only stand and then switch it. Or we call it as a standing hoist. Then they can use. There are so many varieties of equipments available, and it's just not only having the equipment, but it's very important to train the person who is next to the patient, and the role of the physiotherapist is very, very vital in that aspect. So it's all together, like it is a teamwork. So it's rather than the one person. Yeah.
Thank you, sir. Thank you. Over to you, Dr. Trupti.
Thank you, sir.
Thank you, sir. Your presentation was really very nice, sir. And you managed it very well in spite of the technological failure, sir.
Thank you, madam. Yeah.
So there is one question for you. In case of the immediate therapy after when the stroke is the patient gets a stroke, when they give a tissue plasminogen activator, what is advisable? Do you advisable the patient to remain bedridden in the bed, or to mobilate, and how the impairments can be reduced by this?
You mean TPA infusion? I didn't get the question actually. How the?
So in case when they give the tissue plasminogen activators, that is the crucial phase after the patient gets stroke. So what do you feel that does the patient has to be immobilized, or the patient has to get mobilized after the therapy?
I mean, during the therapy, they have to be on the bed anyway. So because, and we don't know, we haven't got the complete picture of the patient's assessment and everything. And, like the first 10% will be given bolus, and the next 90% will be given on the infusion over an hour. So during that time, definitely the patient needs to be, monitored very closely, because of the blood pressure and everything. And then depending on the assessment, the patient needs to be mobilized and all. It's all depending on the patient's condition at that time. And if the blood pressure is very high, extremely high, you cannot take a risk at that time in the beginning. But early mobilization is very important. But that doesn't mean that, during the infusion or anything, we cannot mobilize the patient. And we haven't gone up to that high standard yet, I think we hear. So that probably need to be considered, and we need to do some research work on it. Or I can ask the sir, Varadharajulu sir is expert in this. So maybe he can contribute something on that.
When as per the physician's advice, we are supposed to follow in the ICU, and absolutely once the acute care management is perfectly done, then only the mobilization of the patient, everything has to be done, because till that time he will not be indicated for physiotherapy at all.
Yeah.
Okay. So the next question for you goes, how in your place in the UK, How do you integrate yourself between nursing fraternity and the physiotherapist? How it goes hand in hand?
We got a very good relationship between the nursing faculty and physiotherapist, and we have different teams in the physiotherapist, like a ICU physiotherapist, stroke physiotherapist, and the cardiac or like a respiratory physiotherapist. They are all specialized into their team. But when it comes as an emergency, irrespective of what specialty they are, like I am a nurse, I'll just go and do anything. And the same way, the physiotherapist, they're physiotherapists. They don't stand back and say, oh, no, I'm an intensive care physiotherapist. I don't come and do it here. So they don't do that, because as long as they're within that boundaries or within their roles and the responsibilities, they all work together here. And that makes a big difference and huge difference for the patient's recovery. And everybody, one most important thing is the health team understand in United Kingdom or most of the developed countries is that patient is a centered person, and we all are here to help the patients. And because nobody thinks that I'm helping this nurse, and nobody thinks I'm helping this doctor, nobody thinks in that way, because our focus is a patient centered. And whoever is contributing, pharmacist, OT, physiotherapist, dietitian, nutritional, community nurse, everybody's focus is on that patient. And because of that, I personally seen that difference here, and we follow that guidelines. And because of our boundaries are so much so tight, so we need to work under that. Because the litigation, when it comes to the litigation, it is a very, very dangerous thing here. Because if as an Indian nurse background, if I look at that, and I personally think, because I'm talking about 20 years ago, but not, no, it might have changed now. But what I was talking about 10, 15 years ago, we haven't had a role driven by the medical team or the doctors or the consultants. And they will, no, I have told you, you do this. You don't need to do that. Who asked you to do that? This is how the most of the medical teams are controlled. But here, if somebody tells you something, whether it's a consultant or whether it's a nurse, or the pharmacist, no, I'm a pharmacist, you do this one. And if you are a nurse, and if you're a nurse prescriber, then if you say, no, I'm not happy to give this patient aspirin, and because there is a high risk of bleeding and things, and you can argue here, but it's not argument between the persons, it's argument for the benefit of the patients. That we understand very, very clearly. But in back home, I think the hierarchy comes, and when they say, I am a boss, I'm telling you, you follow this. Because here we work as a leaders, not as a boss. And that's why patient center is very, very important and the most important thing. And that helps a lot and hugely in the patient's recovery and helping the community. And I think I answered that question. Yeah.
Yes.
Thank you.
Thank you so much, sir, for your presentation. It was indeed very great, sir. Heartfelt thanks from the organizing committee of NOX 2020. Thank you, sir.
Okay. Thank you, madam. Thank you very much. Jai Maharashtra and Jai Hind. Thank you. Namaste.
We shall begin with the next session. Dr. Abhijit Shelke is here to speak on chronic heart failure. I hand over the session to Dr. Poonam Patil.
Warm welcome to Dr. Abhijit sir for this session.
Am I audible?
Yes, sir. Yes, sir.
Yes, sir.
Good.
Thank you, Dr. Trupti. Good afternoon, sir. I take privilege to welcome the speaker from this session, Dr. Abhijit Shelke. She has completed MBBS from Krishna Institute of Medical Science, Karad, in 2002, MD Medicine, Grant Medical College, Mumbai in 2006, DNB Cardiology and Fellowship in Cardio Electrophysiology in Care Hospital, Hyderabad, 2012. We welcome you, sir. You can, and currently he is working as Associate Professor in Cardiology in Krishna Institute of Medical Science, deemed to be University, Karad. You can start with your session, sir.
Thank you. Am I audible?
Yes, sir.
Yeah. So thanks for kind words. First of all, I thank organizing committee for giving me this opportunity Today I'm going to talk about chronic heart failure. Now this is very, I'm going to start with a few cases, two cases. All of us know that heart failure incidence is going. The more and more patients are coming with the symptoms of heart failure. Now this is a first case scenario. This is a case of 72-year male. He had a past history of myocardial infarction 7 years ago. He underwent bypass surgery because he had a bad triple vessel disease. And then 2 years ago, he was admitted with a breathing difficulty. He had a pedal swelling, typical symptoms of heart failure. And then his ejection fraction that time was 35 to 40%. He was improved with the heart failure therapy and he was discharged and he was doing well with the medications. 6 months ago, again, he came with a worsening of the symptoms of heart failure and he had documented 2 episodes of syncope due to ventricular tachycardia. You can see the ECG here showing a ventricular tachycardia, and this was the ECG at the rest when he had because of myocardial infarction, he has old QRs in the chest leads. Now he was evaluated again, and this time his ejection fraction was 30%. Clinically, he was in a heart failure. There were classical symptom signs of the heart failure like the red JVT, pedal edema, hepatic congestion. Echo showed ejection fraction of 30%. Distal part is damaged. The red color, what you are seeing is a damaged part of the heart, which is not contracting. And this patient was titrated with the medications. A titration of the medications was done because he had a ventricular tachycardia, documented ventricular tachycardia with the syncope. We had to put a ICD. ICD is intracardiac defibrillator or implantable cardioverter defibrillator. This actually was combined with CRT. CRT means cardiac resynchronization therapy because his ejection fraction was very low. ECG was showing wide QRS. We put we implanted CRTD in this patient. So CRTD means cardiac resynchronization therapy with implantable cardioverter defibrillator. This device will give shock whenever patient develops ventricular tachycardia. Obviously, we have to give the drugs to prevent the ventricular tachycardia in these patients, mainly beta blocker, amiodarone. But despite these drugs, these patients can throw hemodynamically unstable ventricular tachycardia and they can have a sudden cardiac death. So to prevent sudden cardiac death, we put a ICD and CRT component to improve the synchronization of the ventricular walls. We put a CRT. So just to tell you how this patient was presented and how ultimately he got a CRTD. Now, at least on CRTD, he is doing well. He's regularly following, at least symptoms are under control. And he never had another episode of VT. Now, another case scenario, 45-year female, young female presented with heart failure symptoms, classical heart failure symptoms with the ECG changes. ECG showed LBBB. Actually, this patient was referred for the CRT because LBBB ECG with heart failure is a typical indication for CRT, cardiac resynchronization therapy, or we call as triple chamber pacemaker. But we evaluated her in detail and then we realized that her cardiac MRI is showing some fibrosis. We had a doubt that she is having probably inflammatory cardiomyopathy. So we did PET scan. PET scan showed the cardiac inflammation, which you can see yellow color, whatever uptake is the FDG uptake. That indicates the tissues are actively, the metabolic activity is high. These are the inflamed tissues. So whole myocardium is inflamed. And then we did an endomyocardial biopsy and it proven to be a cardiac sarcoidosis. We treated with the steroid and after 3 or 4 months of the steroid, patient clinically improved. Her ECG also became narrow and clinically, even in fact, ejection fraction also improved to 50 plus. So in these two case scenarios, what I want to enforce is that always try to find out the reversible cause of heart failure in case like a case 2. If suppose case 2 was diagnosed very late when the inflammation causes fibrosis and scarring and permanent LV dysfunction, patient will go into the permanent heart failure and then the problems of chronic heart failure. Scenario one, especially, that is the commonest scenario whenever patient develops myocardial infarction, damaged heart, and over a period because of neuroremodulation, the LV dysfunction deteriorates and the patient presents with a progressive heart failure. So to define heart failure, what is a heart failure? Heart failure is a complex clinical syndrome where all organs are involved because the heart failure causes decreased cardiac output and every organ receives less cardiac output that results from structural or functional impairment of ventricular filling or ejection of blood. Structural means like a case number one where we had a damaged heart because of myocardial infarction that is going to be a permanent, that is not going to recover. And functional impairment like a second case where because of inflammation, or cases like a tachycardiomyopathy where the once you treat an inflammation or once you correct the rhythm, the functional recovery happens or LV function improves. And the problem of feeling means diastolic dysfunction. Heart has a left ventricle has a two functions. One is a pumping where the blood is ejected from the left ventricle into the systemic circulation, and second is receiving the blood from the atria, that is a feeling. So if there is a problem of feeling like a stiffness of the heart, that itself will cause pulmonary congestion because heart is not ready to receive the blood from the left atrium that will transmit the pressure to the pulmonary vasculatures, or ejection of blood where the heart pumping is down, so heart cannot pump effectively into the systemic circulation. So any of the problem will cause heart failure. If there is a problem of ejection of blood, we call this as a heart failure with a reduced ejection fraction or systolic heart failure. And if the problem of feeling or diastole, we call this as a diastolic heart failure or heart failure with a normal ejection fraction. We prefer heart failure over a congestive heart failure. Congestive heart failure means nothing but a frank right heart failure where the pedal edema, JVP, raised JVP, ascites are there. But scientifically, heart failure is a preferred over the congestive heart failure. Now, heart failure mainly happens because of because to the damage to the myocardium. So, myocardial damage can happen because of coronary artery disease, where patient will develop myocardial infarction because of 100% occlusion of vessel. If the coronary vessel occludes 100% in a short span, the receiving myocardium, the myocardium will not receive the blood supply. If the blood supply is not restored within 6 hours, there will be permanent damage to the myocardium. So the commonest cause of myocardial damage is myocardial infarction. Second commonest cause is inflammation or infection like a viral myocarditis. Other rare causes like infiltrative diseases like amyloidosis can cause myocardial damage. So commonest cause of heart failure is the damage to the myocardial muscles. Heart failure can happen even without damaging the myocardium because of pericardial diseases like a chronic constrictive pericarditis, especially tuberculosis, will cause thickness of the pericardium and it will become like a pericardium is usually a elastic material, but because of inflammation and chronic infection, that will cause like a rigid bottle and that will cause resistance to the filling and diastolic heart failure. Diseases like valvular heart disease, like mitral regurgitation, aortic regurgitation will cause heart failure because the valve will allow the forward flow. Because of leakage, the blood flow will go to the back chamber and it will cause decreased cardiac output and heart failure symptoms. Even electric system also can cause heart failure because of tachycardiomyopathy. If the patient develops a recurrent ventricular tachycardia or recurrent VPCs, ventricular premature ectopics, the burden if suppose more than 20 to 30% of VPC, or even atrial fibrillation with a high ventricular rate persistently, that causes tachycardiomyopathy. But if you control the rhythm, that tachycardiomyopathy is reversible. Heart failure incidence and prevalence is increasing. In all countries, heart failure is one of the most frequent problem and number of heart failure patient is rising. At present, there are approximately 64 million heart patients in the world. Once heart failure is diagnosed, the patient may stabilize with the medical therapy, but in future he develops acute events, and with every acute event, his LV function deteriorates, and ultimately his functional capacity reduces. The first event can be acute or it can be subacute. That means patient can present with acute heart failure symptoms, especially like acute MI and LV dysfunction, or chronic symptoms or subacute symptoms, like in cases of viral myocarditis, where there will be LV dysfunction, and then because of remodeling of the heart, it will cause systolic heart failure, and they will present with a heart failure. The mortality is almost 50% after the 5 years. So once we diagnose the heart failure, 50% population die within 5 years. So heart failure prevalence is rising throughout the world. The reason for pandemic is aging of population, because the life span of population is improved. The aging itself is causing aging of the heart, and the population is developing diastolic heart failure. There are increasing risk factors like obesity, diabetes, and hypertension that ultimately leading to the high rate of heart disease. And obviously improved survival after myocardial infarction. If suppose patient develops myocardial infarction, heart gets damaged, but because of newer therapy he survives, ultimately he will land up into the heart failure. Fortunately, therapies are also emerging for the heart failure therapy, heart failure patients, and morbidity is improving. What are the risk factors for the heart failure? As I told you, cardiovascular disease risk factors, especially diabetes, hypertension, dyslipidemia, tobacco, smoking, obesity. These are the commonest CV factors, ultimately can cause myocardial damage and heart failure. Myocardial infarction, especially in young population, is very important uh, risk factor, because most of the myocardial infarction patients who present late ultimately develop LV dysfunction, and over a period they develop the problems of damaged heart in the form of heart failure, ventricular tachycardia, or they even do develop cardiorenal syndrome or sudden cardiac death due to ventricular tachycardia. Age itself is a risk factor. As aging happens, there is a aging of the heart also. Fibrosis of the myocardial tissue or fibrous content of the myocardial tissue increases. That increases the stiffness of the heart, and aging mainly causes aging, and hypertension mainly causes heart failure with a preserved LV ejection fraction. Valvular heart disease, cardiomyopathy, these are also risk factors for the future development of heart failure. Now, the commonest cause I told you is a myocardial infarction. You can see once the myocardial infarction happens, there is a damage to the apical tissue and the septal tissue. That damage to the heart causes dilatation of heart. It becomes perical. Bullet-shaped heart becomes perical, and ultimately its ejection fraction reduces. Because the geometry of the heart changes, it will cause the problem of the mitral valve also, and it will cause mitral regurgitation also. So already heart pumping is less, and on the top of that, because of changes in geometry, it will cause mitral regurgitation also, and ultimately it will cause decreased cardiac output. Heart failure has a different types, as I told you, systolic or diastolic, or you can say heart failure with a reduced ejection fraction, that means systolic heart failure, and heart failure with a preserved ejection fraction, that is a diastolic heart failure. Even few people try categorize heart failure into left-sided heart failure, right-sided heart failure, depending upon the predominant symptoms. Then we have a NYHA functional class. New York Heart Association functional class is worldwide used for categorizing the symptoms of the patient. This is very important because we should know the current symptomatic status of patient that will be categorized in the NYHA functional class, and the treatment is up-titrated as per the NYHA class. Stages of heart failure, it has A to D stages, which I'll be telling you in next slides. So the main important classification is on the basis of ejection fraction. This is very important because depending upon this classification, the treatment is, treatment is important as per the classification. Treatment of heart failure with reduced ejection fraction is different, and treatment of the heart failure with preserved ejection fraction is different. Even more Mortality, morbidity is also different. So if you want to diagnose heart failure with a reduced ejection fraction, you should have a patient should have symptoms and signs, and the echo should show ejection fraction less than 40%. Now, normal ejection fraction is above 50, or we can say as a 60%. Ejection fraction is nothing but percentage or fraction of the blood volume ejected by left ventricle. So normal is around 55 to 60. If end diastolic volume of heart is 100, or approximately 120, the ejection fraction stroke volume is 75. So it will be around 50 to 55. Then heart failure with preserved ejection fraction, patient should have symptoms of heart failure, signs of heart failure. Echo should show left ventricular ejection fraction more than 50%. You may see do a BNP levels to look for the objective evidence of the heart failure, and even there are few echo features like a left ventricular hypertrophy, left atrial enlargement, because even if the LV function is normal, because left ventricle is stiff in diastolic heart failure, it will cause back pressure into the left atrium and left atrial enlargement will be there, and there will be diastolic dysfunction. To diagnose diastolic heart failure or heart failure with a preserved ejection fraction, you should have a normal ejection fraction and you should have a elevated BNP, left atrial enlargement, or diastolic dysfunction evidence with symptom and signs of heart failure. And there is one category, this classification is on the basis of ESC guidelines 2016. They have included one more category, that is heart failure with mid-range ejection fraction in a patient between ejection fraction of 40 and 50. NYHA class has 4 classes. We have class 1, that means no limitation to the physical activity. If the patient is in class 2, that means there is a slight limitation of activity. If the patient is in class 3, marked limitation of physical activity. Although patient is comfortable at rest, but less than ordinary activity will cause symptoms. Class 4 means patient has severe limitation and discomfort with physical activities and symptoms are present even at rest. So if the patient has a class 4 symptoms, then he will not able to do even routine activity and he may be have a discomfort at the rest. Such patient requires admission. Now the heart failure is staged from the stage A, stage B, stage C, and stage D. What is the stage A? Stage A means high risk population. Whoever is having the hypertension, diabetes, obesity, cardiotoxin use, familial history of cardiomyopathy, these are patients, these are at risk of developing structural heart disease. This patient may develop structural heart disease because of these risk factors. So these are at risk, stage A. Stage B means patient is having structural heart disease, but they are asymptomatic. Such patients like who had a previous history of myocardial infarction, there is LV dysfunction, but patient is asymptomatic, or left ventricular hypertrophy, especially because of hypertension and valvular heart disease, but patient is not having symptoms of the heart failure. That's why they will be in a NYHA class 1. Stage C means patient already developed heart failure symptoms or patient is currently having heart failure symptoms. So if suppose patient develops heart failure symptoms 6 months ago, that patient will be in stage C only because he had a previous episode of heart failure symptoms. So structural heart disease with the symptoms will be categorized in a C. The patient can be in NYHA 2, NYHA 3, or even after treatment, stage C patient may be in NYHA 1, means patient may be asymptomatic with the therapy. And if the patient develops NYHA 4 symptoms and is refractory to the medicine, that is a stage D. So what actually happens, I'll just again summarize pathological progression of the cardiovascular disease. All these diseases will cause myocardial injury. Different diseases which are targeting heart will cause myocardial injury, that will cause pathological remodeling. There will be neurohormonal stimulation because once myocardial injury happens, heart pumping goes down. Once heart pumping goes down, cardiac output to other organs will decrease, kidney will come into the play, and the kidney will start secreting renin and it will try to maintain the perfusion pressure and the neurohormonal stimulation will happen. That ultimately, if it is excessive, will cause symptoms. That will ultimately lead to the chronic heart failure, pump failure, that may lead to the death, or there can be sudden death because of ventricular tachycardia. And ultimately that uh, causes low ejection fraction due to neurohormonal stimulation. So this chart is very important to understand the treatment of the heart failure. Any patient with a heart failure will ultimately cause renin stimulation or renin secretion and angiotensinogen secretion. That happens because of beta stimulation and decreased cardiac output. That ultimately cause angiotensin 1 secretion. 1 will be converted into the angiotensin 2 with the help of ACE enzyme, angiotensin converting enzyme. That ultimately angiotensin 2 will cause peripheral vasoconstriction, increases afterload. Already heart function is low or less. On the top of that, there is a peripheral vasoconstriction. That's why there is an increase afterload. Ultimately, finally, it will cause decreased cardiac output and heart failure. Other pathway, it also causes secretion of aldosterone. Aldosterone ultimately causes fibrosis, and the myocardial damage again continues. It will again, along with that, it will cause salt and water retention, plasma volume will increase, patient will have preload, and then again, it will cause cardiac overload. So one side, there is a vasoconstriction and afterload increase in for the heart, and other side, there is a preload increase. Volume of the blood is increased because of water and salt retention, and vasoconstriction will cause afterload increase. And obviously aldosterone secretion will cause fibrosis. So for the therapy of the heart failure, we use ACE inhibitors so that angiotensin 1 to 2 conversion will be inhibited. We use beta blockers to reduce the beta stimulation. We use aldosterone receptor inhibitors, mineralocorticoid receptor inhibitors to prevent the fibrosis of the heart. So these are the three important therapies to reduce the morbidity and mortality in heart failure. And this is based on this pathophysiology. So how to diagnose the heart failure? Heart failure can be diagnosed with the help of Framingham's diagnostic criteria, Boston diagnostic criteria, European Society Cardiology diagnostic criteria, or even Gothenburg. There are multiple score systems. But what is important to understand is medical history is very important, physical examination is important, and supporting investigations are important. So if you take a proper medical history and physical examination, most of the times you will diagnose the heart failure clinically, and you can do the investigations to justify your diagnosis or to find out the etiology so that you can tailor the therapy as per etiology. So what happens in heart failure? Why the symptoms happens? As I told you, left ventricle systolic function or diastolic function will be hampered in the heart failure. That causes back pressure to the left atrium, and ultimately from the left atrium to the pulmonary vein and the pulmonary artery. That will cause pulmonary congestion. Because of pulmonary congestion, patient will develop breathing difficulty. As the process continues, ultimately it will cause pulmonary hypertension because pulmonary artery will go into vasoconstriction. That will cause right ventricular afterload. Right ventricle will ultimately develop hypertrophy. And as the process continues, it will cause right heart failure, and then because of right heart failure, right ventricular and right atrial pressure will increase. Because of increase in right atrial pressure, it will cause raised JVP. JVP is nothing but jugular venous pulsation because it's a passive drainage into the right atrium. But because right atrial pressures are increased, the column will be up, that is raised JVP. And then ultimately all venous system will be congested, causing peripheral pedal edema, then hepatomegaly, splenomegaly, and ascites. So this is a backward pressure, which we call as a right heart failure. And when there is a left ventricle failure initially, that will cause pulmonary congestion, that will cause breathing difficulty, PND, orthopnea, or fatigue. As forward flow is reduced, patient will develop fatigue, that is a forward failure. So typical symptoms: breathlessness, orthopnea means patient is not able to lie down supine. Paroxysmal nocturnal dyspnea means patient will lie supine in the night for 2 hours, 3 hours, and suddenly he will wake up from the sleep with a breathing difficulty, and that may remain for more than half an hour. This is called as paroxysmal nocturnal dyspnea. Reduce, this is because of pulmonary congestion. All these three symptoms are because of pulmonary congestion. Reduce exercise tolerance, fatigue, tiredness, increase time to recover after exercise. That is because of reduced cardiac output. And ankle swelling and ascites, all these are right heart failure signs or symptoms. Signs, classical signs like elevated jugular venous pressures, hepatojugular reflex, third heart sound. If we auscultate on a heart and if we find third heart sound, it's generally because of systolic heart failure. Laterally displaced apical impulse, especially in systolic heart failure where the heart is enlarged. There are less typical symptoms, cough, wheezing because of cardiac asthma, loss of appetite because of hepatic congestion, bloating, confusion because of decreased cardiac output, depression, palpitation because of cardiomegaly, dizziness because of decreased BP, syncope can be because of ventricular tachycardia. So all these are less typical for the heart failure. This can happen in other diseases like lung disease or even heart disease due to other etiology. Less specific signs like a weight gain, weight loss if there is advanced heart failure, tissue wasting, cardiac murmur, peripheral. Sometimes patient new cardiac murmur indicates that patient is having some structural heart disease, which is causing the uh, valvular lesion and heart failure. Peripheral edema, pulmonary capitations can happen in lung disease also. Reduced air entry because of pleural effusion, tachycardia, tachycardia because heart pumping is less. Heart has to pump more times because cardiac output is equal to stroke volume into heart rate. So if the cardiac output has to be maintained and stroke volume is low, heart rate has to be increased. So generally, heart failure patients will have a tachycardia, irregular pulse because of atrial fibrillation, hepatomegaly, ascites, oliguria, neuropulse pressure. The symptoms and signs of the heart failure due to reduced ejection fraction and normal ejection fraction are almost same. So once you suspect the heart failure, you have to ask the history of. So if suppose patient comes with the history suggestive of heart failure like a pedalema, breathing difficulty, or weakness, easy fatigability, then you should suspect the heart failure. You should ask history of myocardial infarction. If the patient has a past history of myocardial infarction, high chances that he has a damaged heart because of myocardial infarction and heart failure. History of arterial hypertension, exposure uh, exposure to the cardiotoxic drugs, radiation, use of diuretic in the past. It will indicate that with the diuretic, if he's feeling better, probably he's having LV dysfunction and heart failure. Orthopnea, PND, physical examinations revealing the edema, murmur, rails, JVP, lateral displaced heart, and suppose ECG showing some abnormality, then you should suspect strongly heart failure, and chances of heart failure are high. The next investigation is echocardiography. Echocardiography will tell you what is the ejection fraction, what is the pulmonary pressure, what is the myocardial status. If it is confirmed, then you can proceed with the treatment and further evaluation to find out the exact etiology of heart failure. And if we can reverse that etiology, patient's LV function can be restored. That is what we need. If it is not possible, if the heart is totally damaged, then you have to just continue the medications to control the neurohormonal stimulation. Suppose echo is generally we go with the echo directly. If suppose echo is not showing systolic heart failure, there is doubt about the diastolic heart failure, then we go for a BNP. We don't use BNP for regular diagnosis because BNP has a lot of fallacies. It can be raised in multiple other conditions also. So when there is a doubt, when the patient has already other diseases like lung disease, pre-existing lung disease is there, and patient comes with a means breathing difficulty, so we are not sure the breathing difficulty is because of lung disease or heart disease. In that situation we do a BNP. BNP is raised because of stress to the heart, because there is a increased intraventricular pressure that will cause stretch on the heart, and that will release the BNP. So even if there is a direct damage to the heart in the form of myocardial infarction or myocarditis, or even if you give a shock, external shock, in that situation BNP will be raised. Echocardiography, you can see left side, it is a normal left ventricle. This is a left ventricle, then left atrium, right ventricle. Right atrium is and left atrium are of more or less same size. Left atrium is little larger. Left ventricle is more, dimensions are larger compared to the right ventricle. This we call as a four chamber view. That means we can see the four chambers in a one view. That is apical four chamber view. You can see the normal contractility of the LV. Suppose a heart failure patient comes with this echo, you can see the left ventricle is not at all contracting or hardly contracting. If you compare with the left ventricle contraction here on the left side, the contraction of the left ventricle on the right side is reduced. So that is because of damage to the heart. Probably he has developed myocardial infarction in the past and there is a damage to the septal wall. That's why it is not contracting. Only the lateral part is contracting, and that has caused reduced ejection fraction. It may be around 30% of ejection fraction. So with this echo, I can diagnose heart failure is because of old myocardial infarction, and that has caused reduced ejection fraction. You can have this kind of echoes also with the heart failure. This is a typical case of hypertrophic cardiomyopathy. You can see the heart is thickened, the wall of the heart is thickened. This is a septum and this is the lateral of the left ventricle. Both are thickened. And if you see the systolic function is normal, or in fact, no, more than the normal. It's LV cavity is totally obliterating during the systolic. So if the patient has a heart failure signs with this echo, that is typical of diastolic heart failure. Because of this abnormal myocardial texture or myocardium, the heart doesn't expand easily. The heart resists to dilate or resists to accommodate the blood from the left atrium. That causes diastolic heart failure. Or you may get this kind of echo where the mitral regurgitation, left ventricle function is normal, but mitral valve is leaking, and that is causing backflow into the left atrium, and that jet itself is going to the pulmonary vein. You can see the mitral regurgitation jet is almost reaching the pulmonary vein here. So when the left ventricle is contracting, most of the part is going to the LA back. So that will cause a forward heart failure as well as pulmonary congestion signs. Now, another investigation, as I told you, ECG can give clue to the diagnosis of the etiology of the heart failure. In this ECG, you can see typical dilated cardiomyopathy, ECG of a dilated cardiomyopathy patient where you will have low voltages because myocardium contraction is less. The electrical signals generated by that myocardium is less. That's why the QRS is smaller. Chest leads will have a bigger voltages and poor progression of R waves. So that is a typical of Goldberger triad, which is commonly noticed in dilated cardiomyopathy patients. Such patient, if comes with the heart failure signs, you can see the Q waves in the chest leads along with the persistent ST elevation. That is because of myocardial infarction in the past, which is causing LV dysfunction and LV aneurysm. Heart failure with this kind of ECG where QRS is very large, U waves are there, T inversions are there. These are typical of hypertrophic cardiomyopathy. This is a case of ARVD, right ventricular dysplasia, arrhythmogenic right ventricular dysplasia. The problem is in a right ventricle. It is a genetic disorder which causes dilatation of right ventricle and right ventricle failure. The patient mainly will have a right ventricle failure signs and symptoms along with arrhythmias, ventricular tachycardia. Generally, these patients present with a ventricular tachycardia. But ECG will have a typical of epsilon waves. Because of dilatation of RV, there will be some blip in the V1. This is called as epsilon wave. And you, on the ECG basis, before doing echocardiography, you can diagnose this condition. This is another interesting diagnostic ECG where you will have a low voltages, pseudoinfarct patterns, but echo will show hypertrophy of the heart. So if there is a hypertrophy of the heart on one side and less electrical signal generated by that heart, that is typical of amyloidosis, cardiac amyloidosis, because the muscles are actually infiltrated with amyloid tissues and there is no actually muscle to generate the electrical signals. This is another ECG which is important to know because the therapy depends on this ECG. If the patient is having typical LBBB, this is classical left bundle branch block ECG, and if the patient has heart failure signs with severe LV systolic dysfunction, this patient will get benefit of cardiac resynchronization therapy. So other than medicines, devices like cardiac resynchronization therapy can improve the heart failure in these patients. As I told you, BNP can be used for the diagnostic purpose. Even BNP can be used for the prognostic purpose. You can repeat the BNP after discharge and you can serially follow the BNP levels to see the patient's recovery. And there are multiple causes which can cause raised BNP. That is also very important to understand. Few investigations like chest X-ray. Chest X-ray is not that diagnostic, but in emergency you can see use the chest X-ray to differentiate with the respiratory causes, or it can diagnose other respiratory causes for the symptoms of breathing difficulty or suspected case of heart failure. So chest X-ray is a basic investigation in a patient with a breathing difficulty, but heart failure patient will have a cardiomegaly, they will have a pleural effusion, they will have a pulmonary venous congestion because there is a backflow from the left ventricle to the left atrium and ultimately to the pulmonary veins. So pulmonary veins will be prominent. There will be curly B lines. That is because of lymphatic prominence. Because of pulmonary congestion or pulmonary edema, the lymphatics will try to clear the fluid from the alveoli and that becomes bigger, and these are seen as a curly B lines. And typical of bat wing phenomena can happen in later stages of acute heart failure. Cardiac MRI gives more information than the echocardiography. Echocardiography can tell us ejection fraction, but we are not sure how much myocardium is damaged and how much damage is permanent. In few cases, we have to use cardiac MRI, which will tell us what is the amount of the tissue which are totally dead and amount of the tissue which are salvageable or can recover after the therapy. Like suppose patient has a coronary artery disease and we are not sure that myocardium is damaged or not. If the MRI shows the myocardium is not damaged, probably I will do angioplasty or bypass, and the myocardium, once the flow is restored, blood flow is restored, will start pumping again. That is called as hibernating myocardium. But suppose if the myocardium is totally damaged, in this A slide you can see the whitish is a damaged heart. If I open the vessel which is supplying this area, still that will not cause improvement in ejection fraction or LV function because it is totally damaged. So cardiac MRI we use for the viability purpose. You can see the normal black color margin is a normal heart. This is a long axis, this is a short axis. And you can see the whitish rim, which is actually dead myocardium. This is actually contrast enhanced MRI images. Sometimes, especially in ARVD, which I shown a ECG previously, ARVD sometimes or arrhythmogenic right ventricular dysplasia sometimes is difficult to diagnose on the echo. In that situation, MRI helps. MRI can diagnose early ARVD diseases where you can see the RV is dilated and there is a fibrosis of the right ventricle. Few patients who present with angina and heart failure symptoms, angiography is must because as I told you, coronary artery disease is the commonest cause of left ventricular dysfunction. And if the patient has angina, that indicates that patient is probably having a viable tissues. If patient has heart failure symptoms without angina, even there are coronary artery blockages, probably the viable tissues are less. If the tissues are not viable, it will not cause a pain. If the tissues are viable, chances of angina plus heart failure is because of coronary artery disease. So once we do angiogram and if there are blockages and LV function is severe, we generally do viability testing in the form of cardiac MRI or in the form of nuclear scan. Nuclear scan also tell us viability of the tissue. Now this nuclear scan shows that whatever the black things are there is a non-viable tissue. So if the vessel is supplying to this area, even if I do bypass surgery or angioplasty to that vessel, it will not improve the ejection fraction. But suppose if there is a viability and there are multiple blockages and heart failure is less, heart pumping is less, I will go for revascularization because this is called as hibernating myocardium. That hibernating myocardium will improve after improving the blood flow. Sometimes we have to go for endomyocardial biopsy. So this is one case we did an endomyocardial biopsy for this patient. She presented with a 50-year-old, progressive exertional dyspnea, 50-year-old female. She had a right heart failure and she had a past history of carcinoma of cervix. She received radiotherapy for the same. Echo was performed and we surprised. Echo showed dilated right ventricle with a full of mass. Right atrium is also dilated and left ventricle is compressed because of dilated right ventricle. So we tried to, we did a PET scan and we realized that whatever the mass is there in a right ventricle is metabolically active. These are not a fibrous tissue. Then we ultimately planned endomyocardial biopsy. We did endomyocardial biopsy through the transjugular approach with the bioptim, and to surprise, it was actually squamous cell carcinoma, and it was metastatized from this CA service, which was previously 7 years ago it was treated. So it is a late recurrence of the metastasis, and that itself caused right ventricular mass and right ventricular heart failure. So sometimes echo will give a clue to the etiological diagnosis of the heart failure, and depending upon that we have to plan the therapy. We planned radiotherapy for this patient for the debulking of the mass to improve the symptoms, but because patient's general condition was poor, patient succumbed to this disease. So heart failure medications, coming to the heart failure medications, we have already, I told, there are three types of medications. One is ACE inhibitor or ARB blockers. ACE inhibitors will prevent the angiotensin 1 to angiotensin 2 conversion, that will prevent vasoconstriction. Another drug is ARB that will cause a angiotensin receptor blockers that also has a similar action like a ACE inhibitor, except that ACE inhibitor will have symptoms of cough or sometimes angioedema. ARBs will not have these side effects. Beta blockers to reduce the beta stimulation and prevention of neurohormonal stimulation that reduces the action of the stress hormones and slows the heart rate. Beta blockers are contraindicated in active heart failure. Suppose patient comes with acute heart failure, beta blockers should be avoided. Then it should be avoided when the BP is less than 90 mm of Hg, and it should be avoided in patients with active asthma. Another drug category important is aldosterone blockage, that is spironolactone or eplerenone, that will prevent the fibrosis of the tissue. And then diuretic group or digoxin group is for the symptomatic benefit only. ACE inhibitors, ARBs, beta blockers, aldosterone blockers are important therapy in the heart failure because it reduces the mortality in this patient. So any patient with the active heart failure should have these three drugs, either ACE or ARB plus beta blocker plus aldosterone. So just to summarize this flow chart, which was published in 2016 guidelines of ESC heart failure guidelines, the patient with a symptomatic heart failure, you start with the ACE inhibitors and beta blockers. Patient if still symptomatic and ejection fraction is less than 35, add mineralocorticoid receptor antagonists like a spironolactone or eplerenone. If still symptomatic and ejection fraction is less than 35, ACE inhibitors can be converted to the ARNI. So this ARNI is a new group used for the heart failure. ARNI is angiotensin receptor neprilysin inhibitor. If the patient is symptomatic despite these three drugs, then we can go for the newer drug, ARNI group of drug, which actually should be started after stopping ACE inhibitors. We should give at least 36 hours of washout period after stopping ACE inhibitor. Otherwise, they can develop persistent hypertension. Then if the patient has a wide QRS and despite this therapy he is symptomatic, look for candidate or evaluate for the need for the CRT. If the patient has a wide QRS, probably he may improve with the CRT. If the patient is having persistent tachycardia despite beta blocker, you can add vabradine. These above treatments may be combined if indicated. It depends on the patient's NYHA class after starting the therapy. And if the patient has resistant symptoms despite all these things, then consider digoxin or hydralazine or isosorbitate combination or LVAD or heart transplant, that I will tell in short. Diuretics should be used as per the need of the symptoms, because diuretic is not going to improve the mortality, it will just improve the symptom. So if the patient is asymptomatic with this therapy, I'll not add diuretic. If the patient is symptomatic despite this therapy, I will use the diuretic. And obviously, ICD should be used if the patient is at high risk of developing sudden cardiac death. That I already told, even European guidelines or American guidelines says ACE inhibitors, beta blockers, and MRAs, mineralocorticoid receptor antagonists, are must for the therapy. These are the dosages of the drugs. ACE inhibitors like captopril, enalapril, lisinopril, ramipril. These are available. Captopril is not available. Enalapril, lisinopril, ramipril is available in India. You have to start with the low dose and go to the maximum dose. Beta blockers like bisoprolol, carvedilol, and metoprolol are preferred because these three drugs have antiarrhythmic activity also. ARBs like valsartan, losartan, MRAs, eplerenone, spironolactone. ARNI is sacubitril plus valsartan combination. It should be substituted for the ACE inhibitor, either ACE inhibitor or ARBs or ARNI. And if the patient is having tachycardia despite tolerable doses of the beta blocker, then you should go for evaporating to control the heart rate. And the diuretic, we have option of furosemide, torsemide, thiazide diuretic, potassium sparing diuretic, spironolactone, eplerenone. Another important thing I just want to enforce is that any patient with heart failure, we should not use NSAIDs or COX-2 inhibitors, because that will ultimately will again cause neurohormonal stimulation and it will worsen the heart failure. So any patients, if suppose comes to you for the physiotherapy, suppose a known case of heart failure comes with a joint pain or some kind of muscle sprain, and if he's on a NSAIDs or COX-2 inhibitors, you should discourage him to take these medications. Stage-wise treatment: stage A, control the risk factors; stage B, just prevent the heart failure symptoms with the help of ACE inhibitors when there is a LV dysfunction. If required, angioplasty or bypass. If required, valvular surgery, go for the valvular surgery. Stage C means symptomatic. You have to control the symptoms with the diuresis and our three drugs like ACE inhibitor, ARBs, beta blockers, and MRAs. If patient has a LBBB and chances of getting improved ejection fraction with a CRT, put a CRT. Risk for the heart cardiac arrest, ICD. Stage D, we can't do much. Stage D patients should be evaluated for the heart transplant therapy. So in short, I'll just tell a device therapy. Patients with the NYHA class 2 and 3 study showed that 60% population dies suddenly. So heart failure patients with the NYHA 2 and 3 class, especially stage 3, stage C patients who are ambulatory, develops ventricular tachycardia and sudden cardiac death. So such patients, we generally put ICD. Any patients with a heart failure less than ejection fraction less than 35% and past history of myocardial infarction or documented ventricular tachycardia or unexplained syncope in heart failure patients, we put ICD. What ICD does, it is like a pacemaker like machine. The lead goes to the heart. It continuously watches the myocardial activity. Whenever the patient develops ventricular tachycardia, it gives the shock and it stops the ventricular tachycardia. This is because despite antiarrhythmic drugs, patient may develop ventricular tachycardia, which can be life-threatening. If the patient doesn't reach in the hospital within 5 minutes, patient will have a brain damage and cardiac arrest. So that's why machine detects the ventricular tachycardia in 5 seconds and gives shock in the next 5 seconds. So within 10 seconds, patient gets the therapy. As I told you about CRT, I'll not go into the details of the CRT, but there is a therapy you should know which can improve ejection fraction in a few subset of patients who has left bundle branch block, whose myocardial dysfunction is purely because of electrical problem, because the septum is getting current later than the lateral wall. I mean, lateral wall is getting current later than the lateral wall. That's why there is a LV dysfunction. So cardiac synchronization or resynchronization means it synchronizes the septal wall and the lateral wall, and it improves the ejection fraction. You can see without CRT on, and this is with CRT on. Then another therapy is LVAD, left ventricular assist devices. This should be reserved for the patients who has symptoms for more than 2 months, severe symptoms despite medical therapy, ejection fraction is less than 25, peak VO2 max is less than 12 ml per kg per minute, recurrent hospitalization. This therapy can be used as a bridge to the heart transplant, or it can be used as a destination therapy, means just put a LVAD and continue till the life, or it can be used for a temporary circulatory support. So what it does, it just sucks the blood from the left ventricle, and it, with the motorized system, it pushes the blood into the aorta, and from the aorta it goes to the systemic circulation. And obviously, if the other options are not helping, the last option is a heart transplant. You have to see the candidate in the detail. I mean, you have to examine and do detailed examination of the candidate. Is it fit for the heart transplant or not? Even if you do heart transplant, patient has to be on immunomodulators or immunosuppressant lifelong. There are newer generation artificial hearts going on, and they are under development. There are newer therapies which will cause neuromodulation with the help of vagus nerve stimulation, spinal cord stimulation, renal nerve ablation, carotid baroreceptor. All these things, modifying these nerves input, we can modify neurohumoral activation. But these therapies are under investigation. They are not approved. Lifestyle changes are very important for these patients. Eat low sodium, low fat diet. This is very important. Medical therapy is important. Other devices, everything is important. But this is lifestyle changes or whatever dietary advice is very important than the medical therapy. Suppose if patient doesn't take the low sodium diet, or if he takes excessive salt or excessive water intake, then whatever diuretic you are giving will not work efficiently. So patient has to take low sodium diet, low water or restricted water intake, he should do regular exercise to lose weight, physically active, he should avoid the alcohol and caffeine, and he should stop the smoking. Exercise training is very important. Studies have shown that it reduces the heart failure hospitalization. It improves the functional capacity and symptoms. So your role is also very important in the management of this patient. Follow-up and monitoring is important. Once you treat the patient, once patient is asymptomatic, he has to follow up regularly. He has to, there are some self-check plans where patient can go through this kind of charts where he will understand he's doing okay or he's having any symptoms or early symptoms. You have, there are few devices like which can monitor pulmonary artery pressures. Suppose pulmonary artery pressures goes beyond a particular level, then patient can get a signal and he has to visit hospital, because if he doesn't take it seriously, then he will develop frank heart failure symptoms. So normal pulmonary wedge capillary pressure is around 15. So if it goes beyond a certain level, especially 20, they develop symptoms of heart failure. But the most important or best device for monitoring heart failure is a weight. If the patient monitors weight regularly, and if suppose there is a sudden increase in weight, especially 5 kg weight increase within 1 week, then he should be alert that he may develop symptoms of heart failure because there is a water deposition or logging. So once sodium retention and water retention happens, that will cause cardiac overload, and again he will start developing symptoms of heart failure. That's why salt restriction, water restriction is very important or integral part of the therapy that should come from the patient side. And obviously medical management, medicine and regular monitoring is important. To just summarize the therapy, once the heart failure is diagnosed, beta blocker, ACE inhibitor or ARBs, and newer drug like ERNI, mineralocorticoid receptor are important drugs. Patient, if at risk of developing sudden cardiac death or documented ventricular tachycardia and syncope, ICD should be used to prevent sudden cardiac death. If the patient has a left bundle branch block and dilated heart, we can use a resynchronization therapy that will reduce the symptoms of heart failure. LVAD for particular patients who are actually bedbound, they are having class 4 symptoms, and transplant for a few patients who are actually eligible recipients and ready to take lifelong immunosuppression. So in summary, heart failure is a common disease and common entity, and it has a high mortality, almost 50% at the end of 5 years after diagnosing the condition. Whenever you diagnose the heart failure, look for a reversible cause. Once you find a reversible cause, try to correct that so that his LV function will improve and he will have less morbidity. Drug therapies improves the survival, like beta blocker, ACE inhibitors, aldosterons, ARNI. SGLT2s are new group of drugs not included in the guidelines, but still the studies have shown that SGLT2 actually anti-diabetic drug, but it has very good response in heart failure patients. So diabetes with heart failure will respond to the SGLT2 inhibitors. Newer therapies like biventricular pacing or CRT or synchronization therapy or ICDs has improved the survival. Transplant remains rare last option, but newer technologies like mechanical assist devices are improving. So we may get in future artificial hearts. And obviously, as I told you, physiotherapist's role is very important in managing heart failure because exercise will improve the functional capacity, it will improve the uh, uh, mortality as well as it will improve the morbidity. Thank you.
Thank you very much, sir, Dr. Abhijit sir, and really it was very nice presentation. Definitely, the knowledge that you shared in this platform will be definitely useful for all physiotherapists who are attending this conference. So, thank you, sir, once again from the bottom
If
of
any questions, I'm ready to take. I think I'm already consumed extra 10 or 15 minutes of other speaker.
no problem. Over to you, Dr. Trupti Saru.
Thank you, sir, for your presentation. We have some questions for you. Do you think after pulmonary vein isolation ablation, right heart function improves?
Pulmonary vein isolation generally we do for atrial fibrillation. So atrial fibrillation will cause tachyarrhythmias and it will cause LV dysfunction. So if there is a LV dysfunction because of atrial fibrillation, and if you can isolate the pulmonary veins and make him into the sinus rhythm, LV function will definitely improve. But generally, such patient will be having extensive left atrial disease where pulmonary vein isolation is very difficult. And patient who develops intermittent atrial fibrillation, and for that patient, if we are doing pulmonary vein isolation, these patients generally will not have heart failure symptoms. They will have a normal heart function.
Okay.
So,
Yeah. Yes, sir, you can say.
no. So in short, if there is a LV dysfunction because of atrial fibrillation, the disease is extensive and pulmonary vein isolation is not that easy.
Okay. The next question is, in reduced ejection fraction up to 35% heart failure, if there is no ankle swelling but reduced walking endurance mildly, would you consider that this as a heart failure?
Yes, yes. If the patient has easy fatigability or reduced functional capacity, that, as I told you, is a forward failure symptoms. Because cardiac output is reduced, the body is not getting sufficient oxygenation. That's why he's getting easy fatigability or subtle symptoms like late recovery from the exercise. These are the signs of the heart failure.
Okay. Next question. Do you think in paroxysmal atrial fibrillation, reduction of weight would be help with patients having BMI 24?
There are reports that high BMI or increased pericardiac fat, especially obese patients, will have increased pericardiac fat. If reducing weight or decreasing fat will have a favorable effect on managing heart means atrial fibrillation, especially if this patient has obstructive sleep apnea. Generally, most of the patient with obesity will have obstructive sleep apnea. They will have intermittent hypoxia, especially in the night time, and that hypoxia causes changes in the heart, especially in left atrium, and that causes atrial fibrillation. So if you correct the weight, that will reduce the sleep apnea, that will reduce the chances of atrial fibrillation. This link is proven. Sleep apnea is one of the documented cause of, reversible cause of atrial fibrillation. And sleep apnea, the commonest reason is obesity. So even if the patient doesn't have sleep apnea, probably there is a role of pericardiac fat, which is not yet established, but there are, favorable results in that favor.
Last question for the session. If the patient's BP is 90/17, which is low, which strategies do you use to give Vimada? That is, do you give Valsartan or do you give Scabutril?
Okay, no, well, Vimada is a combination of sacubitril and valsartan. So this is a ARNI class of group. As I told you, whatever the third group after ACE inhibitor and ARBs is a ARNI. ARNI is a combination of angiotensin receptor and neprilysin inhibitor. So valsartan is an angiotensin receptor and sacubitril is a neprilysin inhibitor. So it is a combination. We cannot give it separately. We have to give in combine only. But the only thing is that when the BP is less than 90, I will be very hesitant to give this drug because this drug causes hypotension. So generally, if the BP is less than 90, I avoid giving this drug.
Okay, sir. Thank you so much, sir, for your presentation.
Thank you.
Yeah. We move on to the last presentation. Thank you, sir. We shall move on to the last speaker of this conference, Dr. Moira Crack. Are you there, ma'am?
Yes, I'm here.
Yeah. Welcome, ma'am.
Glad to be here. Hello.
Hello.
Hello, madam.
Hello there. How would you like me to begin? Thank you for inviting me to speak.
Thank you, madam. We are very happy to have you on this platform.
Okay. I work at St. Vincent's Hospital in Melbourne, and my physiotherapy role is included helping to coordinate the heart failure rehabilitation program there. What we hope to discuss this afternoon is what is rehab, what is the team that we've heard a previous speaker elucidate that you need a team for rehab and management of the heart failure patient. I'm going to talk about eligibility when physiotherapists get referrals for heart failure patients to do rehabilitation with them, who is eligible, who's not, what sort of equipment you need, what are the resources that you need to run a heart failure rehab program. Also, heart failure patients are a little bit different to standard cardiac rehab patients, and I'll describe the differences and the similarities and the differences. Talk a little bit about exercise prescription for heart failure patients and some of the sort of troubleshooting issues that you might have when you're running heart failure rehabilitation for this often breathless and very fatigued demographic. So heart failure rehab, it's a team. It's not any single person or health professional, it's a team of people. We're promoting in the heart failure rehab patient regular physical activity. We ask them to try and understand what heart failure is and what the signs and symptoms are, what the self-management strategies that they can use to help themselves be as well as they can be. We have to take into account what barriers they might come across. If we were asking them to make a change in their lives, to take more tablets, to change what they eat, what are the barriers to those change? And also for the heart failure patient, for rehabilitation, it's good to have some kind of goal that they're aiming for. Like they may be too breathless to do certain tasks at the moment that they used to be able to do. And so having an achievable goal is very important for their participation in rehabilitation. So the rehab is not just for the patient, it's for their supporters as well, their family, their friends, because everybody would need support when dealing with a diagnosis of heart failure. The rehabilitation could be in an outpatient setting with a group of people, or it can be an outreach setting with just the patient in their own home. And also rehab is not just doing exercise and listening to lectures about information about heart failure. There needs to be constant reassessment and communication amongst all the team members. We've already discovered, our previous speaker has mentioned that aerobic exercise and is recommended for patients with heart failure, and that people are enrolled, patients are enrolled in a multidisciplinary care management program. It's a team of people that helps look after the heart failure patient. This team, I'm very lucky in Melbourne, in Australia, where I am at the moment. Our team we have enough resources for a pretty good team. So we need a medical expert. We have the cardiologist, of course, who looks after the patient. We have a registered nurse, which is often their clinical nurse consultants or clinical nurse practitioners. They're very expert in their field. And we have the medicines expert, the pharmacist as well. We have somebody who is an exercise expert. The amount of work we're going to ask the heart failure patient to perform, we need someone that understands the workload that's involved. And it's not just physiotherapists, but there are exercise physiologists involved as well. We need, if we're going to ask the patient to work, we need to know what kind of fuel we're going to ask him to eat. So a dietitian is part of the team. Also, dealing with the diagnosis of heart failure can be quite stressful for the patient and the family. So we have a psychosocial expert, either clinical psychology or the social worker. And we have the OT, the previous speaker talking on stroke. It's a very important member.
Sorry to interrupt, ma'am.
Yes.
Ma'am, your presentation is not visible to us.
Oh my goodness, I thought I was sharing the screen. I'm terribly sorry. Let me just, let me see if I can, where are we? I'm still, I'm sorry for technical difficulty. Let me just find my controls and see if I can. I'm still viewing.
Yeah.
I'm still viewing Dr. Shelke's screen here. Oh, here we go. Let me try this. I cannot start my screen share while
Just
the
a
other
minute.
participants are
Dr. Shelke, can you please stop your screen share? Yes, ma'am, you can start.
Okay. Okay, so let's go back here again. Share screen, is that happening?
No, ma'am.
Not yet. I'm pressing the share screen button. And I'm not sure why it's not happening. Share screen? Oh, hold on.
You have to click on your PP. Oh. Yeah, now it came. Yeah.
Okay, I'm terribly sorry. Technical inexpertise there. Thank you.
Ma'am, you can press the slideshow option or F5. Yeah.
Is that okay?
Can you give me a minute? I have to introduce yourself.
Oh, okay. Will I go back? Will I take my screen back to the previous
No problem, ma'am.
slides?
You can start from where you are.
Okay.
Okay. So a warm welcome to you, ma'am. We have the presenter for today, Dr. Moira Crack. She is a chronic heart failure rehabilitator. She is currently working in cardiopulmonary exercise rehab at St. Vincent Hospital, Melbourne. She is a graduate of La Trobe University in Melbourne, and she has more than 15 years of working experience in cardiac rehabilitation in Melbourne. We welcome you, ma'am, to this conference. You may continue, ma'am.
Thank you very much for your invitation. Good. I'm sorry about the technical difficulty. Thank you for letting me know. Okay, so where were we? We were talking about the team that I work with. So we have a doctor, a nurse consultant, physio or exercise physiologist, dietitian, a clinical psychologist, an occupational therapist, and we're lucky enough to have a systems expert so that we can have a look at our program and figure out, is it working well? What bits are working? What are not? How do we need to look ahead to the future? what kind of research may we be able to generate from the kind of data and statistics that we collect. So this team that we've just described is put together to help the patient be informed about their heart failure. When you're delivering information, it should not be didactic. You shouldn't be lecturing at the patient. You need to take into account when you're teaching the patient about their chronic illness, you need to take account their hierarchy of needs. Maslow's hierarchy of needs has told us that patients are not really interested in learning about, depending on what they need. Their needs start at the very basic. The physiological needs come first. So they need food and water. If they don't have food and water, they're not going to be very interested about safety, belonging, esteem, or self-actualization. If they're safe, if they have a roof over their heads and they are safe, then if without safety, they're not going to be able to take any interest in the issues above that sort of level in the hierarchy. If they have part of a family group or a group where they belong, they are esteemed in that group, and then they'll be able to take other information on board and deal with that. But depending on what it's the physio's or the team's job to find out what is important to the patient and what they will, to enable them to learn and take on new information. Also, the stages of change, whether someone is ready to take on some information. We've known, for example, like if you're going to interact with them and talk about stopping smoking because it's very damaging to the heart, if they're not even thinking about stopping smoking, it's very difficult for them to sign up to the behaviours that are involved and the necessary behaviours involved in smoking cessation. So whether they're thinking about it or they're preparing to do it, they're preparing to stop smoking. So the information you give them depends on where they are in this cycle of change. And so they need to be ready and willing to make changes and take the action needed to improve their health. And that has to be taken into account when you're giving the patient the information about the heart failure. Also, you have to find out what literacy are they able to read and write in their own language? What sort of beliefs do they have about their health? Some people believe that their health is predetermined and there's nothing much they can do to change things. They have this disease and that's just how life is, and there's nothing will make any difference. So they're not prepared to make any changes or take part in any therapy. So you need to understand where the patient is while you're providing the education. The heart failure rehab also plans to improve their physical functioning. You have to carefully prescribe their exercise and progress their exercise. You have to monitor them closely so there is minimal risk of any problems happening. And also with heart failure, there's aggressive management of their comorbidities. The clientele that we have, often they can be elderly, they have other problems. If they have diabetes, they have COPD, they have arthritis. And so to maximise the effect of heart failure rehab, you've got to seriously go after those problems and help them proactively manage those other conditions as well. So also the teamwork that we do, we've got to maximise their psychosocial function. As I said, it can be quite stressful receiving a diagnosis of heart failure. If you can help them with counselling, point them in the direction of local services to help support them so that their mood and their function, they don't not plagued with depression, low mood. That's extremely important too. And also helping them to self-manage so that they can be self-efficacious. They can recognise their signs and symptoms. They can get early to the doctor. Their family recognises the signs and symptoms, and to help them manage the minute they see any symptoms of worsening heart failure, that they know they have a strategy that they can put into effect to get medical attention quickly and resolve the problem. And also if they understand how things, how their strategies, the local medical care is, they know how to use the local health and community resources effectively as well. So the elements of successful heart failure management problems means you have a number of health professionals so that you're covering all the aspects of issues that the heart failure patient has to face to manage his disease carefully. You get continuity between the family's primary physician out in the community as general practitioner, and also your facility or I work out of a hospital, so linking and liaising with clinicians, physicians and cardiologists at the hospital, as well as the patient's GP is very important. We follow evidence-based guidelines. We have the European cardiology guidelines, Australian guidelines for based on research, evidence that we put into practice to manage our patients in rehab. We have the successful heart failure management program can monitor the signs and symptoms, and so that's effective management. You can work with the family and the patient so that what you're aiming for, what are the patient's goals, what are the aims of care, because in later stages, the aim of care might not be to, not in rehab, but in heart failure management, is to move on to end stage and the end of life situations there. So the aim of care is very important that everybody's clear on that. Each management plans are individual for each client. One patient is not necessarily the same as another. There's no recipe that you can apply. There are evidence-based guidelines, but each patient has its own management, has his own management plan. And there's enough strategies and support for the patient's capacity to self-manage. We have some patients, they get elderly, their executive function starts failing. They have poor memories. They're not very good at problem solving. And so we see if we can find, family support or health professional services support the patient's capacity to manage his symptoms. And that there are behavioural strategies so that the patient can adhere to the management plan. What should he do? Where should he go? One patient's management plan was simply, if he felt unwell, he's to ring his daughter. So that's his management plan. It was very simple, but that's what his capacity was. And also, if for the successful management programs, you need to have some quality improvement, some improvement management systems for making your program better as you go along, to see what your client demographic is, what works for your program and your patients, and improve your program wherever you can. So to be eligible for rehab, you need a diagnosis, and echocardiography is the most effective way of diagnosis. You can have, as we've heard, you can have heart failure with a reduced ejection fraction. We know EF is normally 50 to 60, so heart failure is less than 40. Sometimes you have ejection fractions of 50 to 60, but the heart is stiff. It doesn't relax properly, and you still get signs and symptoms of failure. So the ejection fraction is preserved. To come to a class, predominantly, I'm talking mainly now about rehabilitation, that you can do progressive exercise. The patient needs to be stable for 2 to 3 weeks. Commonly, the New York Heart Association heart failure class is class 2 or 3. Class 1s don't have any symptoms and they're quite well, they're functioning well in the community. Class 4 are too breathless often to leave the house. So the rehabilitation program deals with class 2 to 3. And the patient has to agree to come along to rehabilitation as well. Sometimes we have patients that turn up and they're really not happy to be there, and they're here because their doctor said they had to. And so they have to agree to come along to 2 to 3 sessions per week. Now, I might just take an opportunity here just to say these slides that I have, I will send the PowerPoint presentation to the committee so that they can keep these resources there. So eligible, anybody that would like to go back through the slides again is very welcome to do so. So don't feel you have to be taking notes as we go along, because I will leave this presentation with you. We've already discussed, the previous speaker has given us a classification, class 1 to 4. People that can't come along to the rehab program, if they're unstable, they've got inflammation, they're getting unstable, their angina is frequent and not manageable. If they've got exercise, if they're assessed, medically assessed, and they've got exercise-induced ventricular arrhythmias, ventricular tachycardia. If they have decompensated heart failure, if they're fluid overloaded, they're extremely breathless and they need medical management, they're not coming to rehab. Also, if they've got significant aortic stenosis, we do take aortic stenosis, AS patients in rehab, but if it's severe, you have to be very careful. If these patients get an arrhythmia, it's very hard to bring them back. The aorta is stenosed, and doing CPR on these patients is extremely difficult. So if their AS is anything other than mild to moderate, we do some other kind of exercise therapy, but not in a group in the hospital setting. Also, we talked about eligibility. Some people do not like groups. We have people with psychiatric conditions. They're on antipsychotic drugs, and they don't fare well in a group situation. So they can have rehab face-to-face, one-to-one with a physiotherapist. They can still be active, but a group rehabilitation program in a community setting is probably not for them. Also, the patient needs to have, if their cognition needs to be satisfactory, that they can, have a reasonable idea of understanding where we go, what we do. They can take the education on board. Also, for heart failure, you need resources. So the main resource is you need space. You need enough room so that people can exercise. And certainly we don't have, at the moment, we don't have group classes because of the COVID-19 restrictions. We're doing all our rehabilitation now on telehealth by video as we are speaking at the moment. But enough space when we do start. We're making preparations at the moment to perhaps start again with maybe a couple of people, one-to-one, face-to-face, but I think we're looking for 4 square metres. But generally, without the COVID restrictions, before this all descended upon us this year, you need enough space to move and to have your equipment. You need to be safe as well, depending on the kind of patients that you're taking on board. You need to be able to monitor them. You need to know what their blood pressure is. You need to be able to listen to their lungs, and you need to be able to see what their oxygenation is. Pulse oximeter, as long as the patient isn't anemic, then a pulse ox won't be much help. You need some sort of resuscitation equipment. The incidence of events in cardiac rehab is very low. In 10 years of heart failure rehab, there was one occasion where a patient had a nasty arrhythmia and crashed, that we had to call the crash team in. And that's, 6 to 8, 10 people twice a week over 10 years. That was their one incident. So the incidence is low, but you should have some resuscitation trolley and a defibrillator close by. Certainly if you're taking class 3 patients. You need enough staff to run heart failure rehab. So commonly we have, there's myself, the nurse, and an allied health assistant. And with 3 of us together, we take a class of 8 to 10 heart failure patients. It's different if you're putting heart failure patients into a larger group of cardiac rehabilitation patients post-MI, post-stent. But certainly with 3 staff, we had a maximum of 10 people. You need somebody that you can call upon if you need assistance. For us, we're lucky, we're based in a hospital. If the patient is decompensating and too breathless, we put them in a wheelchair and just take them over to the emergency department, where a physician can review them and see how they're travelling, deliver drugs as appropriate. We're lucky to have interpreters as well. In Melbourne, we have many different languages spoken: Greek, Italian, Arabic, Vietnamese commonly, so we have interpreters. And we have someone that can evaluate our program too, to look at the system. Equipment, we've got aerobic equipment. We need equipment for patients who are non-weight bearing, for example, people with diabetes that have no sensation in their feet. We need to have some equipment for them. So we've got aerobic space. Some patients just walk. If they can't use a treadmill. So some aerobic work, space to walk up and down the corridor, for example. Non-weight bearing, we've got resistance. We have free weights. We have a few dumbbells. We've got some TheraBand, rubber band for resistance work. And just by the way, we have our chairs without arms. I tried to do a class where the equipment was chairs with arms. It was very difficult to kind of move and do your weight training. We have bariatric equipment as well for patients. We have patients with very large BMI They're wide and broad and very heavy, and some of the chairs and the equipment has a limit on it. So we've got specific bariatric equipment. And we have a plinth, a mat that we can lift up and down according to need. We've got material that we can hand out. We do translations as well, handouts, especially for the education component. We've got some music because we do chair aerobics for people that can't stomp up and down on their feet for some reason. They might have a foot wound. So we play music and we do aerobics in a chair. We've got exercise pictures. So we've got pictorial evidence for people that don't read as well. So if you're going to put, if you're experiencing cardiac rehab, the heart failure patients, you can work them inside the program as well. But commonly the difference between the heart failure rehab specific program and a standard cardiac rehab program is the ratio. You need more staff for heart failure patients. You need to be able to assess their progress from week to week. Commonly, standard cardiac rehab is once a week for 8 weeks. Heart failure rehab, it's 2 or 3 times a week for 12 weeks, even 24 weeks as well, because often it takes a number of weeks for the patient to stop deteriorating and stabilise as far as their exercise capacity is concerned, and then start improving again. The scheduling for heart failure patients, it should be in the morning because they can get progressively more tired as the day progresses. Also, if you have a heart failure patient, if they're going to be any arrhythmias, it will be after exercise. And so you don't do the education component before the class, you do it after the class so that they're still within your, in your area while they're sitting and listening. So you can continue to monitor them while they're having their education. You do the similar assessment when the patient comes in before class. You need to see what their clinical signs and symptoms are. They need to tell you if they've been to their GP and changed their medications. You do a quality of life measure as well. We do the short form 36 to get some measurement of their psychosocial functioning. Self-efficacy, I always find it's a bit of a red flag if the patient can give me no reason why they turned up for heart failure rehab, no issues that they want, no improvements they want to make. They've got no idea, why they're there, what they want to improve. They've got no goals. And even though you may affect some changes, lifestyle changes in rehab, inside 12 months, the patient with no self-efficacy and no help in that regard will just go back to living their life the way they used to. The education component's about the same for heart failure and standard cardiac rehab patients. They talk about, beneficial lifestyle changes. They've got cholesterol to change their BMI, to change, reducing the cardiac risks, the common cardiac risks that we know of. Again, you provide that education according to what they already know, their adult learning principles. They have a lot of life experience already. You tap into that when you're giving their education sessions, and also what they're interested in. If they're too busy worrying about other issues, they're not going to take on learning to do with themselves. And so the 2 extra education sessions that you must provide in that context are symptom recognition. So the heart failure patient needs to recognise when they're going into fluid retention, and they have to recognise salt, salt and fluid as well. Fluid restriction, why it's important to have a fluid restriction and stick to it, and why it's important not to eat salt to prevent fluid retention. The session assessment before they come in, before they start the class, they arrive a bit early before the class starts so that you can see, we put a pulse oximeter, we get their heart rate as well. Is their rhythm steady? Is their rhythm irregular? Often we get clients there in AF, but there's controlled AF, their heart rate's under 100. And so most of the heart rate should be under 100 because they're predominantly heart failure patients take beta blockers. It helps them live longer as well. So someone that's got a heart rate of 120 in a heart failure class Most commonly we find is that they haven't taken their tablets this morning, so that's a question that we ask them. You need to know what their fluid load is, so we take their weight. So we ask them, have their medicines changed? Have they taken all their prescribed medications? What is their weight? They go to the scales, and before every single class, they see where their weight is. Are they peripherally warm or cool? If their weight has gone up a couple of kilos, we need to have a listen to their lungs as well to see if they've got crackly lungs, so their fluid retention is happening. And we need to see how breathless they are. And did they get tired after the last session? So that's the main difference between standard cardiac rehab and heart failure patients. What you see is not what you get. You can prescribe some exercise. We'll get into this in a moment, but if you prescribe exercise, they might be able to do the activity that you prescribe that day, but they might pay the price later. They might get very tired later that day or the following day. And if they have diabetes, we check on their blood glucose levels, and if they have COPD, we see what their oxygen saturations are as well. So the exercise prescription changes is not the same between cardiac rehab and heart failure patients. The standard cardiac rehab patient improves week by week. They're healing after their stents or their bypasses or their infarct. They're getting better every week. Their health is improving. The heart failure patient, on the other hand, can be fantastic on a Tuesday and be very poorly on a Thursday. So we saw the graph earlier about episodes of acute decompensated heart failure. Every time the patient goes into one of those, they never really get quite back to, as well as they were beforehand. There's a steady downward decline. They recover from the acute heart failure, but they're never quite as well as they were before. And after 5 years, their function has deteriorated commonly quite severely. I'm not sure whether the aggressive management of comorbidities for a standard a cardiac rehab patient that's had a stent, and they come in complaining of aches or pains, you say, look, you must see your GP about that. Go and talk to your GP. You can leave that with the patient. They will sort that out themselves. I find the heart failure patients, they're tired and breathless, and they need help managing their comorbidities. I refer to other physios for musculoskeletal problems so that the expert can deal with them on an individual basis as well. The heart failure nurse consultant gets them in to see the cardiologist a bit sooner than their next appointment, rather than leaving it up to the patient as well. You kind of deal with issues there and then. You don't rely on the patient or the family to help sort out health issues. We can help them with that. The standard cardiac rehab patient, if he's had a heart attack or bypasses, often their mood can be low, but it's usually reactive. It's a big shock to discover that you've had problems, that you have a heart problem. But the cardiac rehab patient, depression can be short-lived. They get back to their lives again. The heart failure patient, on the other hand, has episodes of decompensated heart failure and needing to go to hospital for management. And so their moods, their lowering mood, their depression can actually be longer lived and might need some medical help. When you're prescribing heart failure exercise, what their ejection fraction is not necessarily indicative of what their functional capacity is. I've worked with clients whose ejection fraction is 12%. And they still walk into the rehab gym and they can talk quite well and they use public transport to come to the hospital. They have a reasonable functional capacity. And so you can't always think that they're going to be in very bad shape because they have a lower EF. Similarly, I've had patients with, 38%, 35% EF, and they can barely leave their wheelchair. So it's not necessarily related. Okay, when you're prescribing heart failure exercise, the Borg scale, you need work more than half of their maximum, their VO2 max, their maximum oxygen uptake, in order to improve their cardiorespiratory, their endurance. But luckily for us, clinically, we don't need intricate medical tests to give us a VO2 max to be able to tell us where we tell the patient where they need to exercise at. Sorry, 1 minute. Okay, get rid of that. We're able to tell them on the Borg scale, the rating of perceived exertion, that somewhere between medium to a bit hard is a training zone. So when they're exercising, if it's easy peasy, then we'll make them work a little bit harder, because the training zone for cardiovascular efficiency to improve your oxygen uptake is somewhere between 11 and 13 on the Borg scale. We have a modified Borg scale from 0 to 10. The patients find that easier. So we need them to feel like they're working between a 3 or a 4. So medium to a little bit hard maybe is where we need them to work when they do their exercise with us. How long you get them to exercise for, it depends on their symptoms. If they're very breathless, they might do a minute of pedaling on a bicycle and then they stop and have a rest. Then the interval training, if you can, it helps improve their cardiovascular efficiency rather than steady state work on exercise, bike or treadmill or walking. You can go from stop and start. Very severely breathy patients, they do 30 pedals on some floor pedals and stop until they get their breath back. And the upper echelons, the patients can do 15 minutes on an exercise bike at the level that they would describe as a little bit hard. So the variation between there, you depend on their symptoms. But what they do need to do every day is go for a walk. So they come to exercise rehab 2 to 3 times a week, but they must do some walking every day as well. When you're providing resistance training, that's also to help local circulation. If you have, you can impact peripheral circulation so that their vascular resistance is low. You've got good blood supply in your arms and legs. It helps reduce the work of the heart. They've got good blood flow peripherally. You want strength. We have patients come in that can't get up out of a chair without assistance. We have patients working on their stamina and endurance, so they're not so tired. You can do commonly the kind of weights that we have people lifting in heart failure rehab between 1 kilo to 2 kilos. We end up with 3 sets of 10 repetitions. And as long as the patient isn't extra tired after the last exercise session, if they're saying that, no, that was pretty good, yes, I didn't, I've got no muscle aching, no, I didn't get extra tired, I get a little bit tired, but the exercise didn't increase my fatigue, then that's about the right level, and you might look at increasing their exercise as well. We're lucky enough to have lots of machines in the physio gym at St Vincent's Hospital, but you don't need machinery. People like exercising on flashy looking silver machines necessarily, but you just need some weights. If machines help the patient engage, they like working on the machines, some patients just do, then that it helps them adhere, then that's good. But really free weights. And at home, I get patients to start off with tin tomatoes at ½ a kilo each and see how they manage as well. So it all depends on what their assessment is. Before the program assessment, I forgot to mention that we commonly use a 6-minute walk test to determine their exercise capacity. And the 6-minute walk test, we find that people who manage less than 300 metres in 6 minutes, they're often at the lower end of the spectrum, and we can start quite slowly with those clients. The patients, they describe being very tired, needing to sleep for a couple of hours in the middle of the day. So a 6-minute walk test is very handy as well for functional capacity to know where to start. The resistance training, it's the same as anybody doing resistance training, strength training, alternate days, upper and lower limbs, alternating exercises, large muscle groups. Where are we? 75% of a 1 rep max. So if we have patients, it's easy to find out on how much they can lift one repetition. And so what they're doing sets of 8 to 12 is 75% of that maximum lifting capacity that they have. But I'd say for most heart failure patients, I give them 1 or 1.5 kilos to start with and give them 8 repetitions and see whether they get tired later on. The other thing they must do is breathe as you move the weight. If the weight is too hard for them to lift, they will breath hold to stabilize their trunk, trying to use their arms. So they have to count aloud as they're doing the repetition of the exercise for resistance training. This is fairly standard training. Physiotherapy staff are well familiar with protocols for this. So what we do before we do the class, how we run our class is patients come a bit earlier. We do their assessment, their heart rate, have they taken their medications, their weight, their symptoms. The nurse and I and the allied health assistant, we liaise to see who's fine today, who is a little bit breathless, who is not in good shape at all and should go home or stay and be taken to see a cardiologist while they're here. Then we do 10 minutes of warm-up exercise. As we know, patients on beta blockers take a longer time to warm up. They need to wait for the brain needs to read the circulatory byproducts, the metabolic byproducts of exercise before the brain makes their brain, heart increase rate. The beta blocked patients don't have that sort of instant response to exercise that non-beta blocked patients have. When you're warming up as well, we do stretches too, but stretches don't help prevent sprains and strains, but warming up does. Then after the warm-up, we do 20 minutes activity, either aerobic or strength training, one or the other. Then we sit everybody down and take their heart rate again and how much work they found that their exercises. Then we do another 20 minutes with rests as needed by the patient themselves. And then we do measure heart rate and oxygen level, their rating of exertion. So I know whether they found it easy and I can put the exercise up for the next class or not. Then we do a cool down as well, making sure that we reduce lactic acid buildup. Then we all go to the education session with drinks or snacks. And then the clinicians have a chat again about how the class went, who did well, who needs more attention. So you modify your script depending on the symptoms, if they're more breathless, if their weight has increased, if they're retaining fluid, if they've got ankle swelling, if their waist measurement has gone up, if you can hear crackles in their lungs. The symptoms again, were they tired after the last session or did they do well? They felt quite well. Do they have any new arrhythmias? The nurse consultant, the cardiac nurse consultant may do a rhythm strip to see if they're complaining of any new irregularities and to find out whether the patients have been dizzy or not. In regard to that, in referring to the last speaker, we often find because the patients have ACE inhibitors and beta blockers on board, the common blood pressure level that we have for our heart failure patients, because we've reduced the work of their heart quite a lot in order to minimize their symptoms. A very common blood pressure that we have is 80 systolic. So commonly we have 90 systolic. Very rarely, I would say, our patients who are on maximum medication, they don't often have a blood pressure over 100, and it's quite common to have patients with blood pressures of 80 systolic without any symptoms. They're not breathless, they're not tired, they're not dizzy, as long as they remember to stand up from the chair slowly. So we take that into consideration. Nobody jumps up from a chair in heart failure rehab class. So how you progress depends on how old they are, what their comorbidities are. 92-year-old lady in heart failure rehab with a lot of arthritis is not going to progress as well as a 42-year-old gentleman with heart failure, drug-induced myocardial destabilization. So depending on what they prefer as well, you can progress their aerobics in the order of frequency. You start with 5 minutes and then you can do some walking at home, 5 minutes in the morning, in the afternoon, in the evening. Then as they get better, they can do 5 or 10 or 15 minutes in the morning or the afternoon. And it's when a patient can do an hour of exercise that you can actually make the intensity of the exercise increase that a bit more. For a lot of the patients, for the heart failure patients, I spend a bit of time encouraging them not to be being frustrated, because I have actually slowed them down. I've made them walk more slowly because they get so breathless. I've given them a kilo to lift that they think is, very minimal, and, they're waving their single kilos around until they understand that an hour of exercise, the class lasts for an hour. And if they're doing physical activity with me, they have to begin slowly to see what the effect is 24 hours later. So we're still aiming for a 10-minute period of exercise in the class. Some people can't do that. They do a minute of exercise and they have to sit down for 5. And we're always aiming for the general guidelines is 30 to 60 minutes of exercise throughout the day for everybody, including me. So the intervals, you get them to stop and start their pedals or their walking until they can manage to sustain, 10, 15 minutes on a bike. They might go slower, and the interval is a faster interval inside that period. And of course, you increase the resistance training by making them do more sets of repetitions. I get them to do 3 sets of 10 and not be tired, whatever weight they're using, not be tired later that day or the following day before I put their weight up. The progression, I find I often start patients without any weights at all if they're very breathless and very tired. Lots of positive reinforcement. Sometimes the patient, you do more listening as well. You engage with them so they want to come back. They don't find the exercise too hard. A common presentation is, I'm so breathless already, why would I want to come along to an exercise program? So they have to engage with their rehabilitation. I don't want their symptoms getting any, discovering that they're more tired and more breathless after they did the class. And so a couple of sessions where they're stable and they're well before I put their exercise prescription up. And I either increase their weight training or their aerobic, but not both. I just thought you may be interested in the education calendar that we have. As you see, the team contributes their education session as well. We even have a speech pathologist contributing as well. So I do a talk, dietitian, the nurse. This one doesn't actually have the OT. This is a program, our OT was on long service leave. And so the OT commonly does a session on relaxation, and also does a session on energy conservation, which is very important for heart failure clients. We have people that have their comorbidities. If you have clients with diabetes, if they don't measure their blood sugar and they haven't had any breakfast, they didn't bring anything with them to eat, they don't join the class. They go and get something to eat for breakfast, and they measure their blood glucose before we let them in the class. If their blood glucose level is so high that they have ketones, we consider having them sit out as well and manage their diabetes and discuss with the nurse managers. Also, for diabetes patients, we try to get them to exercise daily. If they're insulin using, that insulin dose will be on a daily basis. And if one day they do a lot of physical activity and the next day they do nothing because they're too tired, because I didn't prescribe appropriately, that's very difficult for their blood glucose management. Type 1 diabetes patients, they need to monitor a little bit extra for 24 hours. The effect of a single exercise session can impact on the blood glucose for 72 hours. And also, as we've discussed before, patients with problems in their feet, you have to have some non-weight-bearing exercise issue. We have clients awaiting transplant as well. We need communication with their cardiologist, quick access to the cardiologist. If there are any issues arising, we need medical advice. They still need to keep mobile and keep as much functional activity as they can before their transplant, so they're not getting more and more debilitated. But the nurse consultant pays very close attention to their symptoms. They might need blood tests if their renal function is going off, their liver function is going off. And so the nurse consultant is very much engaged with the transplant people, but the exercise prescription is still the same. They start at a low level of activity and they can progress according to their symptoms. I think we've spoken about heart failure rehab, the heart failure patients in an already established cardiac rehab group. So the education sessions that we've discussed, you have to include fluid management, salt. They have to know how to self-manage themselves. They've got to weigh themselves at home every day. They've got to recognise their symptoms, get to the GP early, and also don't keep up with your neighbour on the exercise bike, because that might be a post-stent patient who's previously healthy and well, so you're not to keep up. There's no competition between the clients in rehab. And there has to be good communication from medical. Medical staff have to advise. As I said, we're lucky. We can just take our clients up to ED if the cardiologist is not available. We have pulmonary hypertension patients as well. Whatever their etiology, a lot of heart failure patients have some pulmonary hypertension, but the goals are similar. You're going to improve their exercise tolerance, their long-term outcomes. You monitor their symptoms. You keep close contact about their medication, close contact with their medical health professional, and they still progress their way through rehab with, again, improved function and less breathlessness. Sometimes with troubleshooting, if you're having heart failure rehab, if you're trying to set up a heart failure program, how many heart failure patients do you have in your local area? If there's resources to be spent setting up a heart failure program, because there are a lot of clients that can do with the physio expertise and the expertise of the heart failure rehab program. What kind of funding are they going to give you? You need a minimum of 2 people. You need a medical person, a nurse consultant, or a GP who's involved, and you need an exercise specialist. The Heart Foundation recommends 8 people in a heart failure rehab class. But really we've found if you've got 5 or 6 people in a class and 3 of them that are unwell, that's your 3 staff already engaged in further assessment of the class as well. So we haven't had a class of 8. Commonly our class is a maximum of 5 or 6. Depends where you want to hold. If you're setting a rehab, where do you want to hold it? At home, in a hospital, in a community site? And what is your equipment minimum? How much space do you need? How much physio exercise equipment do you need? What have you got? You need to be able to monitor them. You need to provide some education materials. So resources, you have to have enough resources for the kind of what class heart failure client you're going to be seeing, and where you're going to be holding the class. If you know that there are heart failure rehab patients that can do with your expertise, but you're not getting referrals, because there needs to be a medical referral because you need a diagnosis, an echocardiogram and a diagnosis for referral to heart failure rehab. Do you have a doctor who can champion your cause? Most doctors are aware now, or cardiologists are aware, that exercise is an important part of the non-pharmacological management of heart failure rehab. So if you can find a cardiologist that can champion your cause so you end up with resources, funding for heart failure rehab, that's very good. And if you're the first to start the heart failure rehab, once you can market your expertise to the medical fraternity, they will be very happy to refer into your program. The patient safety is the primary aim. You must do no harm. So you have to have the resources and the staffing to be able to deal with type 1 diabetes clients, frail people, elderly people who can only manage. We've had clients that can do 150 meters on a 6-minute walk test. They're very debilitated. They're very breathless. So you need the staff. We have a defibrillator. When they were made available, we're lucky here in Melbourne, our supermarkets have defibrillators. Our local newsagent has a defibrillator. But with heart failure clientele that can be subject to nasty arrhythmias, it's certainly for safety, it's very much in demand. And again, you need to be able to access medical experts, nurse practitioners, cardiologists, the doctors available. Also, will patients come back to your class? We have issues here with Melbourne is a very spread out suburb, and come along to the heart failure class, the issues of transport. But now we know that Zoom is a very effective modality that you can help people exercise at home. Again, you need access to GPs and medical experts as well, but your resources are important. Also, we have in Melbourne, we have culturally and linguistically diverse populations. We have many elderly Greek, Italian, Vietnamese people that don't speak English. We also have Aboriginal and Torres Strait Islander clients as well, who have a different cultural set of beliefs. And also we have private health insurance here that we have to consider as well. So all those aspects are part of the heart rehab. Patients have to realise, know that there's a benefit for coming to rehab, and they have to believe that they can get a bit better, because when you have people that it exhausts them just turning up to the gym or the rehabilitation program, it's very difficult for them sometimes to think that they're going to get any better. And so you have to be able to engage and change their beliefs that if they just stick with it, you can help them feel a bit better, be less tired and less breathless. Their activity program has to be realistic. There's no point in teaching them how to lift their weights, you know, how much weight are they going to do above their head, even though it's good for their muscles, but there has to be, to help them engage, it has to be realistic and relevant. You don't want them to be able to join a marathon next year. You want them to be able to walk to their letterbox down the road and come back again without getting breathless. So whatever goals you set have to be realistic. And also, as we know, physiotherapists can be very charming people. We've had many grumpy people patients turn up for heart failure rehab, but we've been able to engage them and explain to them how important it is for them to keep mobile, not to sit at home because they're breathless, but to do a little bit every day. And we're always able to help them realise that it's good for them to exercise. Won't talk about that one. So in summary, heart failure rehab's well-established modality. How you run heart failure rehab depends on what your resources are, what clientele. Are you only going to take class 2 people that only have slight impediment to their physical functioning? If you have a cardiac rehab program, you can put your heart failure patients in amongst the standard cardiac rehab patients, but with important differences as well. And you have to consider the issues of how you're going to get the patients to keep returning, the clinical management, supervision, reassessment constantly, and also your patients must be very safe. Thank you very much for your attention. Happy to take questions.
Thank you very much, Dr. Mohra. Nice presentation and enlightening to all the physiotherapists in this country and the world. So we are very much happy to have you as a resource person for this conference. Over to you, Dr. Trupti, sir.
Thank you, ma'am. Thank you so much. Thank you for your presentation, and we are glad that you accepted our invitation and you are the presenter for today. Okay.
I apologise. I think I've gone slightly over time. I do apologise for that.
No, madam. You are in time. You are in time.
You are in time. Okay. So with this, we'll end with the scientific session. And for the next, we have the panel discussion ahead. I hope all the panelists are there in the meeting. Thank you, Moira ma'am. Thank you for your presentation.
You're welcome.
Ma'am, you can stop the slide share from your side.
Yes.
Good afternoon, sir.
Yeah, good afternoon, everyone. Good afternoon, Vadraj, and good afternoon, everyone.
Good afternoon, sir.
I thought I have joined that. Actually, the session was going on, so I was just confused whether I've joined the correct link or not. That's why I got disconnected and then connected again.
This is the last scientific session.
Okay. No, that's. I think.
We are all in time.
Yeah. So that's good. Thank you.
My video is visible, sir.
Good afternoon.
Yes, sir.
Yeah. Good afternoon. Good afternoon.
I'm Ganvi, sir. How are you?
Yeah, fine. Good.
Actually, I'll not be knowing most of the people except Dr. Vadraj and maybe Dr. Sudeep Kale. I think I've not spoken to anybody. I've not seen anybody, in fact.
Yeah, I will introduce, sir. I will introduce all the members to all of you. Dr. Tushar sir is there?
Yes, sir. Very much here.
Yes, sir.
Good afternoon, sir. Good afternoon to all the panelists and the viewers here.
Unmute करना है.
Hope all of you had lunch.
Yes, sir. Very fast.
So, if you are an offline conference, if it is an offline conference, you all could have been in our campus and we could have enjoyed the day.
But now we are having the feeling of that we are in the campus only.
Yes. Welcome, Dr. Ujjwal, sir.
Sir, good afternoon. Thank you. Thank you for inviting.
Dr. Sudeep Kale, sir, will be joining. Then immediately we will start the.
Already joined, sir. Long back.
Sir is there.
Yeah.
Already joined.
Sir is very well there. Good afternoon, sir.
Good afternoon.
Good afternoon, Dr. Sudeep. Hope you are doing well.
All is well, sir. Thank you. How are you, sir?
Yeah, I'm okay. I'm also fine. Doing okay.
Madam, all five should be. So you will be starting there. Yeah, like that. Yes. I sent you the form of the leave form guidance for you, and according to I'm in a confusion.
Sir, shall we start?
Yeah. We can start.
Ladies and gentlemen, good afternoon to one and all. Greetings from Krishna Institute of Medical Sciences, deemed to be university, or KIMS DU as it is fondly called. Spread across a spawning 54 acres world-class campus, the institution right from its conception in 1982 has been a pioneer in medical education, research, patient services, and environmental consciousness. Krishna Institute of Medical Sciences, deemed to be university, is accredited by NAC with A grade. It is also an ISO 9001-2008 certified university. Krishna Hospital and Medical Research Center is accredited by National Accreditation Board for Hospitals and Healthcare Providers. Neonatal ICU is accredited by National Neonatal Forum of India. Blood Bank is accredited by National Accreditation Board for Hospitals and Healthcare Providers. KIMS Diagnostic Laboratory is accredited by National Accreditation Board for Testing and Calibration Laboratories. With due permission for testing and management of COVID-19, we have more than 2,500 COVID patients successfully discharged from our institution and also started plasma replacement therapy for critically ill. The university is also recognized by Malaysian Medical Council and Medical Council of Sri Lanka.
It is my great pleasure to welcome you to the panel discussion of International Physiotherapy Conference, Knospe 2020.
Physiotherapy profession is the profession which goes hand in hand with other healthcare professionals pertaining to physical healthcare.
Be it general physicians to super specialists, be it nursing to dental and allied health professionals, physiotherapy profession merges with all the healthcare providers.
To bring all the related professions on a single platform and allowing them to express their views regarding timely coordination and its importance on quality of life of physical healthcare in the case of all therapeutic conditions.
The theme of the conference, Health Professionals' Integrity, is the hallmark of physical therapy and rehabilitation, was put forth.
So now I welcome the panelists for the panel discussion on Physiotherapist as an important integral member of healthcare profession for the welfare of various stakeholders of our physiotherapy profession.
We take privilege to welcome our panelists, Dr. Sudeep Kale, Dr. Tushar Palekar, Dr. Rakesh Kumar Sinha, Dr. Shyam Ganveer, and Dr. Ujjwal Yeble.
I also welcome the moderator for today's panel discussion, Dr. G. Varadrajulu, Dean, Faculty of Physiotherapy, Karad. To introduce our moderator, Dr. G. Varadrajulu, having 24 years of professional experience in administration, teaching, and clinical areas, graduated from Tamil Nadu Dr. MGR Medical University in the year November 1996, and post-graduation from MG University, Kottayam in the year July 2002. A challenging neurophysiotherapist having excellent leadership qualities. Presently serving as Dean, Faculty of Physiotherapy, KIMS TU Karad, Maharashtra, duly from October 2002 to till date. Having research background of guiding more than 25 staff projects, 75 post-graduation dissertations, and numerous undergraduate projects during the tenure of his service. So far, he is having 5 publications as first author, more than 25 publications as corresponding author in his credit. He is awarded twice National Level Distinguished Service Award by Indian Association of Physiotherapists. He is always a visionary physiotherapist, wanted to take up some professional development responsibilities in this part of country. Presently taken the responsibility of President of Satara Physiotherapist Association and also working as founder member of establishment of Indian Neurophysiotherapist Association. We welcome you, sir.
So thank you very much for the introduction and welcoming all the panelists. So once again, wholeheartedly welcoming all the panelists for this panel discussion on the topic of, you all might have aware of by this time that the 2 days of conference is going on with the theme of health professionals' integrity is the hallmark of physical therapy and rehabilitation. And almost all of us are heading the various institutions in Maharashtra. And of course, Dr. Sudeep Kale sir is here, who is heading the entire physiotherapy community at the state level, being a council president of our prestigious state of Maharashtra. So we are the people who can definitely go for some thought-provoking or brainstorming discussion on the the theme as well as the topic which we are going to put forth in front of all of us. So the topic for all of us that just I thought of out of my experience in this in our profession is that is related to our theme only. Physiotherapist as an important integral member of healthcare professionals. So whether we as a physiotherapist, whether we are volunteering ourselves to integrate with other health professionals for the welfare of our stakeholders. This is what is the topic which has been there with us to discuss. And before going into the topic, it is my great pleasure and privilege to introduce all the panelists who are really pioneers in the field. And to begin with, I will start with my own teacher and my own principal when I'm doing my PG, Dr. Rakesh Kumar Sinha. So Dr. Rakesh Kumar Sinha is graduated from the NAOH, then postgraduate from the Tamil Nadu Medical University. Sir is having more than 25 years of teaching, administration, clinical experience, and a renowned teacher because whatever he taught me the basics, still it is continuing, still continuing with me, and it will be there till my last breath also. So that is the introduction to my own teacher. And next to the Dr. Sudeep Kale sir, who is an young, dynamic leader, true leader, who is having the good visionary on our profession. Of course, who is representing our profession, state level, national level, at wherever he come across the professional need and some legalities to be formed, and Dr. Sudeep Kale is there. Really, he doesn't require any introduction in Maharashtra, especially, even in India also. We are very much pleased to have you, sir, in this as a panelist for this today's discussion. And my own friend, Dr. Tushar Palekar, sir, we both are togetherly working in Maharashtra from past 18 to 20 years. And of course, sir is initially worked in Pravara institution, then now is heading the D.Y. Patel College of Physiotherapy. We are very much, both of our thinking is almost same as far as the professional concern, professional growth and development is concerned. We always share many, we were togetherly shared many as a judge, examinership, chairmanship, many things, many. There is no much differences between myself and Dr. Tushar Palekar sir. And then come to the Dr. Ujjwal sir, who is heading the Maharashtra State Association, president of IAP, Maharashtra State branch. And really, Ujjwal sir also, many times he was joined with me, he was with us during many ventures of our college, and he is a well-wisher of Varadarajulu in fact. So I'm overwhelmed to welcome Dr. Ujjwal sir. And
thank you, sir.
And one more important panelist today for whom I am very much happy to introduce. Maybe the first time we were together and henceforth we are going to be together. That is Dr. Shyam Ganvir sir, who is the principal of V.K. Patel College of Physiotherapy, Ahmednagar. And God has given me time in 2020 in Corona time on this panel discussion to come together and work together for the betterment of profession. So with this brief introduction, I welcome all the panelists for this important panel discussion on the topic of where a physiotherapist as an important integral, whether we are volunteering ourselves to be as an important integral member, how much extent we are giving the importance to this concept of integration with other health professionals. In this topic, we are going to discuss. To begin with, so I wanted to ask all the panelists to share your view on the theme of this conference in brief, in 1 minute, all of you. Your views about the theme of the conference. You can unmute your mic and you can share your thoughts. Dr. Sudeep Kale, sir.
Sir, first of all, thankful for giving an opportunity to interact on this topic and also for good introduction. I am of opinion that good people always speak good about others, and because positivity has to be there, and this concept which you have given. Yesterday also I have spoke. This is not your first time. This is the second one. Previously, you have taken the opinion of all the stakeholders, and in this theme, you have tried to highlight the importance of physiotherapy. Not only that, but towards the delivering a quality services to the people. Such kind of themes, they are important not just for the thought process or the discussions, but ultimately resulting into the quality services to the people of this great nation. I'm thankful that the institutes of physiotherapy are taking this on the agenda. This is, or I think this was missing link, missing area of Indian physiotherapy. And now the government of, as well as the public is also getting the idea that physiotherapy is an important paternity. And I am thankful that Varadarajulu sir, the team, Vice Chancellor sir, Pro Chancellor sir, has taken this on the agenda for volunteering the services to the people, and that is with the integration with other. I hope all the physiotherapists will take a good message from this and they will deliver best to the society, the people of India. Thank you.
Thank you, sir. Dr. Rakesh Kumar Sinha, sir.
Yeah, thank you, Dr. Vadraj, for the nice introduction. And yes, truly it has been a long and what do you call, I say, enjoyable journey for the last more than a quarter of century that I have been dealing in this teaching in this profession and doing administration and teaching. But it is good. The thing is the way it has evolved from the times when people were not knowing about what is physiotherapy. When we talk about 25, 26, 27 years back, the integration of physiotherapy into most of the different health systems was quite less as compared to when we see today. I think it is not that whether it is the patient or whether it's the other health professionals, even the health professionals, they are quite aware of the role of physiotherapy. There are few people still like we have to start keeping on working, but the integration which was there around 25, 27 years back and the integration which is in 2020 is totally changed. Now, whether it is a field of neurology, whether it's a field of cardio, nobody thought like 25 years back that we are going to use this we need cardio physiotherapists in this. It was very rare on only in some specialized centers where you can think of having a physiotherapist in the ICU. Very rare. But now, where do you find? Which hospital doesn't find a physiotherapist in the ICU? It's very rare. So that integration, and when we say about rehabilitation means integration. Rehabilitation means integration. It cannot happen without that. Integration not only of the professionals, integration of the patient also. So he's the most central aspect to that. And that is what I'll say. This is a very important topic now, and all of us have to be aware that what we do and how good we are, that will itself show how integrated we are going to become. The person in front of us, the other health professional, should see the importance when we do something. That is what where we all should be very, very clear and very good in our practice and knowledge. Once we do that, I think integration is always going to be there. So thank you, Dr. Vadraj, for providing this opportunity, and I think we'll have a very fruitful discussion. I think that's what I hope. Thank you.
Dr. Tushar Palekar, sir.
First of all, a warm welcome to all the panelists, viewers over here. Dr. Varadarajulu sir has given a very nice introduction of all the viewers and the panelists. So first of all, a big thanks to him. I also would like to thank him for a continuous message that he passes through the SNOP that he conducts every year. And it's a different, unique conference. When he started SNOP for the first time, when I had been there for the conference physically also, if you remember, we had spoken that in a place like Karad, this is slightly difficult to do, but you have managed at that time itself so extremely well. And you have shown and proved that you should not judge a book by its cover. So hats off to you, Varadarajulu sir, and the entire team of your top management who is always supporting you. I remember the kind words of Honorable Chancellor sir, Ved Prakash Mishra, who always says that something needs to be done. It should be measurable and measured. And that is what abruptly and absolutely Varadarajulu sir is doing basically. So hats off to you. And the theme of this conference is very well chosen. It's the health profession integral part that is required. It is also a part not only which is required a part of curriculum, but also a part of clinical making. So clinical decisions need to be based on various parts of integrity, and that is what I think he is communicating to us since yesterday with his series of the conference presentations, where medical, dental, and various other faculties are also involved along with physiotherapy, and that is how he has brought in the integral form of the health professions together. So that's a big congratulations to you from my end, and I heartily congratulate you, the participants who have been here throughout and listening and hearing to all the deliberations given here in the two-day conference. It's a very unique thing that you are a part of the Physiotherapy, and that's also a integrity that you have shown amongst the professionals. So that's again a hats off situation for the entire program. Thank you for even inviting us on this panel.
Dr. Sam Ganwar sir. Shyam sir.
Thank you so much, sir, for inviting me for this conference. At the 11th hour, you have called me and I accepted your invitation. The theme, your question was regarding the theme of your conference. I have seen the theme and I have attended the conference without your permission. Sorry for that.
It's my pleasure.
But the theme was very interesting, and that's why I entered into the presentation. And I have seen that the excellent presentation was given by the resource person, and the theme what you have selected regarding integrity, that is very important, because myself, I have done some interdisciplinary program in the PhD program from MUHS. So I know what is the importance of the interdisciplinary and the integrity program. And sir, I really thank you that you have developed integrity not in the interdisciplinary, but bringing the integrity among ourselves, that is more important. And that is what you are proving through this conference. So that's what I want to talk about the theme. Further, we will discuss about this panel. Thank you so much, sir.
Dr. Ujjwal sir.
Yes, good afternoon. Good afternoon, all the panelists, my respected teachers, the delegates who are attending this discussion. First of all, I must congratulate Dr. Varadrajulu sir for always keeping up and coming up with the innovative ideas while deciding the theme of research platforms and the conferences. I was also fortunate, along with other teachers, to be a part of the conference which was organized in 2016. Involvement of the stakeholders, where even the patients were being called on the platform to share their views. And I feel that was really an innovative approach, where we can actually discuss on that platform the patients' ideas and their feedbacks, from which we can very well update ourselves and upgrade ourselves. Again, this year, sir, I must say, for this panel discussion topic, as well as overall the theme of this conference, were integrity of all healthcare professionals. And what I learned from these 2 days, that the resource persons from medical field, dental field, and nursing field, this integrity is really going to help out in overall patient management and patient treatment. I must say, when it comes to teamwork and integrity, physiotherapists are always having the first hand to come with. Yes, and I hope to go with a very conclusive discussion during this panel. Thank you so much for calling.
Okay, sir. So thank you very much for you all in line with thinking of mine. I'm really wholeheartedly I thank from my bottom of my heart, because that will give me the energy to proceed with the topic. The next question to all of you that because most of us are almost experienced more than 10 to 15 years, and some of us are more than 20 years, and my own teachers are there. So I wanted to ask you, what are all the factors which may affect the health professionals' integrity in real sense, in real practice when it comes? What do you think? These are all the factors, sir. These are the factors, sir, which is affecting our integrity in real practice. Because theoretically, integration, but practically when it comes to the real practice, what you all feel That these are the factors solving which the true integration will happen. Anybody can answer. Whoever taking up.
Sir, I feel I am there. Sir, I am there.
Yes, sir. Yes, sir.
Yeah, the question raised by you, sir, it's very nice. It's like touching to our heart because, yeah, it's audible, sir.
Yes, sir. Yes.
Yes,
Yeah.
yes.
The question raised by sir is a very beautiful question he has raised because why I'm talking about this, because now I am working in the rural setup. And I am very thankful to our management that they have given the opportunity to work in the rural setup and to run college in the rural setup and to make understand the people and to doctor is a very tough job. When I moved to the conducting the camps and conducting some extension activity, outreach activity in the field, I have to make them understand from very layman language about the integrity program, about the condition. For example, if you take any type of condition, now you know that we need medicine also, we need an orthopedic surgeon also, we need some surgeon also, and we need some other field work also. But then in our place itself, to make understand to our professional like medical profession and all, from there itself our job start very tough to make them understand what I feel. And then here we have to prove ourselves that how we can develop the integrity among our specialty number one. Instead of going to the other specialty, medical profession specialty, we should have integrity among our specialty. For example, when you talk about the cardiorespiratory, or when you talk about the community, when you talk about the neurological disorders and all. So there has to be integrity among our specialty, and then we have to prove them about the integral program, and then only they will understand what is the importance of the integrity, and then we can go slowly to the field work to make them understand with the medical profession. And that's why we have started here like integral teaching also, integral teaching that we have started in our institute to make understand the other people, medical profession, how integral teaching is going to help the student. Because as we are talking today, our bread and butter is depend upon the student. Very frankly, I'm telling you. Similarly, the patient is our God. We know that if the patients are there, the hospital will run. So we have to see the welfare of the patient also. So how the integral program will work on the patient. So to make them the understand. So we have to start ourselves an integral program to set one example for the medical profession. Then only they will understand, and then they will mingle with us to develop the integral program in the benefit of the patient. But setting in the rural setup is very tough job to make them understand, but still we are trying our level. And now today 80% people are accepting our program, and they are getting involved in our outreach activity, extension activity, and for the welfare of the patient. That is what we are doing in the rehabilitation. Like Sinha sir also told that rehabilitation is a teamwork and it is an integral program itself. So we are having the whole team with us, like orthotic, prosthetic, social worker, orthopedic surgeons, one junior residents are there. And we form one team for the rehabilitation, and we move outside in the benefit of the patient. But it is a tough job. It is not a very easy job as staying in the rural setup. Thank you so much, sir.
Okay.
I will like to add this. This is Sudeep Kale. Am I audible?
Yes, sir. Yes, sir.
Yes, yes.
The first thing is that first difficulty is lack of professional knowledge. What a physiotherapist can do, this is till there is a lot of unclarity to most of the healthcare profession. So that is one of the barrier for this linking of these three different professions. Second thing is communication barrier. This is one of the important barrier, because how to communicate with other faculties. That is one thing. Sometimes it can, most of the things, sometimes we take it on the personal grounds, and sometimes related to the egoistic issues also. These are also the problems or the barriers. And third thing is that I think the scope and thinking of a physiotherapist itself also is a barrier, because we have to move outside. We have to collaborate with the people for the benefit of the people. Most of us are happy in what we are doing, and we are not taking this physiotherapy to the platform of, or rather wider platform. So I think these three barriers are there, which has to be addressed to for the success of this kind of the programs. Thank you.
Okay, sir. Thank you.
Yes, myself, Tushar Palekar, would like to add upon both the panelists. Dr. Sudeep Pare well said, and Dr. Ganvir sir also brought. I want to just highlight a few things adding to it. First of all, the thing what is required is the development of soft skills, communication skills, personality development. When this is getting developed among students right from day one, from the time they have taken admission into BPT, possibly the integration of the speech can be well sort of. So only when you are soft spoken, you can build up good rapport amongst ourselves in the beginning, with your own seniors and juniors later on, with your PG students if you have in the college. So your development of rapport is very, very important. Here comes the role when you have to have a development of rapport with your patients also. So when the patients are in front of you, they are your clients, as Ganvir sir rightly said, they are like God. Yes, of course, you have to have that soft spoken skill which is required to have the integration between you and the patient, to have good rehabilitation protocol to be drawn in, and the patient needs to get to you. The patient needs to be surrendered to you, so that the development of the recovery can happen within the patient. As well said, again, we have to have proper coordination between ourselves, basically the physios. Now that we have several master's degrees, and then the patients should get referred in a proper manner, there should be a systematic referral system amongst our own specialities. If we start practicing our specialities completely in a well organized systemic manner. So if this is a possibility, then defragmentation would not be encouraged basically. So if there is a total integrity in the system where we have proper referral system amongst the physios, then possibly the integrity could be more stronger. The second part would be then the coming in of other professionals. Now we have always spoken about allopathic medicine and their professional system, but there are different professionals like dentistry and Ayurveda and homeopathy, who Siddha, Unani, various other integral part of the system, where we can have a lot of scope of development of practice in every arena. So I think that would be an added possibility if today's program of the integrity of the health professionals and the profession could go hand in hand and march together. Thank you.
Can I add something to this?
Yes, sir. Yes, sir.
Sure, sir.
Yeah. So what I'll say is, I agree with all the panelists that there has to be an integration amongst ourselves, integration to that. But there is if I think Dr. Vadraj would agree to that, even when it was 25 years back, I used to tell them, it's your profession and you have to respect that. And once you start respecting your profession, other people will have to respect that. It starts from you. It doesn't start from anybody else. So first thing is, we as physiotherapists, when all of the panelists are telling that we have to integrate, we have to think like, are we ready to take the tough road ahead? That's the most difficult part which happens. There are this integration doesn't happen because there are a lot of people who tries to find the easy path out, and in that case the integration becomes very difficult amongst ourselves. Because I have been seeing, and this is, I think I have been seeing physiotherapists in so many different states of India. I think 8 to 10 states of India I have been working. So now I see like it's different in different places. Problems are different in different places. But there has to be an integration once you have that coordination. So that everybody should be ready to, like I'll say for example, when I stayed in, when I was working in that college in where Badraj was studying long back. Now that's a small place. And there we have only our students at that time. Integrating them would have been quite easier for me. The same thing happened in Haryana when I was working in a college. Now there all the physiotherapists who were there in the city were either from my college, or either they were faculty of my college, or they were students passed out from my college. Now what could happen is, then I could have, they all knew themselves and they could join together and then start working as a team. It's not that I am working different from you. We all are working for the same benefit. That they have to understand. And then they go to the different profession. Even that I agree with that. Because once you have that, they had this formulation. If a patient comes to you, if a patient is coming to me, I don't just try to somehow snatch this patient from you. Now that is not going the right way. We have to work in a coordination manner, and that is what they were able to do very well. I felt really happy, and it is not there in lots of places. It doesn't happen. So that this integration amongst ourselves is possible only when all of us come on the same platform, all of us are ready to take the same path. The moment we try to find the easy path, or somebody tries to, and somebody is ready to walk the tough path, that integration becomes difficult. And as far as the integration of other professionals are considered, is concerned, what I will say is a lot depends on how you show your work. A lot will depend on that. The first meeting which you have that with that person, now that itself gives them a lot of thing, like how well you are, now how well you are able to present to yourself to them, and how well you are able to tell them that you can collaborate their efforts for the well-being of the patient. That is when it starts. So if we are able to make this health, yes, there are a lot of health professionals who are still not willing to see that their patients are divided among physiotherapists. There are people, but there are some lot of nowadays we have a lot of good health professionals also in all the different fields who understand the implications or benefits or advancement and the advancements the physiotherapy has undergone. And it is through those people, it is through those health professionals who understand us, who are ready to work with us. We have to move to the other people in their field. That is the way we have to work. If we try to go directly to somebody who's not able to, who's in a confrontation mode, is very difficult. It is from the people of their fraternity who are ready to interact with us. If we are able to make them understand, so it is those people will tell their fraternity. Now, I have been, my patients have been benefited with this, and so much have been benefited. You can associate. Then it will be a better way. That's why I feel instead of all of us will have to try to get integration with other professionals, but we should try to make our work count, at least for in front of those people who are friendly to our profession, and let them spread it to their profession. That is the easiest way which I feel it can be spread. And integrity, yes, the WHO itself says Sustainable Development Goals 2030. That says integration, that says development of patient as a whole. And without integration, doesn't happen. Rehabilitation, the term itself says integration. So this is where I find, like, once we are integrated, we work together, we understand our limitations, we understand our goals, and then I think we can go ahead. There are a lot of things we can do. That is what I like to say.
Yes, sir. Anything to add on?
Yes.
Sir?
In continuation with what other panelists mentioned about integration, the factors I would like to mention here is we must develop the expertise in our skills and in our field, and we start understanding the scope basically of. It's not only we as a physiotherapist; every healthcare professional start understanding the scope of his own therapy or practice, and then start working in that territory and developing the expertise in that territory. When we talk about integration, it says that it has two components, like vertical integration and then horizontal integration. I must say, integration amongst physiotherapists as well. Like, a graduate physiotherapist must understand his own limitation and the scope of practice. And at some time, he must try to refer or get the expertise from probably a specialist and the masters in a particular specialty, as Palika sir was mentioning, getting the expertise from neuro, ortho, as well as cardio. And he must understand his own limitations and then start working on the patient. This can be an example for vertical integration. Let's talk about the integration amongst the professions. As we know that many orthopedic physicians, now they have also developed their own specialties. Like now, for any case, we do not just simply go to orthopedician. We just, we try to look for a spine person, spine surgeon, or a plastic person. Even in dentist, okay, they have some hierarchy and they have developed a system of integration. So I feel this could be the factors which would affect the practice when it comes to integral part of healthcare. One more factor has already been mentioned, good communication amongst the healthcare professional, because our main goal is to treat our patients. So how our teamwork is going to benefit the stakeholder of our profession, those are our patients. So we must come in together and then start discussing with each other, communicating with each other, so as to come up with a census to develop a best, management protocol for a patient.
Okay, sir. So it's nice brainstorming discussion we had. I think the people, the viewers who are attending this particular session will be definitely having a note of this, and you all, we are all supposed to work on this line so that when we break the barriers, we can move ahead. This is what is the panelist opinion. Now, again an important question to all the experts here. How do we enlighten our own budding physiotherapists who are not aware of about the importance of this concept at all? Because nowadays the young generation, the people who are taking admission to our profession, they were not at all. I feel that they are not at all aware of this concept of integration. They feel that if we learn a particular technique, that is, if somebody is mastered with Bobath concept, you mastered with Maitland manipulation, mastered with some kinesio taping, they think that they know everything in the profession. So they can do all such. That is what is the younger generation's some misconceptions. So how do we smoothly teach them so that they get enlightened? No, you need to be come to the ground, and you have to stabilize your base, then have a proper integrated patient care, so that ultimately their future will be brighter. Regarding this, we need to enlighten them. We enlighten this younger generation. I think we are the right people to guide them. So I want the people to open up with this. But I'm sure that the younger generation not having the idea of integration at all.
Very truly said, Dr. Varadarajan sir. I can say the young minds are open minds, they are open parachutes, so they can obviously fill in a lot of things if at all they are being channelized well. What is required here is to put them on a right path of getting channelized well. So as a part of the curriculum and the syllabi that we are always there to guide them and teach them, and teaching learning as a part of the university curriculum does happen. But what exactly is still required is to fill in their minds with how to communicate with each other. As I told earlier also, it has to be a coordinated fashion between the students, their own teachers, the integrity between the teachers, as well as the integrity which is required with the other professionals also. Now, if they are students, then within the campus, whatever that they have as faculties within the campus, they should have good integrity, as well as the rapport building needs to be there basically. If the rapport building goes on well, I think there can be a regular transfer of medical knowledge, whichever is required for physiotherapist. The physiotherapist can give proper communication to them wherever physiotherapy is required as a part of treatment mode, and thereby the social part of giving the rehabilitation to the patient will also be a fruitful one. So unless and until these three things go together, possibly the patient recovery is also lessened or in a slower process. So this is how we will have to keep the responsibility to keep the patient's outcomes and their recovery on track. Use of proper resource that is there in the college is also to be a part of the usage that the students should have. Now in this digitized world, I think everything is going digital. So whether we should read library books or to go digital online and search whatever resource that we require is also a matter of debate nowadays. So they will have to gather some knowledge either by discussions, debates, any kind of co-curricular activity which can help the knowledge bringing in of various professionals together again, and that should happen at a very young age, right from their undergraduate level itself. So possibly once they are out of their schools, they will be knowing that now they have joined the health professional science and they are going to be in this field forever. Then they should integrate in such a way right from beginning that the things can be taken care of and well supervised by the teachers as well.
Yeah, very rightly said. I feel, I think from when we are tailoring the syllabus, curriculum for our students, from that level itself, if we are given some importance to the integrated teaching,
Yes.
And so that they will get an importance of, yes, this particular condition will be dealt by many doctors, many health professionals which are integrated. Then only we can get the complete treatment of this patient. That kind of idea they may get. So that will be the solution, I feel. Yes, sir. Very rightly said, sir.
Yeah.
And Dr. Rakesh Kumar Sinha, sir, or Sudeep sir, sir.
I want to say,
yeah,
if you permit me. Sir, I got a definition of integrity by the Oxford Dictionary. I will just read out the definition.
Yeah.
A person with integrity is one who stick to his principle despite other pressures and the temptation. Right. एक मोहरा बोलता हूँ मैं, शायरी बोलता हूँ मैं, यदि तुम्हारा हृदय ईमान से भरा है तो एक शत्रु क्या सारा संसार आपके सम्मुख हथियार डाल देगा. So what I mean to tell you, sir, it is everything in the hand of teacher.
Yes, sir.
Once the student entering into the curriculum in the UG level, it is our job, because the students' generation is totally different now.
Yeah.
They are very ambitious and they are using their shortcuts they are running after money.
Yes,
in short, I'm telling you.
Yes, yes.
And this is what I have seen when the students of Mumbai and Pune, they are coming to our places, and when I saw them, their styles and their habits, because they have come from that culture. Okay, so I am very thankful to our MHS syllabus. They have made it very nicely syllabus, and the proper ethics and domains are given from first year to final year. And it is our lacunae, it is the teacher lacunae. They are not taking that ethics and the administrations and the rules very important for the first year students, and we are skipping that area, and we are running after the completion of the syllabus with the other subject. So what I feel, here itself people start teaching them about the ethics, about the integrity and all. I don't think that this will happen to the students till they reach to the final year.
Yes, sir.
And this is what it is. I think we should, I myself take the blame of that. We are at fault. We are not training the student the integrity in the first year itself. Though they are having the subject of anatomy, exercise therapy and electrotherapy, where we can have a proper integrity and nicely integrity program with those subjects. So if you start the integrity teaching itself there, so they will understand that anatomy is related to the exercise therapy, or anatomy is related to the kinesiotherapy, or electro whatever may be. So that message will go to the other batch and the integrity will start. I think so. So the message is that it is the fault of the staff, it is the fault of the teachers, that we are not serious about those students to develop to the integrity in their mind.
Yes, sir. Yes.
I'm very sorry to say, but this is the
Yes,
fact.
sir.
This is the experience of my teaching. I'm seeing about this.
No, we are the people who are supposed to understand it.
Yeah.
When we understand, because all of us are heading the institutions, and we can definitely do a change in our the way that we are looking so far in our teaching or in our system. So definitely we will upgrade ourselves. So there is no point, because that is why that is what is the intention of today's discussion is.
Right.
We should come out of our own. Sometimes we are just going ahead with whatever we are.
Yes,
so
right.
Change, we should realize, and we should come to some good platform for the betterment of our younger generation.
Yeah. For example, I'm saying, sir, in some of the other university, they want to start the computer classes also for the students. But then some of the staff were against those subject and all. But that is the need, because if you don't know the computer and everything, how you're going to do your research and all everything. So that is the need of the student. So we have to see the needs of the student, and then we have to modify our curriculum as per their needs. But we are not taking any feedback from the students. We are not taking any feedback from the stakeholders, outgoing students, and we are just sitting in the room, AC room, and we are preparing the syllabus, seeing to the other university syllabus.
Yes.
It is from my heart. From the bottom of heart, I am talking.
Yeah.
So in my opinion, what I feel,
here I just want to add something. In Three Idiots movie, the Viru Sahasrabuddha has informed us that the life is a race and you have to run.
Yeah.
If you'll not run, someone else will go ahead of you.
Yeah.
Our young generation, young student and youngsters, they are having tough time in the competition. The competition is increasing day by day. The competition which was there 15 years back, that is not here. There is a huge difference between the competition. and because of that, the competition tendency is increased. We are running like a horse. The horse has given only one aim in front of them. If you see the race course, they have something kept in front of their eyes, so that obstruction is given for lateral vision to the horse. Why? Because he should go only in one direction. And that is what the unfortunate scenario of the education system. And your question, how to integrate that concept into the student, we have to open that obstruction. Students should not just only see to pass the exam, but also your colleague. When you are running in the race, every one of us, all the people who are in the profession, all are those who are in the panel, we have something positive and unique amongst us. We should appreciate the uniqueness of others and the positivity of others. The day we will able to make the students understand that your colleague has something better than you, and you can take them for the benefit of all and not as a competitor. If we will able to understand, and if you're able to make the students understand, definitely I think there will be no need to take extra effort. This thing is sufficient. And not only students, even in the professionals, we should also understand that I have something positive, you have something positive. Let's take the positive thing. Let's look at it at positive and integrate that. I think to propaganda, or that will help to whatever your question was there, it will address that issue. Thank you.
Yes.
So basically what I understand, probably this may not be only a concern with a medical profession or a physiotherapy profession. Overall, this new generation, when they are coming up to us, probably in the first year, what we are looking, the approaches, the attitudes within them, and then we are realizing that definitely this is the right time we need to work upon. Probably this is how the curriculum and the syllabuses are being revised even by UGC as well as medical councils. And the best part about this is that, in previous years, the ethics was being taught probably at the end of when the student is getting graduated, probably in the fourth year. And nowadays, the curriculum has been revised, and at the beginning, from the first year itself, the ethics and the principles are being taught to the people. Even they have added the communication skills, which have been taught to the students from first year itself. I feel execution, the well execution by the teachers and training the students on this basis is really going to help us.
Is there anything to add?
Yes, I would like to add a few things to that. Now, when we talk about students, younger generations, now normally they are at an age where we have to mold them to do what they see. It's as simple as that. I'll just say they do what they see. So it is not like what they are doing. It is not what we are able to tell them. It is for us to tell them. That is where I say, when we say about becoming a teacher, people find just getting a degree and becoming a teacher, that's totally two different things. Becoming a teacher means you have to inculcate those values, inculcate those, not only make them as a good professional, but also as a good person, good citizen. Once he becomes that, all these things will automatically come in line. And a lot of things, this comes from the way we deal with this. Now, like when I used to say, like if I say of my college in Calcutta, National Institute, now every week there was a case selected, and right from the physiatrist to the orthopedician to the social worker to the vocational counselor to the physiotherapist to occupational therapist, everybody has to sit and give their opinion on that case. Everybody, right from that, every week it has to be there, and all of us have to attend that. Now that is where the integration starts coming. Now when we talk about that, now the moment we see and we do all these interdepartmental activities we start doing, now students will automatically come to know what is the importance of that. The moment we start giving importance, okay, this patient is there, now we should get an interdisciplinary discussion related to that. It is happening in some colleges. It is not happening in most of the colleges. It doesn't happen. So once we don't make them aware of these things, like when we are doing something, we can talk to other people and discuss. How do we expect them to learn and go outside? No, that is not possible. So it depends. That's not really. And How many of us are ready to do that? That also is a question. How many of us are ready to tell them, the students, no, you should take help of them. No, you should. But most of us say is, no, we can do. No, I'll take care of that. We'll do everything. No, that is not there. So that is a two-way thing. Some things they have to learn. Some things we have to make them understand. So it starts from where we are. We as teachers have to inculcate that in them. If we are not able to inculcate that, it is our failure. Yes, there is a difference in the type of students we used to get around 20 years back and the type of students I'm getting now. But still, students are there to be molded.
The principle is
same. And like if I say, like I'm very proud, like I have got, if I see Dr. Vadraj, I see a lot of his batchmates. I see so many, I just feel proud. As a teacher, that is what I gain. I just feel proud to see that he is there. And he has developed in a good person, in a good citizen, in a good physiotherapist. And that is what I feel. Then I feel proud of what I have taught to him. I have never taught him to disrespect anybody. Let it be any X, Y, Z. It is not a matter of being other profession or other person. A matter of disrespect. A health professional is not taught to disrespect anybody. That is not a professional approach. You cannot disrespect. You may disagree. You cannot disrespect anybody. That is what has to be made. What has our new generation, old generation, anybody. I feel everybody has to understand that. Once we understand that, and everybody, like Dr. Sudeep was telling, everybody has got his own uniqueness. Yes, everybody is important in his or her way. That is what we have to understand. Once we have that, we see this. That is our motto, isn't it? We say every student is different. As a teacher, we say every student should be dealt differently. And as a medical professional, we say every patient should be dealt professionally, should be dealt differently. So that itself comes. Now every patient is different, every student is different. So everything has to be dealt differently. So everybody has got different properties. And once we understand that, we make our students understand that, all this integration will ultimately come. All this integration will ultimately come. That is what I have a belief. It is our task. We are not able to do that. That is where a teacher has to understand that teacher is not only to teach what is there in physiotherapy. It is also there to how do you behave in your tomorrow's life. How do you go out? When you go out, people should understand this person has come out from a good place. Now that is what also is required. So professional knowledge, as well as everybody was telling, like speaking, communication, everything, all those things are, when we merge together, we'll be able to solve a lot of problems. That is what is my opinion, in addition to what everybody has said, with a bit of experience which I have been seeing, and change in people which I am seeing, the type of people I am dealing, the change of students, the change of faculty, the change of professionals I see is totally, there's a lot of difference. We are not able to inculcate a lot of things which we should inculcate in the students. That is what I said, what I have to say.
Okay. Dr. Tushar sir?
Yes, sir. He has very good views about the knowledge of the past students and the current students. But yes, I definitely agree with him, because I think the teachers need to be molded first, and then the molding of students would occur. So possibly the reciprocal formation between the teacher and the student has to be there as an educator and educand. So this kind of a phenomena can definitely bring in some views of integrity amongst the profession itself. Definitely agree with Dr. Akesina sir.
Yeah. Sir, actually, we are the generation who are not the old generation. Who are not the new.
We are basically a sandwich generation.
We have to shoulder.
We have seen both the world now. We should be happy about that. We have seen that world as well as this world. The world where that communications, that lot of this new communication that was not there, and we are seeing the present world, which has got all this thing, everything at your fingertips. So that also is there.
If anything could change in our system, then we are the right generation to change. That is why we are gathered here, and we will work on it. I think after having the opinions of all the panelists, I think this is not a problem. Younger generation can very well be tuned from the day one when they are getting admitted in our college. So I'm happy with that, and I'll go to the last question for the today's session to all the panelists. That nowadays the physiotherapist, once they get graduated, and even the postgraduated, and they work in different setups. As and when they get opportunity, they work. Like when you take from the beginning, when at the lower level, most of the physiotherapists are freelance practitioners. So they go to the home and they deliver the physiotherapy services. That is the base first category. Then they have their own practice, independent clinics they will be having. And some of them are in a small town, they work in a nursing home as a physiotherapist. And some of them will get an opportunity to work in the government hospitals. And some of them are working opportunity to get in a private hospital, which is a tertiary care hospital, which has got all the facilities. And some of them are opportunity to get at the corporate level and big hospitals in the country. So now, what is your, how do we guide them that they have to follow at all the levels the integration? Let it be a freelance practitioner, home visit, hai to bhi, or integration ka meaning, integration they have to continue. And even the same thing, the people who are working at the corporate setup also. So there should not be any variations among the physiotherapists who are practicing in following the professional integration. So regarding this, again, we have to guide the all physiotherapists, because we know our own colleagues, our own fellow physiotherapists, they are working in these categories. So they may say, for me, it is possible to integrate, but for a house visiting physiotherapist, how he will get integrate? He wants a bread and butter. If he get a patient, he will go and treat and his matter is over. The day will complete. He will be happy with that. So, but the quality of the care, when it comes to the matter of discussion, of course, everybody has to follow the integration, I feel. So how do we enlighten such kind of physiotherapists through this platform?
Sir, I would only say Rome was not built within a day. We need to have some resolutions at teaching levels, at academic levels and clinical levels. So possibly, as I again said in my earlier speech, the children, when they are right from the beginning of undergraduation, the bud needs to be a blooming flower once they are out. So once they face the world which is wild outside, they would be getting all sorts of thorn picks everywhere. Now, wherever they get a job, getting in part of a communication with their own colleagues, a new hospital setup, new boss, a new clinical arena, basically, let it be a big hospital, tertiary level, or even a small dispensary. But definitely, whatever if they have learned right from their college level would be definitely in their minds, where the inculcation of knowledge which is being shown during their primary ages, and that would definitely take up a blooming stone for the future. So this would be a stepping stone for them and a learning attitude that they would develop right from the beginning. And definitely they will have some turning stones in their life where they will inculcate by their own communication skills, their own humbleness, politeness, basically their personality. Definitely, I think in future they can do it. If at all there is a will, there is a way. So that is how we'll have to work across and see that the students make it a blooming profession and keep up their name and fame, as well as their institute's name and fame, as well as their parents' name and fame. So this is what I can say. Thank you.
Thank you, sir.
So I have an opinion on this. Basically, a very nice point been taken on this panel discussion. Many times, even my own experiences, now the patients are becoming smart and they are running from one consultant to the other consultant, one physio to the another physio for their opinion, for their treatment, like anything. And sir, the patient's condition is also, there are many chances that the patient condition from day one to day, means probably in the next week may be changing. So a previous therapist, with what thought process he must have come up with the treatment or the protocol may be different, or even how the patient was presented. Many times this happens that patient is misleading to a correct diagnosis. So this happens many times, and then there happens a situation where two different consultants, two different therapists are treating the same condition on different paths, on two different directions. So I feel there is a right time to communicate, to have a good communication with two therapists when there is a handover of one patient to other. Even when the patient tries to mention their previous whatever opinion, the next therapist must try to respect the treatment given by the patient, given to the patient by the previous therapist, and even from his own, may try to just call and consult what was his condition, so that ultimately the patient will be helpful. That is what my opinion is.
Yeah. Thank you, sir.
I think that is very correct. And that is what I keep on telling the faculty working in my institution or our hospital, wherever I work. If I prescribe a treatment, even if it is wrong, don't change. You don't change that. The person who changes is me. You can come and let me know, but you don't change that, because the patient loses the confidence. The moment you change, I may give a wrong treatment. You can come and talk to me and discuss with me, and we change that. But the person who is going to change that is me, is not you. The same thing what he is telling. And what I'll say in this regards, Dr. Vadraj, is there is a very thin line between greed and need. That is what people say.
Yeah.
So the moment you draw that line between greed and need, these things will automatically vanish. Because somebody was telling in the panelists, one of the panelists was telling patient is like God. A patient is our bread and butter, but patient is not our ATM. The moment we differentiate that, patient is our bread and butter, but patient is not our ATM, then we automatically and try to integrate other people also. The moment we feel that the patient is our ATM, so that treatment is never going to end. That treatment is never going to end. And that is where the problem starts coming. The moment we understand every treatment, we have to have a span. Okay, if I'm not getting a result beyond this point, I'll try to consult somebody else. I'll try to approach somebody else. But that doesn't happen. We tell the patient, no, it is still coming on. Don't worry. I'm still trying. It will take some more time. That is where that is what is happening. When I understand that, yes, the patient is bread and butter and he is the center, we are all working toward his betterment, not to get advantage of him or her, whatever it is. The things will automatically work out. This integration, whether you are working in a small center, whether you are working in a tertiary centers have different things. They have fixed rules. So whether you want or you don't want, you have to follow that. So it's not a matter that somebody has to tell you in a tertiary center that you have to refer. It is all written in that. This is the protocol you have to follow. Such and such person is going to come. After this, the next will be that, this will be that. But that is not the case when you come to a rural center or a private nursing home. That is where this problem starts. So that is where I'll feel that all of the therapists will have to understand what is their outcome, what outcomes they are trying to achieve. That has to be, that is what we teach the students, isn't it? First, take your short-term and long-term goals. Once you decide your short-term and long-term goals, now you know whether I'm achieving that or not. If I'm not achieving that, reassess and try to see if you can do. If not, there has to be some other way. It's not that I not and I and only I. The moment that changes, it will change. That is what I'll say. So it is a matter of any center, wherever you're working, whether it's rural, whether it's in the city, whether you're having your own clinic, whether you're working in a group of people. The thing, the moment we follow that, we are all okay. We are okay, all okay. That is what I'll say.
Yeah.
I am here on board with all the panelists on this issue, especially Ganvir sir and Sinha sir. I second them. Ganvir sir had informed about the integrity. Definitely the integrity, if we turn into the integration, the setup will not make any difference. And that is one point. And second, Sinha sir has mentioned the thin line between the ATM and bread and butter. I think sir has given very, very live, great example. The moment we'll able to make this understand to the professionals and students, definitely we will get the success what we are discussing today. So definitely the panelist has given excellent opinion. I think the high time that young generation, old generation, professional students has to follow this.
Yes. Yeah. Dr. Shyam sir. Sir, unmute, sir. Unmute, please.
So the question is very tough. As a teacher, I am not able to answer this question because I think this question can be answered only by the student who pass out and who is going and doing the patient in the rural area. Because when I pass out, no one has taught me about the integrity and nothing else. I have learned myself, but it's a question of bread and butter. So we have to run here and there for the job. It is again the fault of our senior as well as our profession that we have not created a job for them. Today also, I passed out, my admission was in 1992 and passed out in 97, 96 from GMC Nagpur. And I was waiting for MPSC post at that institute. But today also the MPSC post has not created. So why? Only one state government is there. Why not the post has been created in the PSC? Why not the post has been created in the rural areas? Why not there? Why not the post has been created in the railway? Why not the post has been created in the district hospital? This is because of our fault, our professional fault. Today the student has to run here and there. And that is the question of bread and butter. The question and to discuss the answer in the panelist is very nice, very good. We can discuss here, we can solve here, but practically and logically, it will be remain same thing. For discussion, it will be a good. Today, I am having this National Medical Commission Undergraduate Medical Education Board public notice. I think everyone has gone through this notice. Page number 15. If you see the page number 15, in that page number 15, they have created a post for physiotherapy. Number 1 is professor, second is associate professor, third is assistant professor, where under minimum requirement of tertiary hospital of Medical Council of India, recognized by Medical Council of India. New commission they have passed, and the head of that department, who is working as a professor for physiotherapy, professor, assistant professor, physiotherapy, and assistant professor, the head of the department is PMR. So then where we can stop? Though we, from myself, I can start the integrated program, but if the boss is PMR and I am working under him as a physiotherapist, how we can do the integrated program here? So what the students, or the students, those who are seeing me working under the PMR, this is an example I'm telling. I'm not working under PMR. This is an example I'm telling you. According to this commission, if the students are seeing us like working under the PMR, definitely this message will go outside. So there cannot be an integrated program if the pressure, political influence. This is number 1. We are lacking in the political way. We are not having that much of influence to make our profession.
Dr. Sam, if I can interrupt you, just a small thing.
Sir, let me finish. Sir, let me finish. अभी थोड़ा गर्म हो गया मैं, थोड़ा तो मुझे नरम होने के लिए टाइम लगेगा. So this is a discussion. Sorry, sir. Sorry so much. So, sir, what I want to tell you, why we are lacking all this. So for discussion is very nice question. Everything is there, but then really we are the sufferer. Our junior are sufferer. Our student are a sufferer because of all those political influence or the guidelines which is prepared by the higher people. Anybody who was there. So this is really it is very difficult to answer such questions.
Yes. I understand, sir. I understand. But being the seniors, just at the extent within our limitations,
right?
Guidance.
No, I'll just say, Dr. Vadraj, I'll just tell him, like, I'll just like to. It's very true that the way profession should have developed, the way it should have developed, a lot of things has not happened. That everybody, I think nobody is there who disagrees with that. But there's one thing which I disagree with you. When you say a PMR is working, is the head of the institution. I have studied in the National Institute of Orthopaedic Handicap. The head is PMR. But I still remember nobody ever thought of writing a treatment of physiotherapy. No, it was just referred to. It had happened once in our duration, and our head of department just took that paper and told, how can anybody write what treatment of physiotherapy is required? I still remember that, and that is where I learned. That is from where I learned that our profession has to be. You have to stand on your legs. You have to show them that, and that doesn't happen many times. But yes, a lot of things can change, should change. I think Dr. Sudeep will be able to tell us about these things better than a lot of us are telling. I'll just say that. But we have to stand. We have to understand that even within our limitations, what we can do, we should try to do that.
I agree with you, sir. I agree with you. But then, if head is the PMR, definitely there has been some pressure among the physiotherapists.
Yes, it is always.
What you are saying, you are right. That practically, you are very right. But when you are working in that setup, some difficulty, because I have faced the problem when I went for the inspection at Haji Ali AI PMER. The staff were discussing with me all those matters, and I went to the PMR head also, and I talked with them. There is some pressure. They are not that much independent to work in that atmosphere. But you are right. What you are saying, that is acceptable.
I would like to just contribute here. The NMC, National Medical Commission, has given the new MSR for medical that is MSR 2020. I think it's my personal interpretation that the things which is mentioned as the physiotherapy and rehabilitation department, that is, I think it is a printing mistake, because if you read the previous pages and later pages, nowhere it is mentioned that the department is called as physiotherapy and rehabilitation. NMC has mentioned the mandatory department as physical medicine and rehabilitation, but I think by mistake it has been printed like physiotherapy and rehabilitation. My personal interpretation is that the professor of that department will be from PMR, associate professor, assistant professor, senior residents, all will belong to the PMR faculty. And at the bottom, they have mentioned that there is a physiotherapist, occupational therapist, and others. So I don't think that the physiotherapist will get a professor AP post in NMC. I think it is a printing mistake, and
Yes.
this is a serious issue, because till date we all the medical colleges were used to run independently within our scope. Now, as per this NMC guidelines, there will be a PMR department, and there is a difference in the response of a PMR department under the Social Welfare Ministry, which Sinha sir has mentioned, and there is a difference of behavior and responses of PMR department under Health Education Ministry. The report from Health Education Ministry is very negative, whereas from Social Ministry, the institutes under that is positive. So in future, as Ganvir sir has mentioned, this is a coming challenge to us, because we will be at the lower and someone will be there. But if you will not go into the administrative issues, and if you think, as Sinha sir has mentioned, for the patients, definitely we all will able to deliver best, but it has to be understood by all. But the response report of Health Ministry run government institutes and PMR is not encouraging. Thank you.
Very well said, Dr. Sudeep Kale, sir. I fully agree with both the council members. I think there is a fire of rebel everywhere. But I think this can be sufficed with the current batch of students who are now just budding physios, as well as the budding talented students who have come into the profession right now. And possibly when we talk about health integrity and the professional integration that is required, it is just a small good communication with a positive thought, as we had already started with positive vibes with this panel discussion. So definitely we can make something turn around. The young budding people can be sown in the seed with doing something good, and definitely a health integrity amongst the professionals can be revolutionized in a new manner. So that is what we look forth for. Varadarajan sir, please unmute.
Because every drop has its own importance. So filling the bucket, that's what I say.
Very well said, sir.
Yeah. Finally, we have come to the conclusion of the panel discussion. Really, I think to discuss such kind of topics, I feel the people like us are only the appropriate people, because mixed leaders in the profession who had a tremendous experience. Almost Dr. Rakesh Kumar sir is almost having 8 to 9 states he works, and so many people are here who are really experienced the true value of our profession, and we are the people to discuss. And definitely we will be making a fruitful result out of this to our own products. And I think we will start from us, from wherever we are working, and then that will go to the national level modifications. So with this, thanking one and all once again from the bottom of my heart for sparing your valuable time and for this brainstorming discussion, which is a need of the hour for today's generation. So once again, wholeheartedly thanking you all for sparing your valuable time. Thank you very much.
Thank you, everyone, and thank you, Dr. Vadraj, for letting me know a lot of people in this state of Maharashtra.
Sir, I will just say one shairi in Hindi.
Yes.
It is very related to our integrity. अगर आप सही हो तो कुछ भी करने की साबित नहीं, कुछ भी करने की साबित मत करो, कोशिश मत करो, बस सही बने रहो, गवाही वक्त खुद दे देगा.
Truth is always the same. Truth never changes. That is as simple as that. One line. You don't have to remember the truth. You have to remember only lies. You don't have to remember truth.
Yes,
that doesn't change.
बहुत उम्दा दस्तखत दे दिया सर, गणवीर सर, उम्दा दस्तखत.
हमारी तो आदत ही है, हम जहाँ जाते हुए अपना माहौल बना लेते हैं.
That's good ना, अच्छी बात है ना. That's very nice.
So thank you very much, sir.
Thank you so much.
Meet you all in some other time, in some other occasion.
Right.
Thank you.
Thank you.
Good to meet all of you.
Thank you.
Through this video conference. It's good to have an interaction.
Yeah.
Thank you.
Thank you.
Thank you to all the panelists present. Thank you for sparing your valuable time for the discussion. With this, we end the panel discussion and we'll move forward to the valedictory function. Thank you. Over to you, Dr. Khushbu.
Good afternoon, one and all. It was great to have all the participation of all the speakers and all the members throughout these 2 days of NASP 2020 with the theme Health Professionals' Integrity is the hallmark of physiotherapy or physical therapy and rehabilitation, where we have been listening to eminent speakers with abundance of knowledge, not only from India, but even abroad. I take this opportunity to welcome you all to the Valedictory Ceremony of NASP 2020. May I now request Dr. Suraj Kanse to deliver his welcome address.
Dr. Suraj
Kanse is online.
We'll just check it out, sir. Just a minute. Dr. Trupti, can we see Dr. Suraj?
Suraj. Welcome. Welcome.
माइक नहीं क्या? माइक नहीं क्या? तुम्हारा Trupti, Khushbu, you can only do the welcome address.
Sure, sir. On behalf of the organizing team of NASP 2020, I am very delighted to welcome all the members, all the dignitaries. We are very grateful for the presence and the support of our Honorable Chancellor, Dr. Suresh Bhosle, sir, our Honorable Vice Chancellor, Dr. Mrs. Neelam Mishra, Madam, Honorable Chief Advisor to the Chancellor, Dr. Ved Prakash Mishra, our Pro-Chancellor, Dr. Praveen Shingare, respected Registrar, Sir, Dr. M.B. Khurpade, Deans of all the faculties and principals of all the colleges of physiotherapy who have been associated with us for NASP 2020. Along with that, I also heartily welcome all the members. We have with us Dr. Tushar Palekar, sir, Dr. Ruchi, madam, Dr. Ujjwal Yevle, sir, Dr. Anandi, madam, for the present ceremony. Now, we would proceed for our next part. It is rightly said that even if a student is full of wisdom and intelligent, the footsteps of his teacher are always 2 steps ahead of him. To prove this thought, I would hereby request Dr. G. Varadarajulu to give an overview of the conference NOSP 2020.
So very good afternoon, one and all. It is my again a great pleasure and privilege to give the aerial view of this 2 days of the conference, which has been held with the theme of health professionals' integrity is the hallmark of physical therapy and rehabilitation. So on this occasion, I am very much delighted to have our Dr. M.V. Gorpade sir, who is our Honorable Registrar of the Krishna Institute of Medical Sciences deemed to be University, as the chief guest for today's function. We will be presiding over this valedictory function. And we have Dr. Ruchi Varshane Madam, IAP Head, IAP Women's Cell of Indian Association of Physiotherapy, and Dr. Ujjwal Ivle sir, who is a Maharashtra State IAP branch president, and Dr. Tushar Palekar sir, who is the Dean of Faculty of Physiotherapy, Devi Patel University, Pune, and all the dignitaries in the platform, even Dr. Sudeep Kale sir, who is the President of OTPT Council of Maharashtra, and all the dignitaries. Again, it is my great pleasure to welcome you all, as well as to give you the aerial view of this conference. So this conference is intended to conduct offline only in the month of March, April. Because of the corona, this happens to be conducted in a virtual platform. So the main intention of this conference is that we as a physiotherapist, we are supposed to work as a team member with all the healthcare professionals, and to witness the importance of this, and how do we get integrated with an orthopedic surgeon, neurologist, even dental professionals, nursing professionals, cardiovascular surgeons, all the healthcare professionals, how we get integrated to have this kind of a platform to come all of us to make all of us to come to one platform and to have a good discussion is my only intention of having this theme and conducted this conference actually. So this conference, yesterday at 9 o'clock in a virtual platform, it has been inaugurated with the blessings of our Honorable Chancellor Sir, Honorable Pro Chancellor Sir, Honorable Vice Chancellor Madam, and even the Dr. Sudeep Kale Sir, Dr. Ujjwal Ivle Sir, all of them were there been in the inaugural function, and the inauguration was happened smoothly with the blessings of all the dignitaries of our university, even in the profession. We have gone ahead with the scientific sessions, and that is a scientific session. We have got 2 sessions, and the topics that we have covered is initially the BPPV, where a physiotherapist will be working with ENT surgeon. And the second topic is a dental, TM joint dysfunctions, a dental profession with physiotherapist. And then we had a discussion with today we had a stroke where Dr. being the resource person. So like that, we have taken topics which are where we are daily seeing the cases, and those topics, how well we can be integrated. So we have had a good scientific sessions for this conference. Nearly about, we have a tie-up with the Physiotherapy, which is launched by the Sanchiti Institute of Pune. And we, as a joint venture, the entire program is live in that Physiotherapy on the YouTube channel. And of course, the program, the scientific sessions, everything happened in the Zoom platform. And so far, yesterday, there are more than 3,500 viewers were there. Today also the same. And there are about 650 registrations were happened. So in a Google registration form. And the response was very high. I think we had in a post-less session, we had a very good panel discussion where there are 5 principals and 5 leaders in the Maharashtra state. They come together and we have discussed a topic on how a physiotherapist will be an integral member. Whether do we voluntarily ourselves to be an integration member of the health professionals for the taking care of the our own patients. So that was the topic we have discussed, and the topic went on very well. So far for this conference, to call it as, to name it as a international conference. There are 5 international speakers who have been as a resource persons, and 3 of them are from California, Australia, and they delivered a very good talk, and the people definitely might have been benefited out of this conference. And to coordinate this, our own alumni, in fact, who are working with them in the Australian, American, UK, they helped us to get the resource persons, Dr. Nittal Tavade and Dr. Dhaval Banishale, who are helped us to get the resource persons from that country, where we as a staff, students, alumni, togetherly, we work togetherly for the success of this conference. Of course, all the resource persons, all the judges, all the panelists, they are all supported this success of this conference. Finally, before I'm forgetting, this entire conference, since it has happened in the virtual platform, our university, that is technical team and the College of Physiotherapy technical team, especially Dr. Trupti Yadav and Smita Patil, Khushbu Bhatia, they work tremendously to see that the platform is stable for the deliberation of various scientific sessions. So this is what is the in general aerial view, and we are in the valedictory ceremony. Over to you, Dr. Trupti Yadav and Khushbu Bhatia.
Thank you so much, sir, for orienting and giving an aerial view of our 2 days of event and the activities which happened in the conference NOS 2020. Oceans of knowledge have been spread, but now it's time to value the pearl in it. So it's time to separate the best out of the better in the category of senior scientific paper presentation. To declare the results, I would now request Dr. S. Anand, Professor and Organizing Secretary of NOS 2020, to take over the session.
Very good afternoon to all of you. The scientific paper presentation has happened yesterday, the afternoon session. So 3 of the judges were there. One Motimat, Dr. Motimat from Kerala, Belgaum, he was the judge. And second judge was Dr. Sridhar from Kempagoda Institute of Medical Sciences, Faculty of Physiotherapy, Bangalore. And third was internal judge is Dr. Suraj Kansek, Associate Professor, Neurology Department from Krishna College of Physiotherapy. So there were totally 18 papers in senior presentation presented. It was very much difficult time for them to finalize the results. And within a margin, it has found out they have finalized. So you all, the participants will be very much delighted. I will announce the names of the winners. 3 prizes. And the college names. Karad has won the first prize in scientific senior paper presentation. Second prize, Dr. Aishwarya Rawat, DVVP of College of Physiotherapy, VK Patel Foundation, College of Physiotherapy, Ahmed Nahar. And another second prize was won by Dr. Akshata Guhe, Dattamagi College of Physiotherapy, Varda. All these 3 are very much congratulations. We congratulate on behalf of the scientific committee. Congratulations. Thank you very much.
Over to you, Dr.
Over to you, Madam.
Thank you so much, sir. There is a famous quote: "A woman stands up for herself, and she stands up for all the women." And to truly justify this quote, we have Dr. Ruchi Vaishne, the IAP Women's Cell National Head and the Treasurer of IAP. So we are very glad to have you, madam, with us for this valedictory ceremony. I would kindly request you to share a few words with our audience.
Madam, kindly unmute yourself.
Yeah. Am I audible now?
Yes, madam.
Yeah. Good evening, all. Good evening to all the respected dignitaries, Chancellor Sir, Registrar Sir, Pro-Chancellor Sir, Varadaraju Sir, Sudeep Sir, Ujjwal Sir, entire organizing team of this wonderful extravaganza for physiotherapy. Thank you so much for inviting me and for the kind introduction. It's a pleasure to be a part of this great event in the valedictory ceremony with you all. the kind of work you all have done in the last 2 days, it's really, really, really commendable. India is a vast country. So much of things are happening these days with this COVID pandemic. But one thing that has happened as a blessing in disguise, that world has realized the importance of physiotherapy. We are the most essential service. And with, as the theme says of the conference, that it is the integrity, all the other professionals, it is high time that we all work in tandem with each other to make this society a better one, pain-free, disease-free. It's like, the integral work that all the healthcare professionals have been doing for this past 1 year, facing so many problems. We have lost so many of our COVID warriors. And in this scenario, I would like to congratulate Tripti madam, Khushbu madam, all of you are doing great work. It's like, as I always say, that we need to have core consistency, core integrity as a professional also. So to all the participants, it's a small message from my side. And on behalf of Indian Association of Physiotherapists, I would like to say congratulations. We all have to work with, we have to communicate our things to the patients, to the society as a professional. We have to collaborate with all the other healthcare professionals, as the theme of our conference says, that, the dental, allied healthcare professionals, all other medical professionals have come together for this. Then we should have commitment. This is all C, all the words which I'm using, this all start with C. So I always say these are the 5 C's. You communicate, you coordinate, you collaborate with core consistency and core integrity. So it is our commitment towards the goal. It is our commitment towards this society to make it pain-free, to make it, to get rid of all the diseases which are happening, to all the problems we are facing. And physiotherapists, we have our role right from the stage 1 to the last stage. And as we always say, that physiotherapists work from womb to tomb. So this COVID pandemic has proved that how important physiotherapy is, how important cardiopulmonary physiotherapy is. My mother is in ICU, facing a lot of issues, and I can understand how important, because when a physiotherapist sees her in ICU, still so much of strength she gets when she, blows the spirometer, when she walks for 2 steps. And this is, I personally feeling this, how important physiotherapy is, how important the role of physiotherapists in this entire pandemic. So I request all the participants of this conference, please love your profession, love your association, love the organization that you're working with a lot of sincerity, because this is important. We have to, it is all right to dream big, because once we dream big, then only we are able to, make others recognize that how important we are. So that's all. Thank you so much again, Tripti Madam, Varadaraju sir, for inviting me. Thank you everyone. And I hope this extravaganza continues for another year, and soon we get rid of this pandemic. Thank you so much.
Thank you so much, madam, for your inspiring and motivational words. We love to hear you, ma'am. We all very much thankful to a great motivator and supporter. He is none other than our beloved President of Maharashtra State Chapter of IIP, Dr. Ujjwal Evle. May I request, sir, to please give your kind words.
Good afternoon, dear friends, colleagues, the dignitaries for this conference, Chief Patron and Honorable Chancellor of Krishna Institute of Medical Sciences, Dr. Suresh sir, patrons of this conference, Honorable Chancellor, Dr. Praveen Shingare sir, Honorable Dr. Ved Prakash Mishra sir, Honorable Vice Chancellor, Dr. Neelam Prakash madam, Neelam Mishra madam, the dignitaries who are present along with me for today's event, Honorable Registrar, Dr. Ghurpade sir, the National Head of IIP Women's Cell, Dr. Ruchi Vaishnav madam, Dr. Sudeep sir, Dr. Tushar Palekar sir, a key person behind this successful conference, the organizing chairman and our beloved respected Dr. Valedictory sir, the Dean Faculty of Physiotherapy, organizing secretary Anand sir, and dear friends. It's indeed a great pleasure to be a part of this event. Krishna Institute of Medical Sciences, College of Physiotherapy has always come up with the innovative ideas while organizing various events and the themes while organizing the conferences. A way back in 2006, a similar conference on the platform was organized with the unique national theme, a national level conference for professionals and the stakeholders, where the patients, the parents, parents of the students of physios were being involved. A conference which was organized by Krishna College of Physiotherapy, again under the leadership of Dr. Varadrajulu sir. This year, the virtual international conference, which happened in last 2 days from 22nd to 23rd, with the theme, again an innovative theme, health professionals, integrity, the hallmark of physical therapy and rehabilitation. This conference had a nice blend of innovative scientific deliberations as well as panel discussion from medical, dental, nursing, as well as physiotherapy stream. The national and international resource persons and the stalwarts in their respective fields have shared their experiences, and I feel it was a great opportunity to listen to them on this virtual platform. Definitely, organizing an event, and that too again on virtual platform, needs lots of coordination. And I must say, the organizing team from Krishna College has made it a big success. At the outset, on behalf of Maharashtra State IIP and in capacity of President of Maharashtra State Chapter, I take this opportunity to congratulate Dr. Varadrajulu sir and his team, the organizing committee, for successfully organizing this conference. Dear friends, physiotherapy rehabilitation has emerged with and is playing a key role basically during this pandemic for treating of COVID patients, ranging from treatment in ICU to the post-COVID OPDs which have been set recently by various hospitals. We are proud to mention that the Krishna Institute have treated more than 2,000 COVID patients, what number I came to know till now. And recently on World Physiotherapy Day, we Maharashtra State Chapter of IIP have felicitated the institute and the physios, the COVID warriors, for their distinguished services to the community, to the society. I would like to mention again here that the Krishna College is playing an important role in creating awareness about physiotherapy amongst healthcare professionals, amongst the society, through various activities for professional upliftments. The students graduating from this campus, the alumni, are also proving their excellence to make the institute feel proud. At the outset, I must say that all of us have thoroughly enjoyed this conference and are overwhelmed with the knowledge shared by the expertise, the panelists, and the resource persons for this conference. Again, I congratulate the organizing team for the successful event. Before I conclude, I wish you all best regards for your future endeavors. Stay safe, stay healthy, take care of yourself and your family. Thank you again, Dr. Varadraju sir and his team for inviting me. Thank you.
Thank you, sir. Thank you for your motivating words. Not a single event can be performed without a leader. It was a great opportunity for all teammates to perform under the guidance of respected registrar, KIMS deemed to be University, Dr. M.V. Ghorpade. His efforts are marvelous in the efficient functioning of our institution. May I now request sir to deliver his presidential address.
Thank you so much. Am I audible?
Yes, sir.
Thank you so much. Once again, I thank all the organizers for inviting me over here for this valedictory function. I take this opportunity to welcome all the dignitaries who were present over here for the past 2 days. Honorable Chancellor Sir Dr. Suresh Bhosle, Honorable Pro-Chancellor Sir Dr. Praveen Shingare Sir, Honorable Vice Chancellor Madam Dr. Mrs. Neelam Mishra, Dr. Sudeep Kare, Dr. Ruchi, Dr. Ujjwal Yevle, Dr. Tushar Palekar, all other dignitaries, Dr. Varadarajulu, Dr. Anand, and all the team members of NOPS 2020. At the onset, it was a commendable effort on the behalf of the Krishna College of Physiotherapy, well executed by Dr. Varadarajulu and his teammates. As rightly said, this COVID-19 pandemic has taught us many things. One of this is to be on the virtual platform, how to interact, how to react, and how to have deliberations. As Sir has already said, that Krishna Hospital was foremost in the treatment of COVID patients, and more than 2,500 patients have been successfully discharged from Krishna Hospital. Now, when we talk about this large number, a lot of support was there from the nursing staff, the medical staff, the paramedical staff, and most important of all, the physiotherapy staff. Even a medical director has acknowledged the fact that in this fight against COVID-19, Physiotherapy College was at the forefront. And it was a remarkable and commendable effort from all the physiotherapists, because physiotherapy is needed for all the patients. As you know, you're all experts in this, why physiotherapy is needed and what is the benefit of physiotherapy. I won't go into that, all the details of that, but I would like to say that definitely physiotherapy has a definite role in the treatment of not only COVID patients, but as you have discussed over the past 2 days, from chronic heart failure, stroke, to a number of other things also. And the benefits are so much that the patient feels that the complete treatment is complete only after receiving physiotherapy. So that is how I think of physiotherapy. Now, initially, when we had some knowledge of physiotherapy, we were not thinking about physiotherapy in a holistic way. But I agree now that physiotherapy is one of the most important parts of the treatment of a patient, any patient for that sake. And hence, your role as physiotherapist is very important. And from the report, what I've gathered from Dr. Varadarajulu sir, we had more than 650 registered candidates, delegates for this, and more than 3,000 viewers. This only indicates the interest and the importance of physiotherapy. Dr. Varadarajulu sir, I would say that you must organize such events in the near future for the benefits of not only all the delegates also, but this should go on to all the patients and for all the recipients in the rural area also. I know that you are doing a lot of work of uh, setting up camps of physiotherapy, and the feedback what we have got from the rural patients is very, very nice, because they were never exposed to physiotherapy as such, and what benefits they're getting from physiotherapy, they have expressed, and that expression of their thoughts is remarkable. So physiotherapy is gaining importance, has gained importance, and will stay as an integral part of the treatment part of any sort of disease. So once again, I take this opportunity. I welcome. I'm coming late at this stage in the valedictory function, but I welcome all the delegates to Krishna Institute of Medical Sciences deemed to be university. I also welcome all the dignitaries who have taken part in this conference over the past 2 days, who have taken part in the panel discussions, who have been part of the conference, who have given suggestions, who have given feedback, and who are responsible for the success of this conference. I also congratulate Dr. Varadarajulu sir and his team member for their effort in making this conference a huge success. And once again, I hope that all the delegates take home happy memories and a good basketful of scientific memories. Thank you so much. Thank you, sir.
Thank you, sir, for your words of wisdom. Marking the closing of Knospe 2020, I would request Dr. Smita Patil to propose a vote of thanks to our dignitaries and delegates.
Thank you, Madam. On this wonderful afternoon of Virtual International Physiotherapy Conference, Knospe 2020, it's my privilege to propose the vote of thanks. As you all know, the organization of such events are generally the result of close cooperation among several institutions and individuals. We all have shown the character of unity and vision to conduct this unique international conference on health professionals' integrity is the hallmark of physical therapy and rehabilitation. We dedicate the conference to the almighty soul of our Honorable late Sri Jayantraoji Bhosle, Founder Chairman Krishna Charitable Trust, Founder Chancellor Krishna Institute of Medical Sciences, deemed to be University Karad. Our university is one of the pioneer institutes dealing with delivery of healthcare and enriched with cultural, social, spiritual well-being of every individual. Led by our visionary Honorable Chairman and Chancellor, Dr. Suraj Bhosle, sir. I thank you, sir, motivating us and directing us in this new path of integrating physiotherapy and other health professionals on one platform. I extend my sincere thanks to Honorable Pro-Chancellor Dr. Praveen Shingare, sir, for your continuous support and motivation. I must mention my deep sense of appreciation to Honorable Vice-Chancellor Mrs. Dr. Neelam Mishra, Madam, for her enormous support and cooperation to organize and conduct this event. Thank you, Madam. I express my sincere thanks to Honorable Chief Advisor Dr. Ved Prakash Mishra, sir, for being a huge source of motivation and inspiration. I will be failing in my duties if I do not underline a very important role played by and a tireless efforts made by our Honorable Registrar, Dr. M.V. Gorpade, sir, Chief Guest for today's valedictory function. I thank you, sir, for being a source of inspiration. I thank all university officials of KIMS-DU, Executive Director Mr. P.D. John, sir, COE Madam Dr. Rajni Gaukar, Research Director Dr. Arun Risbud, Additional Director of Research Dr. D.K. Agarwal, IQAC Director Dr. Satish Patil, and Directors of other core areas like sports and cultural collaborations and extension activities for your continuous support. I thank all the Dean of Constituent Colleges of KIMS-DU Karad, Dr. S.T. Moite, Dean Faculty of Medical Sciences, Dr. Shashikiran, Dean Faculty of Dental Sciences, Dr. Vaishali Moite, Dean Faculty of Nursing Sciences, who supported while constructing theme of conference and provided us the eminent guest speakers from their respective profession for the conference. I express my sincere thanks to all the assistant registrars of KIMS-DU Karad. I thank Dr. Sudeep Kale, President, Maharashtra State OTPT Council, Mumbai, for your valuable guidance, motivation, and support all the time at all the ventures. I thank Dr. Ujjwal Evle, President, Maharashtra State IIP Council, for sparing his valuable time and sharing his words of motivation on the virtual platform for today's function. Thank you, sir. I sincerely thank Dr. Ruchi Varshne, National Head IIP Women's Cell, for giving her valuable time and joining us on the virtual platform to share her words of wisdom. Thank you, Madam. I take this opportunity to thank our international and national speakers for uniting all the professions on a single platform and sharing their valuable knowledge for us. I express my sincere thanks to judges of scientific paper presentation, Dr. Basavraj Mutimat sir from KLE, Dr. Sridhar sir from Kempegoda Institute, and Dr. Suraj Kanse from KIMS-DU for your valuable time. I thank our international coordinators, Dr. Nittal Taude and Dr. Dhaval Bhanushali, for coordinating with us for successful organization of this conference. I extend my sincere thanks to all the scientific paper presenters for your outstanding presentations in the conference. I express my gratitude and sincere thanks to the technical team of PhysioTV Pune for being our broadcasting partner and playing an important role in the success of the conference. Team of Faculty of Physiotherapy led by Dean Dr. G. Varadarajulu sir, has been the real source of this event. His efforts to conduct the event with responsibility and integrity needs to be appreciated and thanked. I thank you, sir, for introducing this new concept, which is the need of the hour. Sincere thanks to Dr. S. Anand, Organizing Secretary of International Conference, for his valuable support. My deep sense of appreciation to all the colleges who have participated in this event. I thank all the dignitaries present on the virtual mode, all the faculty members for gracing this occasion. I extend my hearty thanks to the members of IT Department, KIMS DU, for their support and technical expertise provided by physiotherapy staff, namely Dr. Trupti Yadav, Dr. Smita Patil, and Dr. Khushbu Bhatia, who have provided the stable virtual platform. I realize that I missed a few individuals who have been supporting us. I wish to be forgiven for not specifically expressing our gratitude. As participants, we particularly privileged to be witnessing one of the best novelties shown by our university to club different healthcare professionals under one shelter for exchanging and updating science. I, on behalf of Faculty of Physiotherapy, thank you for this opportunity. Thank you.
Thank you, Dr. Smita. With a due permission from the dignitaries on the dais, this concludes remarkable, knowledge boosting and unique Knospe 2020. This may be the end of this conference, but undoubtedly, this is a new beginning. Thank you. Thank you very much, everyone.
Thank you very much, all of you.
Thank you. Thank you so much.
Thank you.
Thank you.
Thank you and best wishes for next event.
Thank you, sir.
Thank you, sir.